So for a few seconds, let's just, stay with inconsequential moments, and then I will start webinar, because apparently it will take a few seconds to propagate for the
Very
new people
quickly
who are
for you
joining.
guys, when you hit your 12-minute mark or 10-minute mark, I'm going to just unmute myself and give you a little peace sign. So you have 2 minutes to go, and I won't like kick you off the screen until you run into the next person's time. But I just want you to have time for questions if you want them. Okay.
Okay.
Yeah, a lot of interesting subjects discussed today. So, for the Q&A, there's going to be a bunch of stuff. Definitely, you feel free to jump in for Q&A yourselves as well. So, not all questions need to be from the attendees. And Sharon, do you want me to send you the virtual background for Neuromatch if you want to use it instead of the white one?
I don't mind if
Totally,
it's better,
totally
then
optional. Yeah. Okay. So I will start the webinar in 3, 2, and 1. And we are live. Chloe, please take it away. Excuse me, you are muted, Chloe.
Sorry. Don't wait till the end of the talk to write out your questions. Just ask them as you think of them so that we can jump straight into questions after our first talk, which is from Merdad Naderi, who's at the University of Latvia. Merdad, go ahead and take it away.
Okay. Thank you. I start. How does the human brain react when we perceive three-dimensional images? Do different 3D images activate the brain in the same way? These are crucial questions to answer in the field of human-computer interaction. My name is Merdad Naderi, and I will tell you about the changes in cortical activity during relative depth judgment when viewing fundamentally different 3D images. Well, nowadays, the demand for the generation and application of high-quality three-dimensional images is growing to perceive a better quality of 3D sensation. The importance of improvement of 3D visualization is necessary not in the entertainment, computer-aided designs, oil and gas explorations, aerospace, military, medical, and industrial sectors uses 3D images for personal training and also diagnostic purposes. The goal of investment in developing 3D visualization is to allow organization to make smarter, faster, and safer designs, decision, and also plan to improve the efficiency and value of their products and services. Therefore, the objective assessment of the effect of improved techniques producing 3D images on the human brain is important in order to reduce the side effects resulting in visual discomfort. However, many of 3D techniques fail to provide users with a comfortable viewing experience. Electroencephalography has been extensively used to detect the instant activity of the brain when excited by the 3D visual stimulus. The previous studies focused on one type of 3D images and their effect on the brain reaction compared to the two-dimensional images. However, it has not been compared how different 3D images influence the brain activity. Well, what techniques are used to make 3D images? Anaglyph visualization is a stereoscopic effect achieved when using two chromatically opposite colors to separate the left and right eye views from each other. These two opposite colors are embedded in anaglyph images and glasses for the right and left eyes. When looking through the anaglyph glasses, each of two filtered images reach the eyes it's intended for. Then the visual cortex fuses the images into 3D scene. One can produce the different depth effect by changing disparity of the encoded images. The anaglyph images contain conflicting information about depth cues, which can negatively affect users' experience and performance. Multiplane technology allows to generate 3D images in a fundamentally different way. The volumetric multiplanar display includes a multi-surface optical element, including a series of diffuser layers, a high-speed projector, projects a set of images on the respective layers in a time multiplex manner. As the images are projected in the different place within the optical element, human eyes accommodate to volumetric image points just as they do the actual material objects. Therefore, the multiplane 3D images contain matched depth cues. The consistency of depth cues is an important factor in the depth perception. Well, now the method of the experiment. 10 subjects with a normal visual and stereo acuity participated in this study. The visual stimulus was demonstrated on two types of display, stereoscopic 3D images on a flat screen display and volumetric 3D images on a multiplane display. The visual stimulus consisted of 4 circles with a constant angular size. One of the circles had different disparity compared to the others. The task was to detect the closest circles and report about the relative location by pressing one of 4 directional keys on the computer keyboard. Each session included 8 tutorials and cross was presented before each relative depth judgment task for the gaze fixation. The entire experiment was performed in a dark room at a viewing distance of 90 centimeters. To record the brain signals, 21 active electrodes was placed following the international 1020 system. The impedance of electrodes was below 10 kilo ohm, and the average of all electrodes was chosen as reference. The obtained data were analyzed offline to evaluate the event-related potentials and continuous wave of alpha and beta frequencies, employing EEG Lab software version 2019. Okay, well, the correct response rate was high and without any significant differences between 2 tasks. This ensuring that the binocular disparity would be a strong depth cues for depth perception. And the result of the general analysis of event-related potential at 2 time logs as the early process and the late process are presented in the topographical map, as you've seen. Statistical analysis showed no significant differences in early processing ERP activity for 2 visualization techniques. As seen on the topographical map, you see the dorsal area in volumetric screen. Dorsal area is more activated in 3D visualization, it's indicating the processing of position of the visual stimulus. However, no significant differences was seen. Moreover, the analysis of the late processing showed considerable difference in the activity on P4 and O2 electrodes, mostly here. The ERP range 250 to 400 milliseconds reflect cognitive processing during depth perception. Further, its distribution is usually on the occipital and parietal areas. Hence, higher activity of the frontal area that's responsible for thinking and problem solving in the stereoscopic 3D visualization might be due to difficulty in distinguishing depth perception, resulting in activation frontal area to handle the depth judgment. Okay, now notable changes were observed in the event-related desynchronization in the alpha activity. The lower and upper alpha event-related synchronization is shown in the topographical map. As seen, the amount of the synchronization in the lower alpha, the synchronization on the lower alpha is the same in two type of 3D visualization. In the parietal area, as you seen here, the parietal area, amount of the synchronization are same. However, in upper alpha, the significantly higher desynchronization was presented in a volumetric 3D here. Volumetric 3D image viewing that might be associated with higher cognitive performance. And besides event-related potential, we analyzed the alpha and the beta band in raw neural oscillations. When you look at the topographical map of alpha activity, you see no significant difference in alpha activity. However, at the same time, the beta activity differed for two type of visualization. The beta band activity is commonly associated with higher level processing as deep thinking and problem solving. So higher activity of the beta indicating the difficulty in task performance regarding depth judgment in stereoscopic compared to the volumetric 3D visualization. And now, to summarize, I would like to review the following points and achievements. The larger negative deflection from the baseline at the late event-related potentials in the stereoscopic visualization or anaglyph 3D visualization might be related to the greater neural involvement in the processing of stereoscopic 3D images in comparison to the volumetric images. Similar conclusions derived from the analysis of neural oscillation of continuous wave beta frequencies, and desynchronization in upper alpha might be associated with higher cognitive performance in volumetric 3D images perception. Yes. And at the end, this work presented here is a part of a research project with, which aim to investigate the response of human visual system to the volumetric images. The project team from the University of Latvia examined the visual perception and visual function applying psychophysical methods, eye tracking, photorefraction, and electroencephalography. Thank you very much for your attention.
Thank you so much, Mehrdad. That was really interesting. So we're just at the end of your time, but if you have questions for Mehrdad, keep them, and you can even post them in the Q&A, and hopefully at the end of this session we can circle back to previous speakers. But right now we're going to switch gears and have John Tyson Carr from the University of Liverpool present his talk. John's fun fact is that he finished his PhD at 25, so well done, John. Go ahead, take it away.
Okay, can I just override if I share my screen? Yeah, here we go. Okay, so everyone can see that, can't they? Perfect. So yeah, thanks everyone. My name's John Tyson Carr. I'm a postdoc over at the University of Liverpool, and I work in the visual perception lab, and I'm looking at how symmetry is processed in the brain, how the brain perceives symmetry, and how it interprets that symmetry. And I'll just get straight into it. So visual neuroscience is concerned with how our brain processes the visual input that is projected onto our retinas. Now we're constantly perceiving this really complex and 3D moving world, and our brain needs to be carrying out a series of complex processes in order to organize this input in a meaningful way for us to actually work with. And symmetry is one of those really important object properties that gives us that provides us with a lot of information about the structure of the object. It's found to be an important determinant of mate selection. It's good predictor of perceived beauty, preference, aesthetics, and our brains actually it's important to the extent that our brains have actually developed. They do respond in quite a unique way to symmetry within the visual cortices. Now, when it comes to symmetry perception, we have to integrate information from quite distant parts of our visual field. So if I was going to give you an example, if you have a painting on a wall and it's got a really nice axis of symmetry right down the middle of that painting, you don't find evidence for symmetry locally. You find it quite distantly across the image, usually a few centimeters apart. And if we look at some fMRI evidence for that accumulation of that integration of information, we've got a paper by Saccades et al. And Tyler et al. In 2005, and they find very little symmetry-related activity within V1 or V2, so early on in the visual stream. But we start to see symmetry-related activity emerging in V3, and it reaches the strongest in the LOC, the lateral occipital complex. And that makes sense because V1 and V2 have got very small receptor fields. But as we go down that visual stream from V1 to V2 and then V3, V4, V7, we start getting bigger and bigger receptor fields. And that's why we start to get that integration around about V3, and especially in the LOC. And what we also know is that these extra striate regions, so V3 and onwards, they generate what we can measure with EEG, something we refer to as the sustained posterior negativity, the SPN. And all that is essentially, it's just a increased negative activity over posterior electrodes when people see symmetrical stimuli. So this is an example from Norcia et al. In 2002. The blue line indicates what happens over posterior electrodes, that negative potential when people see symmetrical stimuli in comparison to random stimuli. And it's important to know that symmetry doesn't have to be this all or nothing concept. So if we look at this Palumbo et al. 2015 paper, if you take 100% symmetrical stimulus like this here, you can actually replace components of that image with random noise and decrease the proportion of symmetry within the image. So here you've got an image with 20% regularity, and it increases in increments of 20%. And they found that actually this SPN response actually increased in magnitude as the proportion of symmetry in the image scaled up as well. And see here, this bilateral negativity over the back of the head, which is characterized as the SPN response, increases in magnitude as the proportion of symmetry increases. And you can see it nicely in these difference waves as well. A really nice clean increase in that SPN response as the proportion of symmetry increases. This was replicated in another paper, Making et al. 2020. Again, exact same paradigm. This is one of their experiments, and it's the same protocol as the Palumbo et al. Scaling of that SPN response, increasing bilateral negativity as the proportion of symmetry increases. The exact same results. Now, this data in Making et al. 2020 is the data that I actually reanalyzed. it's over the past couple of months, in the absence of being able to collect new data, we analysed some data from Making et al. 2020. Now, they didn't just do that one task from Palumbo et al. That was just the first experiment within this series of experiments. And these 5 experiments all had 24 subjects, so 130 subjects across these 5 experiments. And the first task in the regularity discrimination task, they saw a fixation cross, they saw the pattern, and then they made a binary decision between some regularity or no regularity. But in the other 4 tasks, they had to change what they were required to do. So we had the color discrimination task, and rather than the choice between regularity and no regularity, there was the choice between light or dark dots. In the other task, sound color congruence, they had to determine the congruence between the color of the pattern and the simultaneously presented sound in terms of pitch. They had to determine the congruence between the color of the pattern and the direction of a simultaneously presented arrow, like you can see down here, or just determine the distribution of the dots in the image. So what we essentially have is one experiment where people are required to attend regularity, attention towards symmetry, and another 4 tasks where attention is drawn to some other irrelevant stimulus dimension. And in terms of EEG pre-processing, it was a very standard pipeline. And just to reiterate here, you can see this is the first task that I showed you before. You get that scaling of the SPM response as the proportion of symmetry increases. We've got the 4 other tasks as well. You can see a very similar pattern where we get the same increase of that SPM response as symmetry increases. So yeah, you get the same linear response despite attention being drawn to some other irrelevant stimulus dimension. But what we also note is that the regularity task, it looks like we get a much stronger response overall, but we also get this second little wave here that isn't present in any of the conditions, and it's only actually present for the 100% and 80% reflection conditions. So that it would be tempting to just think that was part of the SPM response, but it might be something else. It might be a separate cortical activation. Here, it's a bit easier to see. You get that increase in the regularity task, increase in the color distribution, and so on. But that second peak at around about 600 milliseconds, you can see it doesn't really fit in with the SPM. It doesn't have that bilateral negativity, indicating that it is a separate response and a separate EEG component, characterized by a really strong positivity over the vertex of the scalp at around about 600 milliseconds. So what did we do in terms of reanalysis? We did source localization. Now, source localization just allows us to estimate the origins of the cortical, the patterns we see across the scalp. And what we did was we used source dipole fitting, and we built a series of source dipole models that aim to maximally explain the data that we observed for each task individually. So for one model for each task, and we fitted the models on the difference wave now between random and symmetry. So that is just a waveform that is unique to symmetry-related activity that we observe on the scalp. And we fitted the dipoles to minimize residual variance, or in other words, just to maximally explain the observed data. So we'd fit dipoles and try and explain the data as best as we can. And what we know from previous research is that bilateral negativity from the SPN is generated by a pair of the 2 sources in the extrastriate region, so that visual stream V3 and so on, and the LOC predominantly. So what happens if we fit a model with just those 2 dipoles to see how well they can explain the data? What we actually found was that just using those 2 extrastriate, those 2 dipoles within the visual cortex, that was enough to explain the vast proportion of the data, if not as much as you could of the data in the final 4 tasks. But what we see here, this is the residual variance, or at least a summary of the residual variance. These 4 lines here represent the residual variance for the final 4 tasks where attention was away from irregularity. And you can see that there's not really any discernible period of unexplained variance. It seems to be that those 2 dipoles can summarize the data really well. But what you can see from this line is the regularity task residual variance. There seems to be a extracortical activation that is not allowing the data to be explained by just those activations in the visual cortex. There seems to be at least one extra cortical activation, one extra component active during regularity discrimination. And if we look at the individual conditions, it actually seems to be specific to the 80% and the 100% regularity conditions, similar to what we saw on the scalp maps on a few slides ago. So yeah, this just suggests that there's one extra cortical source. So what happens when we fit the full models? The regularity task required that we fit a third source within the posterior cingulate to explain the rest of the data. And it bumped up the residual explained variance from about 70 up to about 92%, whereas the rest of the data models the rest of the data sets were sufficiently explained by just extra striate sources. So there seems to be a third source active during the regularity task that was required to be fitted. And here's just a summary of the source waveforms, and this is source waveforms just summarize the activity over time for each source, for each dipole. The left and right, or ECD1 and ECD2 respectively, usually show that same linear scaling with that we saw with the raw EEG data, that scaling with proportion of symmetry. But you can see on the third dipole here, this is the posterior cingulate one. It's only active between 400 and 800 milliseconds, peaking at 600 milliseconds for only the 100% and 80% conditions, not active for the other three conditions. And this mimics what we saw on the scalp maps, and it's what we expected from the residual variance, that there was an extra source active during those two conditions. And we fitted it on the Palumbo et al. 2015 data to see if this was just a fluke, and we observed the exact same results. You got that 80 and 100% conditions requiring a third dipole within the posterior cingulate to explain the data. So it wasn't just a fluke in one data set, it was observed across two completely different data sets taking years apart. So what can we take away from all this? Now, in the original manuscripts, both Palumbo and Macon et al., they found that the SPN, that sustained posterior negativity, that symmetry response, scaled with the proportion of symmetry in the image. In Macon et al., they extended this to task whereby attention to symmetry was not actually required, so that SPN seems to be generated automatically, symmetry seems to be perceived automatically. And when we reanalyzed the data, we found that there was actually an extra part of the brain that was active, an extra cortical source that was active when people viewed really strong symmetry, but only when attention was focused on discriminating symmetry. And if we wanted to push it one step further and we localized it, we found that it was coming from the posterior cingulate. And what can we say about this, just to have the takeaway message? So the extrastriate regions seem to communicate with regions outside of the visual cortex when discriminating regularity, but only when discerning when looking at really strong regularity. And this just kind of helps to discern both the perceptual and the cognitive aspects of symmetry discrimination. And that is everything. Thanks very much for listening, everyone. I think that was 12 minutes, so if we got time for questions.
Awesome. Thank you so much, John. So yeah, please feel free to enter some questions. I will abuse my position as MC and take the first spot. I was wondering if you, your work or anyone else's that you've sort of touched upon has looked into relating this to like why symmetry is so pleasing. Yeah,
there's a lot of research on, like, people just love symmetry. I think it's something to do with the fact that evolutionary, people often see symmetry in the face, symmetry in the body as being attractive. I think it just implies order. Mm-hmm. I think evolutionary, there's quite a bit of research on the specificity of symmetry, and the reason that it's so important is evolutionary. What was it? I think it was something like, it's a good indication of whether something is living or not living, and that might be why we find it so interesting.
Okay, yeah, I hadn't heard that one. That's interesting.
Yeah.
And then I have one last question. I guess, have you, I do sort of visual search stuff, and I'm wondering, is this ever been used sort of as a tool? Your point about how you have to take information from a really wide span in order to judge symmetry, has this been used to sort of look at, how far into the periphery we're pulling information from, or has that been looked at?
Yeah, off the top of my head, I've only been in this position, so I reckon decision making for this from a visual literature is a bit shaky, but I do vaguely remember that if you set someone at a certain distance and separate images, certain patterns on the screen, certain visual degrees apart, that information starts to not get integrated as well. Yeah, so I don't remember off the top of my head, but I think it has that yeah, as it like goes further apart, then the information isn't integrated as well. Yeah.
Right. Awesome. Well, thank you so much, John. We are going to switch gears now and hear from Sharon Daniel from Monash University. He is a PhD student, and take it away, Sharon.
Hi, everybody. So my name is Sharon, and I'll be talking to you about my research topic, that is consciousness and attention in the tactile domain. Many times something has slipped out of our pocket without us noticing it. But sometimes we do notice that. Can it be done without attention? Can we notice that something had slipped out of our pocket, like keys or something, without us paying attention to it, top-down attention? In the visual modality, there is an ongoing debate about the necessity of attention to consciousness, having a conscious perception that something happened. I'm not going to go into details with this table, but you can see from this table the vast knowledge that has been accumulated in the visual modality. So in the visual modality, it was shown that for some stimuli, it is possible to have a conscious percept in the near absence of attention, while, for instance, animal and gender detection can be done in the near absence of attention, while other stimuli cannot be done without attention. One of the ways to show that stimuli can be perceived in the near absence of attention is by using the dual task. In the dual task, participants are requested to do a central demanding task while doing concurrently a periphery task. The rationale behind this is if we can if all our attentional resources are devoted to the central task and we can still perform the primary task, as example here, face gender discrimination, it means that for the secondary task, it can be done in the near absence of attention. Also in vision, another interesting phenomena has been shown, that is the hemifield advantage. Alvarez in 2005 was using those stimuli to show this. Participants were requested to track those axes. Those axes were rotating, and at the end of the trial, they were asked if the bar was in the same position as in the initial state. It is quite a demanding task that requires participants to pay attention throughout all the rotation time. Alvarez had two different conditions. In the unilateral condition, the stimuli were presented only to one hemifield, while in the bilateral condition, the stimuli were presented to both hemifields. What Alvarez has found is that when stimuli are presented to two hemifields, performance is better than it was presented to only one hemifield. He also found that this was valid only for 4 targets. But what is the significance of this? The significance of this is quite immense, and it is actually written in Alvarez's paper. It actually means that each hemifield has independent attentional resources. So my research question is to investigate whether visual modality arguments can be applied to other modalities such as hearing and touch. In other words, can we transfer the amount of knowledge that has been accumulated in the visual modality to other modalities? But why have I chosen tactile? Tactile is considered to have simple brain hierarchy compared to vision. Also, if we would like to take it one step further, it enables us to investigate other sets of consciousness, such as sleeps, anesthesia, and coma. It's a little bit hard to give a visual stimuli to a person that is sleeping, but we can still do. We can give a person that is in coma or asleep. We can still give him a tactile stimulation. So with the tactile point of view, I hope to shed light on the debate of the necessity of attention to consciousness. I would also like to see, do all modalities share the same underlying principles of attention and consciousness? Also, tactile has a clinical application, but I will not talk about this study in this talk because of time limitation. So what we can see here, you can see here my tactile task paradigm. Those black things here with the red circle around them are the tactiles. Tactiles, they are those mechanical things that actually vibrates and gives tactile sensation to the skin. I can control their amplitude and the frequency. There were 6 tactiles, and they were divided into into 3 finger pairs as follow. The index and middle finger were always present, and they were considered to be the primary task. Participants were requested to be more accurate on the index and middle finger. The secondary finger was the ring and little finger, where the ring and little finger could have been from out of the same hand as the index and middle, or it could be on the other hand, as we can see on the bottom. And this is actually quoting Alvarez's condition of the unilateral and the bilateral. What we see here is on the x-axis, we can see the performance of correctness of the primary task. On the y-axis, we can see the performance of correctness for the secondary task. Those triangles represent the performance on the single task. At the beginning, we were doing single task. That is, participants were requested to attend only to 1 finger pair and ignore all other finger pairs. We use this in order, and we use our quest staircase procedure in order to find their level of performance matching 70%. Then we use those thresholds into the dual task. So if performance in the dual task is the same, and we were aiming to 70%, so if the performance in the dual task is the same as the single task, we would expect that the dual task result would be somewhere around here. That is 0.7 and 0.7. Here are the real results. What we can see here, we can see a significant reduction from the 0.7 and 0.7. From this, we can conclude that this task requires attention. Also, we can see from here that no differences were found between same hand and different hands. In other words, I was unable to find the hemispheric advantage in this tactile paradigm. However, it's important to note that participant, since the performance is under the x equal y line, we can see from this that participants were doing better for the primary task as they were requested. So they were able to perform the task. So in experiment 1, it seems that frequency discrimination requires attention. Also, in contrast to vision, I was unable to find the hemispheric advantage. But why is that? Well, we suspect that it is because of interference. We speculate that always having 4 tactiles on one hand creates an interference. This interference induces masking that it disables us from seeing the hemispheric advantage. So for this, I have planned an experiment 2, which is a registered report one. And in this experiment, there are 4 tactiles at all times. Those 4 tactiles can be out of the one hand or on different hands. It might be that our inability to find the interhemispheric advantage can be because stimulus dependent. We have seen from the visual modality that the ability to perform a task in the absence of attention is stimulus dependent. It can be done for some stimuli, but it cannot be done for other. Maybe frequency discrimination requires attention, perhaps also in vision. Thank you very much.
Thank you so much. That was awesome. So please, audience, feel free to fill the Q&A. I will give priority to Sharon's talk, but if you also have questions for the previous speakers, pile those in, and hopefully we can circle back to them as well. So Sharon, what is your sort of next steps with this work?
So first of all, when the coronavirus will finish, I hope to be able to do this experiment and to see maybe with this simplified version, I'd be able to find the interhemispheric advantage. Also, it might be that with this simplified version, it can be done in the near absence of attention. So it's at the moment, I'm waiting for the COVID to finish.
And so I know there's probably much better experimental control when you have these tactile stimulations. Have you looked into having people explore objects themselves, like so that they're kind of in charge of the tactile sensation creation instead of sort of passively receiving it?
That is a wonderful question, and I haven't done so. But there is another article that has done so. They gave people exactly what you said. They had to, they were given object, and then they had to say if the objects are the same or not. And what this study show that if you give an object to the right hand, they were doing, and then you give it to the left hand, then people are good as it was sequential and on the right hand, for instance. However, when you give them objects on both hands, you did not see any advantage, which is also surprising for me as well.
Yeah, that's interesting. It's interesting that it transfers so well from one hand to the other. That would be the same as holding it twice in the one.
Yes, but this is also why the reason for the interference that I suspect that might happen. And also, like with your question, in the visual modality, there's this kind of differentiation between complex and simple stimuli. And complex stimuli such as gender face discrimination can be done in the near absence of attention, while what is considered to be simple, such as having now the orientation of green and red disc, cannot be done in the absence of attention. So hopefully I can find the right stimuli or the right paradigm to find this also in the tactile modality.
Right. Yeah, my heart goes out to you. I feel that tactile work is particularly victimized by COVID. As the rest of us move online, I'm sorry.
Yeah, actually, I'm at the moment, so it's not part of this talk, but at the moment, this is what I'm checking. I'm doing an online experiment, and I'm giving people frequency discrimination tasks. And on one hemisphere and on two, and on both hemispheres, and to see maybe it's the task itself, like as I wrote here, to see maybe the task itself is the problem. Maybe frequency discrimination is the task that requires attention in all modalities or not. But I still don't have any data on this that I can present.
Very cool. We have a question from John. Is there any influence in hand dominance?
Surprisingly not. So there is a difference between tactile sensation and the ability to perform a task with a certain end. So in terms of tactile sensation, I was unable to find any kind of differences between hands, and that's actually in line with the literature. Actually, I was actually swapping hands. What you can see here is one configuration where 4 tactors on the left hand, and participant came the next day, and then I put the 4 tactors on the right hand and 2 tactors on the left hand. Didn't find any differences. So in terms of sensation, there are no differences. But in terms of our ability to perform a task, obviously we all feel different with a dominant hand.
Right, yeah. All right, well, we have reached the end of our session. We have about 5 minutes before we're transported involuntarily out of this room. So if there are more questions, feel free. But otherwise, you guys were awesome, and I really appreciate you taking the time to chat to us today.
Thank you.
Thank you very much.
Yep. Thanks everybody for joining in. I will end the webinar in 5 seconds.
Thank you very much.
Thank you, everyone.
Screen now.
Yeah.
Okay, can you see my presentation?
Yes. Very good.
Okay, and you can see if I.
Yeah.
You can see
Let's give a few minutes, a few seconds for our attendees' connections.
Yes. Okay.
We see people are coming in.
Okay.
Okay. Okay, I think I'm gonna start the introduction. Welcome everyone to this session. We're supposed to have 3 speakers in this session, but it turned out our first speaker did not show up yet. So we're gonna start our second talk. In this session, our speakers are going to tell us a lot of new stuff about their work as a bidirectional TDCS and the assessment of a motor and a scale process. I'm sure we're going to learn a lot from them, and I'm very much looking forward to their talks. So please do remember, click the Q&A to ask questions you want, and you also can upvote the questions. Okay, our speaker, next speaker is Jenny Lee. Jenny is a PhD student from UCL Queen Square and Miss Queen Square Institute of Neurology in London, working with Professor Seven Bestman and Professor Nick Watt. She's funded by Brain Research UK. Jenny is interested in how non-invasive brain stimulation techniques could be used as part of stroke rehabilitation. Please do find more information about her in the chat, and you also can find her on Twitter. I'll post it in the chat. Jenny, please take the stage.
Okay, thanks very much for that kind introduction, Jiejing. As you said, I'm a PhD student in the ARM lab at UCL. And this talk is going to be about achieving opposite direction of TDCS current flow in neighboring cortical sites, and why we might want to do this. So transcranial direct current stimulation, or TDCS, is a well-established non-invasive brain stimulation technique, and it can be used to alter cortical excitability. It involves passing a weak electrical current between electrodes placed on the scalp through the brain, as you can see on the left-hand side of the slide. And it has promise as a therapeutic tool in lots of clinical settings, including stroke rehab, because we think that altered cortical excitability could underpin the plasticity mechanisms that are important for relearning. So currently TDCS is more commonly seen in experimental settings in the clinic, unfortunately, because although it's very well tolerated, the excitability outcomes are often highly variable. In other words, it works for some people and not for others. So there's now a large body of literature out which is exploring how the variability in TDCS studies could be reduced. And often the focus of those papers is about the intensity and focality of the injected current. So ensuring that the same amount and the same amount of E field and the same area, the same cortical area is stimulated across all participants. However, direction is also important and it's often overlooked. So as you can see in the right-hand side of this slide, broadly speaking, inward current flow, which is traveling along a neuron towards the soma, is associated with excitation, whereas current flowing in the opposite direction is associated with maybe inhibition. So the point of this slide is to show that the direction at which TDCS current hits the area that you're interested in the brain is important, and we don't think about it very much at the moment with our current study design. So conventional TDCS, as you can see on the left-hand slide again, is normally applied with a posterior anode and an anterior cathode, so that current flows anteriorly straight forwards towards the front of the head. But due to the natural cortical folding structure of the cortex, the orientation of grey matter pyramidal neurons will alternate. So as you can imagine in this diagram on the right, if current is flowing forwards like this, and you have one side of a sulcus that's orientated like this, and then it moves around here, then you might get pyramidal neurons which are stimulated with outward current, which could be inhibitory. And then on the opposite bank of that sulcus, you could get inward current with the orientation of the neurons, which could be excitatory. So current flow in the same direction could actually have opposite polarizing effects for neighboring cortical sites, as you can see here. So we were interested in modeling a TDCS electrode montage, which might push current in opposite directions with respect to the whole head, as you can see here, which in fact is the same direction with respect to the neurons in these structures. So in this case, the target regions that I'm looking at are M1 and S1. This is because we're interested in motor rehabilitation after stroke, and most of our studies are to do with the primary motor and primary sensory cortices. These two target areas tend to be, well, they are found on either side of the central sulcus. So with M1 here anteriorly and S1 posteriorly here. And we want to try and push current forwards through M1 and backwards through S1 so that we might achieve the same polarization of the neurons in these two areas. And the main reason we want to do that is because the motor and sensory activity is so intrinsically linked that we think it's important to stimulate them in the same way. So to do this, we used ROSE current flow modeling software and prescribed anterior current flow through M1 and posterior current flow through S1. We then asked ROSE to generate an individualized montage with up to 72 electrodes. And we used FreeSurfer to generate a gyri-precise mesh of the grey matter so that we could look at what would be perfect inward current flow in each of these cortical areas and then compare it to the actual direction of electric field. And then we compared this suggested montage that ROSE gave with a conventional montage that you can see here. Very briefly, what we found is that we can achieve posterior current flow in S1 and anterior current flow in M1 at the same time. But this came at the cost of intensity. So the blue areas here show that you get low intensity in M1 and S1. For example, about 0.02 volts per meter at the cortex, where normally with about 1 milliamp of standard current, you would expect an average of 0.185. And other studies that have just come out by Caulfield et al. Have shown that actually you might want 0.1 or 1 volt per meter in a target region to elicit neuronal spiking. So we didn't get enough current there, even though we achieved the direction that we wanted. So future directions are to generate a individualized custom montage with fewer electrodes that might still push current in the directions that we hope it to go in M1 and S1, but achieve a higher intensity, which is more comparable to other studies with injected current. And a physiological study to test the effects of this montage on excitability is ongoing, depending on COVID restrictions. So that's a lot of information. I'm happy to take questions. And thanks very much for having me.
Thanks very much, Jenny. That's a very beautiful talk. I'm really impressed by the fantastic and rigorous result and the beautiful figures. Anyone have questions? Let me check Q&A. We currently no question in Q&A. Can I ask question? What's the next step for probably apply what you are doing to the rehabilitation?
Yeah, so with rehabilitation, we're running another study which is looking at whether TDCS, this brain stimulation technique, would be best applied immediately after somebody has a stroke in the next few weeks after that happens, or if it would be best applied later on. So we think that something like TDCS that could boost excitability might be useful because it can enhance plasticity mechanisms. And we're just trying to work out if that would be better to do early after a stroke when plasticity is already high, or if it would be better to apply later after stroke when plasticity levels or excitability levels have reduced back to kind of a normal state. So it's not ready to go into clinical settings yet, and we're still doing exploratory studies, observational studies with the clinical population. But we hope that in the end it might boost excitability to support the existing training that people get with physiotherapy and things like that.
Thanks very much. Very cool. We have a question from Alessio asking the montage is specific to the user. You can also click the chat or the Q&A to see the questions.
Oh, okay, I see. Thank you. With the protocol, so the question is, would the protocol differ as well with directly after or after long stroke with regards to frequency?
Okay, we can answer this first, and we have a question in the chat. We can answer later.
Oh, I'm sorry. Which
no
what
worries.
was you need to answer?
As the montage is specific to the user.
Yes, so the montages are specific to the user. Apologies for that confusion. So with ROAST, what you can do is you input a scan. So the scans we used here, I forgot to say, were from the Human Connectome project. So this is an individual person's brain. It's not just a standard MRI scan. It's a 3D construction that's made by the ROAST software created by Andy Huang and the Paralab, which gives you a 3D model of the brain, places electrodes over it to achieve your desired direction and intensity of current, and then tells you which electrodes it suggests and what intensity of current to inject into those scalp electrodes. So it's a great bit of software. And yes, it does individualize the TDCS protocol for each person.
Okay, thanks very much. We have a question in the Q&A from Eva. I think you already saw that.
Yeah, I'm sorry about that. So before, so would the protocol differ as well after stroke with regards to frequency? So is this question, correct me if I'm wrong, if the protocol would differ depending on how long after stroke a person is? So the answer to that question is we don't know yet. So hopefully in future we'll be able to model with a bit more detail, taking into account lesions that appear after stroke. So for example, immediately after a stroke, a damaged area of the brain might be filled with blood or cerebrospinal fluid or other tissue, which conducts the current differently to cortical spinal fluid does, which is kind of what you see when you see that lesion about 6 months afterwards. So at the moment, we would keep the protocol the same, regardless of the time post-stroke, as long as it isn't too soon afterwards when the original trauma happened. But maybe in future, we will adapt our montages to take lesions into account in a more precise way, but we're not sure yet.
Cool, thanks very much. And Eva replied, yes, that's what I meant, thanks so much.
Thanks for your question.
Yeah, just tell you if anyone want to ask a question on stage, just let me know and open your camera. Okay, cool. It seems no more questions coming out. I think almost time to move on our next talk. Thanks very much again, Jenny, for your wonderful talk. Thanks very much for the questions. So next speaker is Stuti Chakraborty. Stuti is currently working at Christian Medical College, Valera, and she's a country representative for healthcare information for all. Her work is part of SDG 3. She's also engaged in a lot of other teams, associations. In addition, she runs her own nonprofit initiative. It's called Stimulus. They aim to raise awareness about the brain senses and tackle ableism. That's very impressive. And you can also get in touch with Stuti on LinkedIn. Please do find more information on her in the chat. Thanks very much. Please go ahead, Stuti.
Thank you for the introduction. Hello, everyone. Good evening, good morning, depending on whichever part of the world you're in. Am I audible to everyone?
Yes, very good.
Okay, great. Before I begin, I do not have a presentation, but I have a poster and I will be presenting my screen. So I would just like to explain the background of the work that I do. I'm an occupational therapist by profession, and I work in a rehabilitation setup. And I'm mainly involved in the rehabilitation and treatment and clinical management of patients with stroke and different types of neurological disorders. Mainly, the most common ones we see are stroke or cerebral vascular accident, MCA strokes being the most common ones. And apart from that, we also see a lot of clients with road traffic accidents that have deficits in their visual, spatial, perceptual skills, their different higher cognitive and executive functioning abilities, as well as their motor function. So the study that I have done is to develop an assessment tool to find out the deficit in their motor and their process skills. So as an individual who can function normally, when all parts of the brain are intact, there are skills for doing any self-care or daily activity of living, which is anything that includes our starting from our morning routine to what we do at night, and our occupation, or as our role, whether it is us working in a lab, whether it is doing research, whether it is doing teaching at a university, whether it's working at in a university or in a hospital. All these come under our roles and our occupations that we need to perform in our day-to-day lives. So when a person has an injury in the brain, these get affected. And the two ways that we can classify how an injury or the extent of the injury can impact a person's day-to-day routines can be in the form of the motor functioning and the process functioning. So if I take a very simple task like brushing our teeth, it seems like a very normal procedural routine that occurs when we do not have an injury to the brain. But when there is an injury to the brain, especially in terms of an injury to the frontal lobe or an injury to the parietal lobe, where the visual, spatial, or the motor function might be affected, there are deficits in the motor skills and process skills. So if we take the task of brushing, it actually, we do not really think about it, but it actually requires a lot of processing that goes behind in terms of paying attention to where the brush is, paying attention to where the toothpaste is, applying the toothpaste on the brush, taking it to the mouth, and then moving it around the mouth. So all this requires a lot of sequencing. It requires a lot of attention. It requires a lot of understanding about the different processes that are going on inside one's mind. And when it comes to the motor, it requires you to reach for the brush. It requires you to grab the brush. It requires you to manipulate the toothpaste and open the toothpaste. So all these things are very, very important. So I'm going to go right into my study, and I'm going to share my screen. So the name of my study is to develop and design and validate the functional motor and process skill scale, which is called as the FUMS, among persons with acquired brain injury. So acquired brain injury can involve anything, whether that is stroke or whether that is a head injury. So as you can see, the definition of acquired brain injury can be anything which has a rapid onset of damage to the brain because of multiple causes, including but not limited to trauma or post-surgical drainage, CVA, anoxia, toxic metabolic diseases, or subarachnoid hemorrhage, or even different types of infections like meningitis or encephalitis. So the aim and objectives of my study, as I mentioned, was to design and validate a scale to assess the extent of damage in the process and the motor skills of a person with acquired brain injury. Why is there a need to develop this assessment scale? So as an occupational therapist, there are different rehabilitation professionals involved in the treatment of people with injuries to the brain, like physical therapists, occupational therapists, speech pathologists. There is a physical medicine and rehabilitation physician. There's a rehabilitation nurse. So there are a lot of individual rehabilitation professionals that are involved. But specific to the role of an occupational therapist, we really focus on the functionality or the functioning of the patient and their ability to carry out their day-to-day activities and occupations, as I mentioned at the beginning of my introduction. So it was very important to develop an assessment tool that is currently not available in literature specifically for the Indian context, because in a country like India, which is very large and diverse, and the country that I am from, it is very difficult to adopt a westernized tool, which is from a Western country or from an Eastern country, which is culturally very different from the practices that are present in India in terms of the day-to-day occupations of people. And by occupation, I do not mean a job. By occupation, I mean the day-to-day activities that a person might have to do, whether it's brushing their teeth or whether it is teaching at the university or doing lab-related work. So it was very, very important to develop such a tool to assess it specifically in the Indian setting and context. So that is why we thought of developing a tool which will assess the extent of damage to the motor and the process skill for performing each task. So just to give an introduction of the tool, it consists of different activities, starting from some examples of which are brushing, eating your own food, that includes opening a packet of biscuit and taking it to the mouth. And then also includes wearing a shirt or a t-shirt, also includes wearing a pant or a lower half dress, and it's very diverse in different parts of India because it's a very culturally diverse country. Then it also includes sending an email. It also includes gardening. It also includes changing the bed sheets for a particular person's bed. It includes cutting and chopping vegetables. So all these activities which occur in our daily lives might seem very, very generalized to us, but when there is an injury to a person, like I mentioned, the motor and the process skills for performing each of these activities get affected. So the first objective of my study was to design the functional motor and process skill scale, and the second one was to find the test-retest and the inter-rater reliability, and the third one was to find the concurrent validity with the existing scales. So the study involved two phases. The first phase was to develop and examine and choose the appropriate tasks, which are, like I mentioned, completely which are in concurrence with the entire population of India, because India is very diverse. So we developed these particular set of tasks from the ICF core sets for acquired brain injury, which is the International Classification of Functioning, Disability, and Health. So we developed it on the basis of the ICF core sets. Once the tasks were chosen, it comprised of instrumental activities of daily living and basic activities of daily living. Instrumental activities of daily living are basically associated with the individual's environment, and basic activities of daily living are associated with one's own self. That is the activities that they have to do for taking care of their own self. So it consisted of first making the tool, the second step, and then it was modified and it was sent to a panel of experts for getting feedback. And then it was given for validation, that is item validation for expert opinion. And the second phase was to standardize the tool, wherein I assessed the concurrent validity and the inter-rater and test-retest reliability. So in terms of the concurrent validity, we compared it to two currently existing tools, which are there in literature and which are widely used in rehabilitation, specifically in India. One is the Montreal Cognitive Assessment, which is a short cognitive assessment which consists of a total of 30 points. And it requires one to assess different deficits in cognition. That includes, it has different domains like attention, memory, then there's a little bit of visual spatial as well, and then language component. So it's a very comprehensive assessment which can be performed rapidly, and it is a lot more shorter than the ACE, which is the Edinburgh's cognitive examination. So I compared the process component, which had to do with the cognition aspect of doing a task, with the MoCA, and I compared the motor component, which has to do with the physical or the motor functionality of performing a particular task, with something called a COVS. The COVS is also, again, widely used in rehabilitation by physical therapists. And coming to the results, so there were 25 patients recruited. Before COVID started, the study was done, and samples have been completed up till 25. There are 49 samples, so I have around 26 more samples to complete. So the analysis was done at 25 samples. You can see the gender representation and the diagnosis representation. So coming to the results, it was found that the Cronbach's alpha and interclass correlation was very high for rater 1 and rater 2, that is for inter-rater reliability, for motor, as well as for both process skills. And for retest reliability, that is, it was done in a period of within a period of 2 days to maximum of 4 days or 5 days, but not a week, because in rehabilitation we set goals according to weekly basis. So there is a very high chance that the patient might proceed to a new level or a higher level within a week. So we had to restrict to below a week. And this was done for the motor and the process. And you can see that again, there was a high Cronbach alpha and interclass correlation. Then the correlation between MoCA and process score is found to be 0.83, which is a good correlation. And the correlation between COVS and a motor score was found to be 0.78, which is a moderate correlation. So based on this, one thing that I forgot to mention is that this was an extremely, so I'm going to stop sharing my screen now. So one thing I would like to mention was that this was a very function-based tool, because the MoCA and the COVS are very, their assessment or tools which are extremely paper and pen-based or tabletop assessment-based. And so the reason why this tool was developed was to get an idea about what the patient's current or the client's current level of functioning is. So in rehabilitation, it's very important that we make the client perform the activity or perform the task at hand and then assess it, rather than just ask them a couple of questions like what is today's date or day, or what is 100 minus 93, and to find out their deficits in attention and orientation. So this is a more comprehensive and function-based tool, as I mentioned, and we finished 25 patients from different parts of India, and we found quite high correlation. The low correlation with the COVS, or I would not say low, but the moderate correlation with the COVS was because the motor component is extremely functional. However, for the COVS, it just requires the patient, some of the standard things that are performed is to ask the patient to roll to either sides of the patient. It also requires the patient to stand up, get up from the bed, and just general tasks. However, for the motor component for my tool, I asked the patient to categorically perform tasks and then score them on the basis of that. The rater 1 was done by me, and the rater 2 scoring was done by the patient's individual therapist. And the feedback that we got from each therapist was it was quite an easy to score scale, because it was on the basis of 0, 1, 2, which is 0, where 0 stood for not performing at all. The skill is not performed at all. 1 stood for partial performance, and 2 stood for complete performance. So it was quite easy to score as compared to other tools where there's a very comprehensive and extensive scoring list which is available. And apart from that, therapists also reported that it was easy to understand, and based on the difficulties that the patients found out, they were able to plan their treatment according to that. So the plan is now to complete the sample size and move ahead to a phase of standardization, where it can be standardized on around at least 200 more clients, and then it can be readily available for usage for rehabilitation professionals in India, as well as different other parts of the world as well. Okay, so I think I'm going to stop there. I think you're muted, Kian.
Okay, thanks very much, Susie, for your wonderful talk. It's very impressive, and I think it's very, very useful. And it's also very challenging too. So let me see if we have questions in the chat. Okay, so far we don't have questions coming out yet. Can I ask a question? Maybe I just missed a part. So as India is very diverse culture country, so how to validate the assessment across the country? Can you explain more about that?
That's a good question. So the reason why we chose a set of tasks, like I mentioned, we had a look at the ICF core set for acquired brain injury, and we picked the most relevant ones. And we didn't, and to make sure that it was not biased, we also sent it to a panel of experts, which consisted of an occupational therapist, a physical therapist, a physician that deals with rehabilitation, and also a psychologist that gave their feedback and review. And they had representation from different parts of India and also combined experience in rehabilitation. And so after receiving the feedback from them, we chose a set of tasks which are most appropriate and most relevant and applicable to all Indians. So I'm just going to turn off my camera for a while, and I'm going to take up the scale and show it, if that's all right.
Mm-hmm. Go ahead.
So I'm going to share my screen again.
Mm-hmm. Mm-hmm.
So as you can see,
Mm-hmm.
this is neurobehavioral. So this is a task which consists of brushing, combing, wearing a t-shirt or a top, wearing a pant, tying a sari. So sari is actually a traditional attire that many women in India wear. So again, it's very context specific to India. Washing face, opening and eating a packet of biscuit, taking the medicine, folding a shirt, making a list and buying them from the shop or the store, making a phone call, preparing a tea or a coffee, preparing an omelette, preparing a veg or non-veg curry. Yeah, so you can see the rest of them. So these are to do with the daily activities as well as the activities that many Indian women do or many Indian men might do. So just to give an example of what the performance skills entail, it is attention, searching, this is for brushing, so attending to the task, searching for the toothpaste, identifying their toothpaste, gathering their items, using them, organizing them, initiating them. On the other hand, you can see that for motor skill, it consists of positioning with or without an adaptive aid, which can be a wheelchair or a walker, or it can even be a stick or a crutch that they use to walk. Aligning themselves, reaching for the required items, grasping, stabilizing, manipulating, coordinating. So like this, there are a different set of skills for each specific task, which have been altered according to the Indian population, keeping in mind the tasks which are applicable to most of the diverse population, because these things are performed by everybody in India or anywhere else in the world as well. Depending on, regardless of their occupation or their job or who they are or what they do. So yeah, that's all I wanted to share.
Thanks very much. We have a question from Jenny. Jenny said, thanks very much for the great talk. The question one is, how long does the FUMPIs take to complete? And the second question is it easy to train others to deliver FUMPIs?
Yes, so it takes right now, because I am doing the validation, it takes around an hour, 45 minutes to an hour, which includes taking consent from the patient, explaining the entire process to them. So because I'm doing the validation, I have to make them do 3 tasks. So it might depend on the tasks that they choose or the tasks that are most difficult for them to do, in terms of identifying the problems that they have. So it takes me around half an hour to make them. Again, it depends on the patient's level of functioning. If it's a client in RLA stage 4 to 5 or 5 to 6, it might take a longer time because they're a little bit more disoriented or they might be a little bit more dependent. However, if it's a client which is on a higher functioning level, maybe RLA stage 9 or 10 or maybe 8 or 9, it would take lesser time. Similarly with stroke or CVA, if it's a client with a good Brunstrom stage or good score on the Fugal Mayer in terms of their hand or their leg score or their voluntary control, it takes a lesser time. But if it's a client which has more of hemiplegic presentation, where the weakness is more pronounced or the muscles are not working enough, it might take a longer time. So overall, it takes around 45 minutes if you do it. Otherwise, it can be done within 30 minutes. For each task, it would take about 15 minutes. It is very easy to train because I got the feedback from all the therapists that have performed it. It does not require any specific training as compared to other tools that are present out there. So it is easily available as well. So it is easy to understand, it is easy to use, and it does not require formal training apart from what you might have studied in your rehabilitation degree.
Cool. Thanks very much, Tuti. Okay. Thanks again for your beautiful talk. I'm really looking forward to your work in the next step. And I think to wrap up. So I think first I'm sorry, but our first speaker did not show up. But the good thing is that we have more time for the other two speakers, and it went very well. So thanks very much to our speakers again, and thanks very much for the questions. So we hope you enjoyed this session as much as we did, and cool. Have a good day, and enjoy the rest of the conference. Thanks very much, Jenny, and it's today.
Thank you.
Bye.
Bye.
Thank you. Bye-bye.
Thank you very much for Angela. She is helping us as a backend host.
Yeah, thank you so much, everyone. It was a nice talk.
Okay.
Thank you. Bye.
Just wait a second. I just want to say this is an interactive talk, meaning that the talk's going to be roughly 5 minutes. You have 5 minutes, everyone, to come up with questions. You can use the chat, but most importantly, you should use the question and icon to post your question. Just shoot questions. It's going to make everything more interacting. So let's go, Adam.
Well, hello everyone. I'm Adam. I'm going to talk to you about the robot arm we built in the lab. So you can see the picture on the left. So the PhD question that I have is, what is the perceptual basis of sensory motor control? Which means we are taking seriously the principle that we can only control what we sense, or we control the perceptual variables. So we're using tracking, tracing, and drawing, and creating simulations and robots, so with human participants. And we are inspired very much by people who do neuro-robotics and bio-robotics, who try to create models of animals and then study how these models behave in the real world, and then try to get insights from the real world about what we can say about their organization of the animal nervous system. So we designed, built, and programmed the robot arms from scratch, which means that 3D printed arm segments, 4 degrees of freedom, and then we added a pen and a Wacom tablet to sense the pen pressure on the tablet and the angle of, and the position also. We can record it. So it's not state of the art, but it's low cost and customizable robot. You have for the visual system, very low resolution camera with some large delays for image recording, processing, and sending to the Arduino, which is comparable to human visual system in terms of how long is the delay. And there's also noise in detecting the marker position. So basically the camera is just detecting where is the green dot in the image, and then sending this data to the Arduino. So here you can see a robot's behavior on the left. And you can see it's moving in a circular pattern. But on the right, we can see its perception, but it's actually the visual input of the robot, which is an advantage of the using robots as a model in this kind of research. You cannot take like mouse's perception if you're using a mouse model. This is the diagram of the 2-level control hierarchy that's used in this model. So I can talk more about this in detail later. So we have a top-level loops with visual and pressure and tilt control, and then lower level loops that are on the Arduino that are much faster for the kinesthetic control. So they are not controlling joint angles, which is standard in robot control, but sort of synergies of multiple output variables and constructed input variables. This is inspired by spinal and supraspinal arm control structures and simulations by William Powers. So we were looking for features of biological movement in this machine, and we found several things. So one of them is isochrony, which means if you move from a point to another point in a straight line, it doesn't matter too much how long is the distance you are moving. You're going to move roughly at the same duration of time. So the robot moves roughly about 1.5 seconds, and this was found similarly in humans and other primates. And this is achieved without pre-planning the duration of movement. In the same task, we found the bell-shaped speed profiles, which means that the speed profile looks like a bell. In humans and primates, it's mostly a bit more symmetrical, at least what has been found. And in this robot, it's a bit asymmetrical. also it was achieved without planning the speed profile. So when humans track elliptical targets at high speed, we can see on the left plot, the blue areas are low speed or lower speed relatively, and the red areas are higher speed. So this is how humans track ellipses. So they have to slow down in the corners. And when we took the same task to the robot, we had a constant speed reference. The robot had very high speed. The robot also showed the same sort of speed profile, but it did not maintain the mechanism, did not maintain the shape of the size of the shape. So next we checked how well the multivariable control works. So because the robot is programmed to control visual positions in X and Y, and then also pen pressure and pen angle towards the tablet. So we can see on these plots in the middle that pressure and pen angle are controlled in both situations. So on the left is a normal situation, on the right is a situation with tilting the tablet by 30 degrees. And in both situations, the pressure is roughly constant and pen angle is roughly constant. Then we found that the robot can achieve motor equivalence, which is a feature that it can achieve constant outcome despite changes in motor implementation. That is, we block the wrist, so it cannot move it at all, and then we give it the same task. So you can see on the right that the visual position is maintained. The wrist is not moving, and then there is no reprogramming or learning or anything. So this is automatically. And similarly, if we move the marker by 12 centimeters away, which is the tool use situation, the marker still follows the visual reference. And also if you rotate the visual field, again, the robot, the marker follows the visual reference. This is because the higher level does not send coordinates to the lower levels. It sends the goal to move in a certain direction. So to conclude, in terms of Mars levels of analysis, we can see at the bottom that the very different mechanical systems can achieve with this on the top, the goal of reaching or coordinating multiple input variables. So we can conclude that maybe the algorithms that we used are similar to the algorithms in humans in some ways. But for example, we can also see that the following predictable patterns, like ellipses, is not completely modeled in this system because the size is not maintained. So we can see that hierarchies of feedback have some very interesting features. They are coupled with a real robot arm, and when they behave in a real environment, they produce certain biological movement features. However, we cannot generalize too much because there are many differences in the mechanical implementations between the arm and this robot, and also we are missing many higher levels to achieve more complex behaviors. So that's it. Thank you. So
great, thank you, Adam. That was that's quite impressive.
Thank you.
Thanks. All right, we already have a question from the audience.
Okay.
James Hermes is asking, I just didn't get, actually, James, if ever you wanted to come up on stage, you can come up on stage. But he's asking, what are the time delays? What were the time delays?
Yeah,
I think you said that at the beginning.
Yeah.
And then maybe you can expand on what is the control structure. And that's also a question now. I also
okay. So I have it here. So the first pointer, the delays are mostly the biggest in between the camera and the Arduino. So these are around 180, right? 180 to 200 milliseconds, which are comparable to human delays, right? While in the lower level loops, the delays are around 5 to 10 milliseconds. because the sampling time is 5 milliseconds for each of the joints, right?
And so you talk about hierarchical processing. Where do I see
Yes.
this in that graph?
So the hierarchy is sort of, this is an outer loop which goes between, so here is a marker, let's say, in the body of the robot, and this is recorded by the camera, and this is processed in the computer. And then here we have the goals that are set for the marker position. So the ellipse here is like a setting of a goal for the marker position here. And then this is like a top level loop, and it's setting a reference for the lower level loop, which is here. So the X and Y visual control is setting a reference for the kind of kinesthetic control of X position.
Mm-hmm.
And
okay, so instead of saying exactly where to go at every moment of time, it just sets a target that's being updated, and that leads to two levels, but it's hierarchical in two layers, right?
Yeah,
that's what you're saying.
Yeah.
Okay.
So
and your controllers, your markers here are a little bit acting like proprioception.
The markers are acting as visual cues, as visual position
cues.
of, yeah.
Okay, it's all visually guided. Yeah.
In the upper level, we have two visual variables, the X and Y, but then there's also pressure, which is kind of between the pen and the tablet, and there's the angle of the pen, which is like if it's perpendicular to the tablet, it's like 0 degrees, and it's maintained mostly 0 degrees. And then the lower levels, they have kind of angles of joints that are converted to reach variables and other, so X, R, Z, and delta, which are not exactly angles, but some kind of different synergy variables.
Okay. Another question is, so you focus on your isosynchrony and your speed profiles as matching that of human behavior, I guess, of
yes,
probably mammals. So why is so, like, is this an issue in the field, or do you expect that you have this? That is there a reflection of the fact that you're using a hierarchical processing in this?
Not necessarily. So it's possible to achieve this isochrony with different kinds of systems. Sometimes people say it is necessary to plan this kind of movement, but it's not always necessary to plan, even in this kind of a system with large delays, with large unknowns in the physics of the system. So the system is not trained to know much about the physics, and yet it can achieve this kind of movement, which is in a way standard behavior of a second order system. So we can make a model like a mechanical analogy as a mass on a spring with damping that behaves very similarly to this.
Right. Okay. So in that sense, there are some parallels between the mechanisms with which the biological control is being made and your system.
Yeah.
In the sense that it learns to control the mass spring system.
It behaves similarly to a mass spring system. Yeah.
Okay.
Analogously.
And then you talked a lot about the tilt.
Yes.
What changes when you're tilting?
In the experiment with tilting, so here we change the tablet angle. So you can see maybe on the screen the tablet is tilted by 30 degrees. So the pen angle remains constant at 0 degrees, which is the angle of the pen toward the tablet, which is now tilted. However, in the lower part, there is the angle of the surface of the hand or the palm toward the surface of the table, let's say.
Right.
And when the tablet is parallel, then the hand surface is parallel also to the table. And when the tablet is tilted, then the hand surface is parallel to the tablet, but not parallel to the surface.
So James Hermes also has another question. Thank you, James, for your question. He's asking, he's saying, well, it's interesting that you found, this is a little bit with respect to what we were saying earlier, that you find that many patterns are matching the human control. And the question is, how many parameters did you have to tune in order to observe these results?
How many parameters? Well, each of the loops, just a second, right. Each of the loops has 2 parameters. So these are proportional derivative controllers. So we have gains 4 loops on the top and 4 loops on the bottom. So 8 parameters plus the low pass filters, which is another 2 parameters. 10.
They were controlling the shape of the curve, of the learning curve, of the speed of the motion.
Speed of the motion, yes, yeah.
Okay.
There was no learning There was no learning by the robot autonomously. It was all mostly by me, just changing the parameters until stuff works.
Okay, thank you so much, Adam. We'll have
thank you.
We'll have now Laura. Maybe you can now share your screen. Laura, you can share your screen. It's really nice to learn about these robotic arms. Now we'll have on the stage Laura Schwendemann, who's speaking to us from MIT. I can't see your screen yet. It's coming up. She's going to speak to us about a frame-based approach to sub-movement decomposition. I'm actually looking forward to hear about that. There we go. Take it from there as soon as you're ready, Laura.
Can you guys all see the screen? Okay. Is it just full screen and everything?
Yeah.
Cool.
Yeah, we have actually the slideshow on the side, but I don't think it matters too much.
That's weird.
Maybe you can, yeah.
So, yeah. So I'm Laura Schwendemann. I'm an undergraduate researcher who works with James Hermes under Professor Hogan. And we developed an algorithm that decomposes human movement data, like velocity data, into submovements. And our main motivation for doing this was that there's a lot of evidence that humans use an intermittent controller that sometimes utilizes discrete submovements to compose human actions. And so in a lot of research, people try to decompose their velocity data profiles into submovements or fit submovements to it to try to find evidence or gain a better understanding of this controller. There's already a lot of algorithms out there that are pretty fast and can decompose this velocity data into submovements, but many of these algorithms make assumptions about the location of the submovements using greedy algorithms, which can lead to these spurious decompositions that aren't entirely accurate. There are, however, other algorithms that are stochastic in nature and make fewer assumptions. One of these algorithms is the scattershot algorithm. However, algorithms like this tend to struggle on large data sets with many submovements, where the optimization problem has a high degree of dimensionality. So the main goal of this work was to try to somewhat edit the scattershot algorithm into a frame-based version of itself so that it could be more conducive to running on long data records with many submovements. And so the basic outline of the algorithm is shown over here. And basically how it works is that it takes the movement profile, the velocity profile, or whatever kind of movement profile, and splits it into frames of length alpha. And then in each of these frames, it runs the scattershot algorithm and decomposes the profile into submovements, where the scattershot algorithm tries to minimize the error between the sum of the submovements and the original profile. And so after doing that, we then delete the submovements at the edge of the frame, each frame, because these submovements tend to cause more error between the fit of the sum of the submovements to the original profile. After then deleting those submovements, we need to refit submovements in that region because now there's just a gap. So to do that, we define a new frame. This frame is of the length beta, and we take the error within that frame between the remaining submovements in the original profile, truncate it a little bit, and then fit new submovements to it. Then as an exit criterion, instead of just comparing the error between the error profile and the newly fit submovements, we instead consider all the submovements now within that frame from both the original fitting and this new fitting and compare it to the original profile. After doing that for the edge of each frame, each of these beta frames, we add all the submovements together and get our final decomposition. So that's the general outline of how the algorithm works. Then we had to test it after developing it. And so to validate this algorithm, we tested it on synthetic data sets where we composed a minimum jerk submovements, where we knew the values of each of the submovements amplitudes, durations, and onset times. And so when we compared the frame-based algorithm we developed to the scattershot algorithm on profiles of various lengths. And when we were comparing them, we used an alpha of 6 seconds and a beta also of 6 seconds for the frame-based algorithm. The two parameters we mostly compared was the runtime of each of the algorithms and also the error between the fit submovement parameters and the known submovement parameters for each of the algorithms. So regarding runtime, you can see from this graph over here that the scattershot algorithm shown in red has some increases with something that looks kind of polynomic or exponential. And this is likely because the scattershot algorithm has a polynomic time complexity. And then what's interesting is that our framed approach, while it should have a similar time complexity because it uses the scattershot algorithm, because we run the scattershot algorithm on shorter frames sequentially, it almost grows linearly with profile length, making it run much faster. Then with regards to error, we found that the framed approach performed either similarly, if not better, to the scattershot algorithm once the profile length was greater than 6 seconds, the value of alpha we use. As you can see for amplitudes, it performs somewhat similarly, but then when we look at durations and onset times, the frame-based approach performed statistically better once the profile length was greater than 6 seconds. So from those results, we concluded that the frame-based approach we developed performs similarly, if not better, than the scattershot algorithm on longer data profiles and drastically decreases the runtime. And so we hope that this frame-based approach will make decomposing long data records with many submovements more feasible for future human motor control experiments. Thank you for listening. That's my research.
Thank you, Laura. Great. I think it was pretty clear. Do I have any questions from the audience? If not, I do have a few questions, but the first one is super naive, so I'm sorry about that. I didn't quite get what was frame-based in the frame-based approach. Maybe I just missed it.
So the frame-based idea is that we take the original velocity profile, which in this picture over here, it's this black line. And then this can be really long with a lot of submovements. So we define these frames and we section the data.
So a frame, in the frame, you then average the magnitude as if it was binned, or you just look at a subsection one at a time. It's like you go a bit like when we do fast Fourier, we go and look at smaller elements separate.
Yeah, we just look at it section by section and decompose it and then recombine them.
Okay. But then, do you expect that as you increase the profile length, your runtime is also going to end up being exponential if you go further than 12 seconds?
So the main reason it doesn't get super exponential when you increase the profile length is because, generally speaking, in human data, there is a similar number of submovements, spread evenly, right? So if you section each of the frames and you're decomposing it only once or twice, you kind of cap at the max, the worst frame you get with the most submovements. And that's your max time. And then you can kind of just multiply it by how many frames you have.
Okay. I thought it would still be either exponential or logarithmic, but okay. Questions were answered. Okay. So I have a question here. Could you describe in more detail what data was used, the data that you've used in here?
So the beta we used was 6 seconds. So that's like the length of the error frame. And that's how, when we were refitting submovements after deleting them at the edge of each of our like alpha frames, right? We centered this frame that was 6 seconds long in the data that started like, let's say this alpha was 6 seconds and we just decomposed this frame. Then we start a new frame and decompose the error within 3 seconds and 9 seconds in the profile. So that's the beta we used in practice, but this could be any number you wanted. We just generally used that because when we made the synthetic data, our largest duration was like 3 seconds. So we wanted, if we deleted a submovement that was like centered right at the edge, like its tail was just at the edge of the frame, then like it'd be like all of its error would be considered with 3 seconds on either side.
And I'm sorry, I was also reading the second question at the same time, but I think you answered it. Is there was a set of reaching movements in there, right?
Oh, in the synthetic data?
Yeah.
So the synthetic data was supposed to mimic human data, and it was just kind of like continuous data. So like a series of submovements with random parameters that we knew, like a set of random parameters that kind of made sense based off, I believe we did crank turning studies, so sort of reaching movements.
Mm-hmm.
Yeah, and that's generally the data set we use.
Cool. And when you mentioned the scattershot algorithm, you said it was going to minimize the error. So what are the parameters here? Is it?
So we have this error thing here in the main. It uses the fmin_con function in MATLAB. This wasn't developed by me, it was developed by Brandon Rauer, but I believe it uses the durations, onset times, and amplitudes when it defines the submovement. And then there's like a bunch of those because there's many submovements. And then it like uses those parameters in the function and it then finds the minimum value for each of those for every submovement, if that makes sense.
Yeah, absolutely. Then a question from Aaron Wong. Thank you for your question, Aaron. Are the frames non-overlapping, and if so, why?
So we just did not overlapping frames. So just, there's not a good reason for why we didn't overlap them, just that then we considered each piece of data kind of like fairly. And then we were able to easily define the error, like delete submovements, like choose which submovements could be deleted, just crossing over the edge of the frames. So there's less overlap between the submovements you fit, and you don't have to like choose which ones to delete. So yeah, the frames are initially after each other. One frame ends at alpha and the next one ends at 2 alpha and so on.
Oh, and I think I've relayed to you one of the questions wrong about whether it was a set of reaching movement. I think it was pertaining to the data. I'm a bit confused by this. So Michael Berger here says that Joseph's question was about data, not beta.
Oh, so like how did we choose values for the data is the question?
I think it's more the underlying data that was used to guide some of these. Oh, the question was answered apparently, but thank you, Joseph. All right, so sorry for that confusion, but thank you so much, Laura. I think unless there are any other questions, we will slowly transition to our next speaker. All right, so thank you, Laura.
Thank you.
Great job. We now will have Alexei Krotov. Alexei, can you share your screen, please? Thank you. So we have Alexei Krotov from Northeastern University, who's going to talk about manipulating bullwhip. Complex tasks require complex methods. So looking forward to your talk, Alex.
All right, can you hear me well?
Yes.
Okay. Hello and welcome, everyone. While studying motor control, we were so fascinated by humans dexterously manipulating complex objects that we decided to challenge them and ourselves with one of the most exotic tools, the bullwhip. Here's where it stems from. Much motor control has recently focused on locomotion or on constrained arm movements, such as reaching. Interaction with objects offers more challenges, apparently, and has received less attention. The attempts considered mass spring, pendula, Cartan pendulum, and other reduced systems. However, humans can dexterously deal with much more complex objects. For example, on a daily basis, you tie shoelaces and make bed. These objects offer rich internal dynamics, and the study of the dynamics, primarily with modeling, might point us at identifying control strategies, or at least at the right questions to ask. So here is the motivation, and we also wanted to open the agenda for establishing new paradigms and new metrics. And our participants used a whip to hit a remote target. This task required full body coordination, concerted movement of upper body and arm, and interaction with the whip. And the whip has nonlinear mechanics and infinite degrees of freedom. Very few studies considered whip movements in the past. Using physical models of different complexity, they showed analytically that the tip of the whip could reach supersonic regime and crack. These studies, however, did only theoretical investigations without data. Let us see what these models could teach us here, where we ask control questions and we have the data. As I said, we challenge not only participants but ourselves. We seek to identify salient metrics that describe the task and can point us at motor control strategies. While it is at least challenging to control all degrees of freedom of the whip, we suggest that the nature of the task and the human actions could make the physics of the whip simpler to deal with. In particular, we noticed that the whip often unfolded smoothly, as you can see here, while it is propelled towards the target. While no cracking was possible in our experiment, this motion is exactly what the previous models with the previous studies modeled. So we employed simple models used before and elsewhere in physics. The whip here is represented as one-dimensional thread that is pulled forward. As its leading end comes to a stop, the rest of the whip folds and unfolds, and the moving part accelerates. Conservation of momentum or of energy could be used to construct the equation of the whip kinematics. And we found the momentum conservation model to agree better with the data. And we also added the tapering of the whip from geometrical measurements of the real whip. We modeled how the peak's speed travels across the whip when the whip is unfolded. The family of such curves is determined solely by the initial speed of the handle, analogously with the release speed in throwing. In experiment, we used markers to measure kinematics of the body, whip, and the target. Participants were instructed to hit the target in rhythmic style, attempting to hit the target continuously, and in discrete style, with the pauses between attempts. We expected here to force the whip and participants into simpler and more predictable manipulation in rhythmic style. And indeed, we saw clear unfolding of the whip in the data as the whip is thrown at the target. Most of rhythmic trials, which you can see in the left animation, show this evolution of whip shape. While some discrete trials in the right animation showed the same pattern, in most of discrete trials, the whip exhibited more complex movement. So how do we compare model and the data? We focused on a small interval in each trial where the whip was thrown at the target following the peak hand speed. Dealing with the whip speed profiles, we seek to quantify positions of speed maximum. In this exemplary trial, they form a nice ascending sequence. We normalize the profiles in time and in speed, separately for each marker. This way we obtain the heat maps where black area indicates the traveling of the speed maximum, and the model will later be initialized at the beginning of this sequence. We also noticed that each participant had the whip moving in the same way in multiple trials. So for comparison with the data, we moved to grand average, one for rhythmic, one for discrete style. And the model predictions were also matched with the data. So the model was initialized at an averaged time, and average value of the handle initial speed was used to pick one curve of the family of those. And here we are looking at grand average for rhythmic style, all participants and all trials, and discrete. You can immediately notice how the black area, the maxima, is narrower in rhythmic style. Indeed, it indicates how all the participants in trials behaved made the whip behave in a similar way. And you also can see that this performance agrees qualitatively with the simple model. And the pattern is more complex in discrete style, and the model shows a poor agreement. Numerically, this could be quantified with the norm of residuals, where the less score shows better agreement. Hence, here we confirmed that the whip, an infinitely complex object, follow relatively simple dynamics. Following this notion, we demonstrated how physics of the complex object in a complex manipulation task can reduce to fairly simple dynamics. The next question is how humans can create and exploit such dynamics, especially for control. That means relating these dynamics with the participant's performance and analyzing the task from the dynamic systems perspective. These questions will be partially addressed in the talks of my colleagues Marta Russo and Moses Nah today and tomorrow. So stay tuned at NeuroMatch. I'd like to thank my lab members and collaborators, as it is a huge joint work. And thank you all for attending the talk. Let's open the stage for discussion. You're muted, Richard.
Thank you. Don't whip me. Yeah, thank you for the talk. So I open the floor for questions right now. I had a question to start off. So your model of the whip, I was a bit confused because you showed a body with like joints and stuff, but your model is only the whip, right?
Exactly. So in the model, we only consider the whole motivation is to start with the task dynamics, not immediately the body dynamics. So seeing what the object could provide us in terms of control. So in the model, we only dealt with the whip.
Right, cool. And so you then give it like a hand, like you said hand velocity, but I suppose it's also like something with angular momentum.
It should be, and in complex motion, it definitely is. And in the data, we looked at both tangential speed and rotational speed of the hand. However, what is remarkable about this model, it doesn't care about rotation and angular speed at all. So this one only deals with the tangential speed. And there is no rotation here since the gravity is neglected and the whole thread is one-dimensional.
Mm. Yeah, I guess it has to do with where the whip is at the beginning with respect to the angle of the motion.
This points, yes, this is a very important notion as it points at how humans can set the initial conditions to make themselves successful in the task. That's why you should really stay tuned for Marta and Moses' talks.
I see, cool. And so it's kind of interesting, this tapering. Did you, is there any specific tapering that would work better than others? Like, did you have to explore f of x to recreate some of the properties that you've been seeing experimentally? Is there an f of x that makes it a super whip? Like, are the real whip optimized in that sense?
That's an interesting question. Anecdotally, I can say that it was much harder to crack or to manipulate a homogeneous rope as compared to the whip. And it was also much harder to manipulate the whip holding it at the tip. inverting the whole mass distribution. I'm not yet sure whether a particular kind of tapering is important, but looking at a few whips that we had, the tapering is close to linear. So the radius, the dependence of radius on the distance from the handle decreases almost linearly. Slightly, it looks like quadratic, but we use the linear approximation.
Interesting.
As of now, it's an interesting question that you ask, how important the tapering is. I got to note it down.
So is that actually data that you're showing?
Yeah, these are the measurements of the experimental whip.
Huh, wow. Yeah, indeed, almost linear. Interesting. I had assumed that it was exponential for some reason.
Could be.
So what did your model not capture? You've kind of flashed your result at the end, but I suppose there are discrepancies.
Oh yeah, by all means. So here, looking at the main comparison of the model and the data, we could see that the whole interval captures the movement of the whip from the maximum hand speed until the time of the minimal distance when the whip is the closest to the target. So one thing that the model actually predicts inaccurately is that the whip should fully extend, meaning that forward wave should travel completely to the tip earlier than the whip reaches the target. While in the data, we could see that a process ending later. And another discrepancy is the exact profile of how these maxima propagate. Meaning at the beginning, we could generally see a steeper increase, and then we could see something like an exponential or maybe quadratic growth. Mm-hmm. I believe that has a lot to do with again the stiffness of the whip, which is sufficiently large near the handle, so around here, meaning that the whip here might be moving more as a single piece, as a single object. And indeed, in discrete style, as before in animations, you can see that there is not always that notion of the wave propagating. Like the whip is sometimes collapsed as it's being thrown at the target. Sometimes it is moving as a single rod being swung. The movement is more complex, and the model doesn't capture that yet.
Yeah. So what's actually explaining these like discrete transitions that we were seeing in your discrete data?
The transitions could largely result from averaging across a lot of participants. The first idea of averaging was to have the gross product to compare with the model. However, of course, the refined procedure would be to compare trials or at least blocks with the model separately. So we indeed observed relatively large inter-participant difference. And for example, if you look at multiple discrete trials here,
oh, wow, okay,
this view should be better. You can see the average in the middle. You could see different participants having different profiles. While many of them form the same ascending sequence, for example, the first four on top, you could see others having different patterns. Averaging of those resulted in this discrete, as you said, profile.
Yeah, it looks as though there are two types of motions across participants. Yeah,
exactly. That might point to only two or maybe more strategies for controlling the whip.
Excellent. Well, unless there are any other questions, I think we'll thank Alexei and all the panelists today for their contributions. I'll install an echo chamber here so it sounds like there's a lot of people applauding. It's nice to see you all, and we'll close the session and look at all the other talks at NeuroMatch. So nice to see you all.
Thank you, Richard. Ciao.
We have a very nice lineup of speakers, and in this session, we will learn about mainly sensory processing, audio-visual integration, saccade processing, and interaction between locomotion and vision. So we have like very exciting talks. We can just get started. Our first speaker is Aaron Williams. Aaron is a PhD candidate at the University of Pennsylvania, and he works with Dr. Murray Geffen. And he's going to talk about how auditory stimuli modulates encoding in the visual area 1.
Sorry, we don't hear you.
Yeah, you are mute, Aaron.
Great, so can you hear me now? Great, so thank you for the introduction. Like was said, my name is Aaron Williams. I am a graduate student at the University of Pennsylvania in the lab of Murray Geffen. I'm talking about how sound affects visual processing in mouse V1. So multisensory integration is an important aspect of everyday life. If you imagine that you're in a crowded environment where there's a lot of background noise, it's often easiest to understand what somebody's saying if you're looking directly at them and getting visual cues. Or it's as simple as if you hear noise to your right, you're going to turn to your right to get more sensory information from the source object. So literature has shown that the behavioral improvements that are associated with multisensory integration include object identification. I already mentioned speech perception, some aspects of memory recall, as well as spatial navigation. One of the underlying principles of multisensory integration is that it's most beneficial when the unisensory modality is somewhat unclear. When the unisensory modality is uncertain, the additional sensory input can be is most beneficial behaviorally. This is a paper from Meyer et al. In 2018, where they tested mice in a sensory detection task. You can see that performance is improved in the audio-visual condition in purple compared to when there's a visual and auditory stimulus in isolation. In particular, there's the greatest improvement at some of these intermediate visual stimulus levels, which again, it demonstrates that around these sort of threshold levels is when the multisensory integration is most beneficial behaviorally. They also observed improvements in reaction time in the audiovisual condition compared to the visual condition. This is another paper from 2019 where they recorded in V1 while presenting audiovisual stimuli. This is basically a polar histogram where you can see the number of neurons that are recruited to respond to the visual stimulus is greater when the sound is accompanying the visual stimulus than compared to when the visual stimulus is in isolation. This can be somewhat considered a putative mechanism for how improved sensory detection is mediated, but it's unclear whether V1 participates in the improved sensory discriminability with the additional auditory input. So that's what we wanted to see, is whether the addition of whether sound can improve the stimulus discriminability in V1, and if so, how? And so we went about this by recording extracellularly in V1 while presenting the audiovisual stimuli to awake head-fixed mice. The visual stimulus consisted of drifting gratings presented in 12 different directions, presented randomly, and they were either presented in isolation or paired with an auditory white noise. This is an example of the type of audiovisual response that we may see. On the left is a raster plot, and in right is a polar plot demonstrating the directional tuning of this neuron. And we can compare these visual responses to those of the audiovisual response in blue. And we're seeing that there's some mild changes around the 210 to 270 degrees direction, but we can also present a visual stimulus at 5 different contrast levels. And for this neuron, we're seeing that the greatest enhancement in the magnitude of the visual response comes at some of these intermediate to higher contrast levels. And so across 8 recording sessions in 4 different mice, we saw that around 75% of neurons in V1 were visually responsive. And of those neurons, the vast majority of them actually had their visual responses modulated by sound. We can see that when averaging across these sound modulated neurons, there's enhancement of the visual response magnitude at all contrast levels. But the greatest changes in the magnitude of the response came at some of the highest contrast levels, which is unexpected given what I was talking about earlier about the changes behaviorally being at these intermediate contrast levels. It's also worth noting that this integration was supralinear, meaning that the audiovisual response was greater in magnitude than what you would have expected just by simply adding the sound only and light only responses. So this is the magnitude of the response. We were also interested in how sound affected the consistency of the response. We're interested in this because you can imagine that some improved encoding could happen not only through changes in the magnitude, but changes in the consistency. If the neurons are firing more consistently from trial to trial across the population, that can still correspond to an improved signal to noise ratio. So if there's the standard deviation scales with the standard deviation scales with the magnitude of the response, then if this relationship is shifted downwards and to the right, then we can see that for any given firing rate, the standard deviation or the spread from trial to trial would be lower. And so this is what we hypothesized that we would see. It is in fact what we saw. This is an example neuron where you can see that the relationship between the standard deviation and the firing rate is shifted to the right. And we can quantify this by looking at the ratio of the standard deviation to the firing rate, which is known as the coefficient of variation. Coefficient of variation, the lower the coefficient of variation means an increased signal to noise ratio, basically. And so across these sound modulated neurons, we're seeing a lowering in this coefficient of variation. And interestingly enough, the greatest differences in the CV are at the lowest contrast levels, somewhat contrasting with what we saw in the magnitude of the response, where the greatest changes in magnitude were at the highest contrast levels. So just to recap thus far, we've seen changes in the magnitude of the response, changes in the consistency or the coefficient of variation. We also observed changes in the latency and increased onset duration, which we didn't have really time to talk about today, but they were observed. And so seeing that there's this change in this enhancement in the magnitude as well as improved consistency from trial to trial seemed to suggest that we would observe improved encoding of the visual stimulus, particularly the visual stimulus orientation by these neurons. So how did we go about quantifying that? We used what's called a maximum likelihood based approach. And so this is an example orientation selective neuron. We can see that it's tuned particularly to the orientations along this 60 to 40 degrees axis. And if we unravel these tuning curve into its underlying trial by trial responses, we see that responses to the blue orientations cluster much higher than those to the red orientations, the orthogonal ones. And so what the maximum likelihood based model does, if we plug in a probe trial in which the neuron fired at around 40 hertz, we would think that the probability that the visual stimulus was this blue orientation is much higher than the probability that the stimulus was this red orientation. Conversely, if the probe trial is around 10 or 12 hertz, it's much more likely that the visual stimulus was this red orientation. So we ran this maximum likelihood based approach across all of the orientation selective neurons, and we saw improvements in the decoding ability of this model, particularly at these intermediate contrast levels, which could be a potential mechanism or neural correlate of these behavioral results that I talked about at the very beginning. This is when we ran a model with individual neurons. And when we ran the model using populations of neurons organized by recording session, the findings still held true. So we're seeing this improved neural discriminability, and we think that it's related to the changes in the magnitude as well as the consistency that we've been seeing. And so in order to further demonstrate these coding principles, we built what was a very simple probabilistic spiking model, where we had V1 neurons. They are getting visual input. They're also receiving auditory input that are filtered through a set of auditory neurons. We're agnostic at this point as to whether the auditory neurons are auditory cortex or pick your favorite auditory region, but auditory neurons nonetheless. You can see that the probability of firing behaves according to the sigmoidal curve, where there is some baseline firing rate, there is some maximum firing rate, and there's this dynamic range in between. And the bars here represent the various stimulus visual contrast intensities, and the associated PSTHs are on the right. And so when we, because we also saw that the sound was a largely excitatory effect, the sound served to increase the stimulus intensity in this model. And again, the PSTH is on the right. And when we ran this model, we saw that the coefficient of variation decreased across contrast levels. And this really follows simply from the math of it. And so this is again, the probability of firing, the sigmoidal curve on the left. This is the actual mean firing rate in black here, from trial to trial in this model, and in red is the standard deviation. Note that y-axis here is log. We made it log so that we can better see the divergence of these curves, But as the stimulus intensity increases, we're seeing that the standard deviation doesn't scale proportionately with the average firing rate from trial to trial. And so because as the stimulus intensity increases, we're seeing this coefficient of variation decrease. And because the auditory inputs serve to increase the stimulus intensity, we're also seeing decreases in the coefficient of variation in the audiovisual condition compared to the visual condition. And we can see how this model data, the simulated data on the left, resembles the experimental data that I presented earlier. So we can expand this model to include orientation selective neurons. And when we ran the maximum likelihood decoder on these orientation selective neurons in this model, we also saw improvement of the decoding ability, again, at these intermediate contrast levels. And we can see how this resembles the experimental data that I presented earlier. So just to summarize, we see that there's improved encoding of the visual stimulus orientation. We think that it's because of the changes in magnitude and the coefficient of variation. And when we employed these coding principles in silico, we saw that the model replicated the experimental data. Moving forward, we're interested in looking at the circuits that underlie this effect. And so we've been using a retrograde tracer injected into V1 to look at the auditory regions that project to V1. And what we're doing now is using pharmacologic and optogenetic techniques to suppress these regions, start to poke and probe at these circuits to see if they're causally related in providing auditory information to V1. And so with that, I want to thank you all for listening. I want to thank my lab for the support during this project, as well as the funding, which is an NIDCD sponsored training grant through the University of Pennsylvania. Thank you.
Thank you very much, Aaron. That was a really nice talk. So now let's see. Yeah, we have one question.
Sure.
From Sadra Sadeh. I hope I'm reading the name correctly. So Sadra is saying, nice talk. Do you also see a suppression at orthogonal orientations on average as reported before from Tao's lab?
Yeah, so that's actually a difference in what we're seeing compared to what has been previously reported. We've been seeing sort of increases in response magnitude across orientations, and not just at the preferred, but also at the orthogonal orientations. So it makes me consider whether we're not only seeing an auditory effect here, but potentially also some sort of motion effect, movement effect, and whether there's this sound-induced motion is also contributing to improved encoding in V1, since we know that motion and motor activity increases spiking rate in V1. And so moving forward, as we start to suppress these auditory regions, it'll become more clear how much is contributed from the auditory versus the any other sensory modality that may be there. And so no, we didn't, long story short, no, we did not see suppression at the orthogonal directions, but rather enhancement across all directions.
Okay, thank you. Thanks, Aaron. So now we can move on to our next speaker. Okay, so our next speaker is Satoru Miura. He works as a postdoctoral researcher at the University of California, San Francisco, with Massimo Scanziani. And his talk concerns the role of pulvinar in the direction of visual motion associated with saccades.
Great, thank you for the introduction. And today I'm gonna talk about, tell you a story about how saccadic eye movements impact visual processing. So, let's see. So often sensory inputs are induced by the animal's own actions. But in order to exclusively respond to sensory inputs generated externally, many sensory systems have evolved ways to suppress these self-induced inputs. For instance, the auditory system of a cricket is suppressed while it chirps, and the lateral line of the fish that senses the direction of water flow is also suppressed while it swims through the water. And this is also the main reason why it's difficult to tickle yourself. Now, the self-motion we'll be talking about today are saccades. And saccades are these ballistic movements where the position of your eye changes from one to the next within a matter of a few tenths of milliseconds. And this type of eye movement is actually quite commonly found throughout the animal kingdom. And so here I'm just going to show you some examples. And this one is one of the coolest animals on the planet, mantis shrimp. And it makes these saccade-like eye movements. And here you see a fish making saccades. Chameleons, they're very famous for their ability to control the two eyes independently. Many of you have probably seen cats and dogs make saccades, and also primates, including us humans. And we as foveate animals depend on these saccadic eye movements quite heavily to scan the world. Now, as useful as these saccades may be, they also pose a big challenge to these animals. And the challenge is to maintain the sense of stability of the visual world, despite these saccades constantly shifting the visual scene across the retina. And so here's what I mean. Imagine you're looking across this room, right? And you're staring at this pot of flowers, and you decide you want to look at the TV. And so you make a quick saccade to the right. And so here's a new visual image. Now, in between these two stable images, there was a period of time during which the image shifted across the retina in the direction opposite to your eye movement. And so how does this not make us think that the world is constantly dancing around us? Now, one way to deal with this is to omit this visual motion from our visual processing altogether. And as a matter of fact, that's exactly what happens. We become effectively blind during saccades. And in the past, there have been several mechanisms that's been proposed that prevent us from perceiving this visual motion, including some reduction in visual sensitivity in the retina, for instance. But the visual cortex is very good at detecting the direction of visual motion, and how the cortex deals with this direction information induced by the animal's own eye movement is not very well understood. And so we wanted to tackle this problem using spontaneous saccades in mice. And so today we're going to be addressing two questions. One, how does the mouse primary visual cortex, or V1, deal with the direction information of saccade-induced visual motion? Is it canceled somehow? And two, if so, what is the circuit mechanism behind that? And so let's start with question one. And I'm going to start off by showing you a short video of a head-fixed mouse making spontaneous saccades. And as you can see, these animals make spontaneous saccades primarily along the horizontal axis. And so today, we're going to be talking about just two types of saccades: nasal saccades and temporal saccades. Now, in order to understand what goes on in V1 during saccades, we're going to stick an electrode in V1 while these animals make spontaneous horizontal saccades on a vertical grating. Now, also, in order to address how this saccade-induced visual motion, how the representation of this saccade-induced visual motion might be different from externally generated visual motion, we're also going to mimic the changes in a visual scene induced by saccades by shifting this vertical grating while the eye remains stationary. And these we call pseudo-saccades. And here we match the direction, the amplitude, and also the speed to the real saccades. Okay, so let's look at the overall response first. And on the top is a heat map where each row is a single unit sorted by their depth. And on the bottom is the average PSTH. And immediately you can see that the dynamics of the response under these two conditions are quite different. But what about the direction information, right? That's what we're interested in. And so in V1, many neurons are known to be tuned to the direction of visual motion, as we have seen in other talks already at this conference. And so here's an example neuron that responds more to temporal pseudo-saccades than to nasal pseudo-saccades. Now remember, the pseudo-saccades are purely visual motion, right? And these neurons are said to be direction selective. And so if there was a downstream decoder, for instance, whose job was to decode the direction of visual motion, then these would be the neurons that the decoder would rely on. And so the question is, what happens to this direction selective response during real saccades? And so here on the x-axis, I'm plotting the direction selectivity of each neuron to pseudo-saccades. And on the y-axis, the direction selectivity of those same neurons to visual motion induced by real saccades. And -1 indicates a strong preference for temporal saccades or temporal pseudo-saccades, and +1 indicates a strong preference for nasal saccades or nasal pseudo-saccades. So if the direction selectivity remains stable between visual motion induced by saccades and visual motion induced externally, then one should see a correlation here. Interestingly, there is very little correlation here, and the direction selectivity during real saccades is scrambled relative to the direction selectivity during pseudo-saccades. Now, this is an important concept, and so we're going to also look at it in a slightly different way. So here I've lined up all the direction selective neurons according to their direction selectivity to pseudosaccades. So on the left, we have neurons that prefer temporal pseudosaccades, and on the right, we have neurons that prefer nasal pseudosaccades. Now, on top of this, I'm going to overlay each neuron's direction selectivity to real saccades. So for instance, this left neuron retains its direction selectivity for both real saccades and pseudosaccades. But this second and third neuron, the direction selectivity is flipped towards the nasal direction. And so as you can see, the direction selectivity during real saccades is scrambled relative to the direction selectivity to pure visual motion. So what does this mean, right? What significance does it have? What this means is that if there's a downstream decoder, again, whose job is to decode the direction of visual motion, then that decoder would actually fail during real saccades. And so we can actually demonstrate this concept by building a simple classifier that decodes the direction of visual motion based on direction selectivity. And applying that classifier on the response of real saccades or on the response of pseudosaccades and comparing the performance. And so here I'm plotting the performance or classification accuracy of this classifier on pseudosaccades as a function of the number of neurons included in this analysis. Now, compared to this performance on pseudosaccades, this classifier performs very poorly when applied to the response of real saccades. And so the scrambling of direction selectivity prevents the downstream decoders of visual motion from knowing the direction of visual motion during saccades. And so how does V1 deal with the direction information of saccade-induced visual motion? Well, V1 scrambles the direction selectivity such that the direction information is no longer available downstream. So what's the circuit mechanism behind this scrambling? So we hypothesize that this scrambling must be caused by a non-visual input that comes into V1 around the time of saccades. And so to test whether V1 receives such an input, we silenced the retina by injecting tetrodotoxin in both eyes of the animal and eliminated all visual inputs. And even under this condition, sure enough, many neurons in V1 still respond to saccades. And so V1 receives non-visual saccade input. Now, where does this come from? Now, in the interest of time, I'm going to skip over much of the circuit mapping and jump right to the conclusion. And the conclusion is that this non-visual input comes from a higher order nucleus in the thalamus called the pulvinar through direct projections to V1. And so I'm just gonna show you one experiment that demonstrates this. And so here I've silenced the retina by injecting TTX in both eyes of the animal. And at the same time, we've also silenced the pulvinar by injecting TTX or muscimol. Now, after silencing the pulvinar, we were able to eliminate all non-visual inputs into V1. And thus, the pulvinar is the source of the non-visual saccade input. Now, let's go back to the original question. Is this non-visual input from the pulvinar responsible for scrambling the direction selectivity in V1? To answer this question, we repeat the exact same experiment as the first one, where we record the saccade response and the pseudosaccade response. But this time, we're also going to silence the pulvinar. Now, after silencing the pulvinar, the overall response profile now starts to look very similar to each other. Now, if the pulvinar is responsible for scrambling the direction selectivity, then now the direction selectivity under these two conditions should correlate. And indeed, that's what we see. And thus, the pulvinar is responsible for scrambling the direction selectivity. Further, that same decoder that classifies the direction of visual motion is now able to classify the direction of saccade-induced visual motion just as well as it classifies the direction of pseudosaccades. And so here's the direct comparison between pulvinar silencing and control. And so under control conditions, the pulvinar, by scrambling the direction selectivity, prevents the downstream from knowing the direction of visual motion induced by saccades. And so what is the circuit mechanism behind the scrambling? It is caused by a non-visual saccade input from the pulvinar. And so here's what we think is happening. When these animals make saccades, this causes a shift in a visual scene, and this visual motion information is sent to V1 mainly via the DLGN. But at the same time, the pulvinar sends non-visual input to V1, where these two inputs become integrated, and this results in scrambling of the direction selectivity, preventing the downstream from knowing the direction of visual motion. And this, we think, is how V1 cancels the direction information induced by the animal's own eye movement. And so with that, I would like to thank my boss, Massimo, and all the members of the Scanziani Lab, and all my funding sources. And thank you for your attention, and I'll take any questions.
Thank you very much, Satoru. That was a really nice talk. So let's see if we have questions. For now, okay, I don't see from the Q&A part. But yeah, now in the chat, we have a question from Federico Rossi.
Ah, Federico.
Oh, okay, you know, okay, cool. Excellent work. Do you expect motor input to arrive to LP from the SC?
That would be my guess. I haven't gone upstream of the pulvinar, but in primates, it has been shown that the pulvinar receives motor saccade input from the superior colliculus. And I imagine something similar is going on here too. Yeah.
Okay. Thank you, Federica, for the talk. We have one other question. So from James Goodman, to what extent might the properties of the visual scene, for example, spatial frequency, affect the degree of scrambling in V1?
Right, that's an interesting question, and it's a rather difficult question to really address, because it's quite difficult to obviously explore the whole visual parameter space. But what I can tell you is that this integration, I skipped over this in the interest of time, but this integration results from can be best modeled by a linear summation of the non-visual input from the pulvinar with the visual input. And so if the visual stimulus is strong enough, or right, if the visual stimulus is strong enough, it should be able to start to overcome the non-visual input, for instance. For instance, if you gave a flash all of a sudden during a saccade, this could indeed overcome the scrambling. But also one other point that I should probably mention is that this non-visual input actually has a much broader effect. It affects a lot more neurons in the visual cortex than one type of visual stimulus does. For example, in this case, it's a grating, and this vertical grating, let's say, affects only 20–30% of the neurons. The saccade input actually affects a lot more neurons, and so yeah, it's not a straight answer, I know, but I would assume that scrambling, the degree to which the scrambling happens will depend on the spatial, the visual input, yes.
Okay, thank you. Thanks all for the good, nice questions, and thanks again, Satoru, for the very interesting talk. So our final speaker for the session is Elise Xavier. She's a postdoctoral researcher at the University of Virginia, and she works with, I'm allowed to say, JC. Her talk is about the effects of locomotion on visual responses in the mouse superior colliculus.
Hi, everyone. I would like to thank the organizer for giving me the opportunity to share this work. And so I'm going to talk to you today about the effect of locomotion on visual response in the mouse superior colliculus. So first of all, let me give you a bit of context as to why we studied the superior colliculus and how it's modulated. As you can see here, this little guy in the snow has probably a lot going on his mind. It's cold, he's probably hungry, he has to find food, maybe a mate. And all of a sudden, this guy appears. So now his immediate survival depends on his ability to detect this threat and respond to it as quickly as possible. So how can he detect it? And what are the features that give away the presence of an owl? Well, let's take a moment to look at this image. What you can see here is like a rocky cliff, and maybe some of you have noticed a few goats around. So maybe 1, 2, and maybe 3. So now I'm gonna tell you, let's find out. So the point here is the goats became very obvious to see the moment they started moving. So motion is a critical component for detecting others. So now how can motion be detected? So light information is captured by the retina and relayed to the thalamus, dorsolateral geniculate nucleus, and later on sent on to the primary visual cortex. Then it's further processed by adjacent cortical region, which help us recognize objects and make sense of the visual world. So interestingly, recent studies have shown that visual responses in the primary visual cortex can almost double during locomotion, which is also linked to arousal. So this is one of the first studies to show this by Neal and Stryker in 2010. And as a consequence, these results suggest that brain state can profoundly influence how stimuli are perceived. And the question is now, since our internal state can influence our sensory responses, how can we reliably encode visual information independently of these factors? The pathway from the retina to thalamus to the cortex is not the only pathway dealing with visual information. A copy of visual information is sent in parallel to another brain structure, which is the superior colliculus. The superior colliculus is involved in visually evoked defensive behavior, for example, which involves running away the moment you detect the shadow of an owl, for example. And this structure is layered and located in the midbrain. It's known as the mammalian homologue of the tectum, and it was the major visual center until the emergence of the cortex. And the visual layers at the SC receive direct input from the retina, which are here labeled in green. And one interesting feature is that the upper part of the visual layers are enriched in neurons, which display an interesting response property, meaning that they're direction selective. So as I mentioned earlier, visual responses in the primary visual cortex are strongly modulated by locomotion, and the superior colliculus has all the necessary things to evoke visually evoke defensive behavior. So these observations led us to the following question: is the detection of motion in the superior colliculus modulated by behavior? So how did we do this? So I used 2-photon calcium imaging and recorded the neural activity in awake running mice. So to measure the neural activity, I used GCAM6F and injected it in the superior colliculus. And then I inserted a glass window above the SC, pushing forward the transverse sinus so we could gain optical access to the caudal pole of the SC, which corresponds to the upper visual field, essentially. And here you can see a wide field image obtained by epifluorescence. And this is what it looks like under the 2-photon, where you can distinguish nicely all the cell bodies. So the mice are head fixed on a wheel under the 2-photon microscope, and they can run whenever they like it. And then we measured the locomotion, but the rotation, the encoding of the rotation of the wheel. We have the screen placed in the corresponding retinopic location, and we show them drifting grading. So here is an example of what it looks like once we've processed it a little bit. So we're following the blue cell, and you can see the stimulus on the upper left corner. And you can see that this cell definitely prefers going this way. So, and then you can see the change in the calcium signal as we go along. And so here is an example trace obtained using this method. The arrows on the top represent the different directions, and the duration of the stimulus is marked by the vertical bars. And based on this measurement, we can obtain the tuning curve for each individual cells. And then we divide the trials based on if the animal was stationary or if the animal was running. And now we can obtain tuning curve for both conditions, so either stationary or running. And now what you can see here is that both tuning curves are virtually identical for this particular cell. And then we performed this analysis in 12 animals, and we obtained a total of 528 visually responsive cells. And here we're plotting the response for each different condition, again, from the stationary condition against the running condition. In red are the conditions for which the response in the running condition were significantly higher than stationary responses. So roughly 20% of neurons show a significant increase and 10% show a significant decrease. But then went on to quantify that more precisely, and we calculated what we call the locomotion modulation index, which is normalizing the response running minus stationary against running plus stationary. So you get a nice index that goes from -1 to 1. And here's the distribution of this locomotion modulation index. And the median here is 0.03, which means that overall the modulation is of 10% between the running and the stationary condition. So overall, these results show that locomotion only has minor effect on the direction selective cell in the superior colliculus. Now, this is in sharp contrast with what has been reported in the primary visual cortex, where we've seen that locomotion strongly affect visual responses. So we needed a sanity check at this point because we're like, maybe we're not sensitive enough to detect the change. So I used the same method, the same analysis and everything in V1. And what you can see here is a tuning curve for V1 cell. And you can see that locomotion strongly affect the response there. And then we did that for in 2 animals and over 20 cells. So since these results are well established, we didn't feel the need to analyze as many animals. And what you can see here is that when the animal is running, the response go up to the roof. And when we compared the cumulative distribution of the locomotion modulation index for the primary visual cortex neuron against the collicular neurons, and you can see that here the median locomotion modulation index for the primary visual cortex is 0.29, which corresponds to an increase in 182%. So this is in sharp contrast to what we've observed in the superior colliculus, where the median modulation was around 10%. So taken together, these results agree with the literature, and like many other studies have shown that in V1, the response increase, even in the LGN as well. And while on the other end, the response are only mildly affected in the superior colliculus. So aside from affecting the amplitude, locomotion could affect other parameters, like, for example, selectivity. So we look at the response at the preferred direction, and we compare it also at the null direction, and we didn't see an obvious trend. We moved on to look at the global DSI, so that's looking at the tuning, how tightly tuned the cell is to a particular direction by calculating the vector sum normalized by the scalar sum. And we saw a mild decrease, but nothing significant. And also we looked at if one idea we had is that maybe the cell changed the preferred direction as the animal starts moving, but it's the same if the animal is stationary or running. So overall, the locomotion does not affect this selectivity of the cell in the superior colliculus. And then we wanted to see if there could be a difference between inhibitory and excitatory cell, because this could be hidden as we're looking at the overall population. So then we took some GAT2 Cree mice. So inhibitory cell can be identified in the SC by the expression of GAT2. So we took a GAT2 Cree mouse and crossed it with a reporter mouse. And then we had TD tomato expressed in the inhibitory cells. And what you can see here, so I injected still AAV GCAM in the SC, so all the cells can be green and only the inhibitory one are in red. And then we measured the same thing, stationary against running, and overall there was no significant change. And this also holds true when we're measuring the locomotion modulation index between the two populations. So overall, there's no difference between excitatory and inhibitory neuron in the SC. So aside from the visual response, locomotion could affect other parameters. So we wanted to take insight into the variability of the visual responses. And what you can see here from this example neuron, in D1, there's a much higher variability for the same presentation of the same stimulus. Like I think here we have up to 30 trials. And we compare that so then we measured the Fano factor. And we looked at the variability of the responses while the animal is stationary or running in DSC and in V1. And it's significantly different between V1 and DSC. So the response are more variable in the primary visual cortex. We also went to look at the spontaneous event in the superior colliculus and in the primary visual cortex. And same here in this example trace, you can see that there's very few spontaneous events in DSC, while there's tons of them occurring in D1. We even did the same comparison. So there's been some debate in the literature looking at effect of locomotion in dark or gray. So we did both condition, dark and gray for V1 and SC, and looking at spontaneous events. And you can see here that D1 has much more spontaneous event than the SC overall. So overall, in addition to being affected by locomotion, the collicular and the cortical cells, so like different response variability and different amount of spontaneous activity. So to summarize what I've shown you so far, locomotion in the superficial part of the SC has very low effect on response amplitude, no effect on preferred direction, and is not cell type dependent. We also see less spontaneous activity and less response variability. So with this, I'll wrap up quickly. So in V1, we have a lot of effect by locomotion. In the SC, very mild effect. And the next step for me is to look at the cells that project from the SC to the pulvinar to V1 and figure out if these cells, the wide field vertical cell, are affected by locomotion. And with this, I would like to thank you for your attention, my lab, JC's lab at the UVA, and I'll be happy to take any question.
Thank you, Elisa. That was a really nice talk. So let's see if we have questions. Okay. Yeah, so we have one question from Kara Weisman. This isn't my field, so apologies if it's a naive question or if I missed it. But did you say the mice were running at will versus you inducing them to run? If so,
they were allowed to run. So
okay, so at free will.
Yes.
So to say, okay. So there is a follow-up question. If so, why do you think locomotion is affecting the responses versus arousal stage causing both?
So when we use running, it's tightly linked to arousal. So it's almost that some people are able to like disentangle both, and you can do that when you correlate with pupil size, for example. But in this study, we just like consider locomotion and arousal as a similar event.
Okay. So we have another question from Claudio. How conserved is the selectivity of motion detection neurons in the superior colliculus from mouse to mouse?
So we have something coming up on this. So we're looking. So are we looking? Is the question about the distribution of the direction selectivity or the tightness of the tuning?
Yeah, maybe Claudio, you can clarify that. Tightness of the tuning.
Oh, so we're looking just at the topmost lamina, and here we have up to, like, depending on the study, we go like from 55 to 65% of cells that are above 0.25 global DSI. So they're pretty tightly tuned.
Okay. So yeah, I mean, we can have one last question, I think. How, so this is from Cyril Eleftheriou. How do you image the superior colliculus? Do you need to remove some area of the cortex? What objectives do you use?
So we only have access to roughly 10% of the surface of the SC, but the cortex is intact. So we just we push the transverse sinus forward, and then we can image that caudal medial part of the SC, but everything is intact.
Okay. Yeah, thank you again, Elise. That was a really nice talk. And we came to the end of our session. I'd like to thank all the speakers for the wonderful talks and also the attendees for their engagement and like very nice, excellent questions. Also, special thanks to our backend, Said, who's doing all the technical work. And thanks again, everyone. Have a nice evening or nice day. Bye.
Thank you. Thank you for hosting.
And this is the session on theory. And I'm happy to be moderating. I'm Beth Buffalo from the University of Washington. And I first want to introduce all of our speakers and panelists today. For this session, we'll first hear from In-Soo Hyun from Case Western Reserve University. Then we'll hear from Jeremy Magland, who's from the Flatiron Institute and the Simons Foundation. Then we'll hear from Stephanie Noble from Yale University. And then fourth will be Sridevi Sarma from Johns Hopkins University. And then finally, we'll hear from Daniel Fengon from Brown University. And then after all of the video presentations have been presented, then we'll all join back together and we'll have a time for question and answer. So please, as you're listening to the presentations, please feel free to use the chat to start putting your questions there. And then we'll all, as I said, get back together for a discussion after about 20 minutes or so of the presentations. All right, so with that, we'll go to the presentations.
Hi, my name is In-Soo Hyun, and I'm on the bioethics faculty at Case Western Reserve University School of Medicine and Harvard Medical School. I'm going to give you a short theory presentation today on human brain organoids and ethics. What are organoids? Organoids are complex 3D structures that are grown from human stem cells, either pluripotent or adult stem cells, that self-organize into various organ-specific cell types and culture. They can be made to model many different types of organ systems, including brain, liver, and airway, as you see in the pictures in the middle. And because they recapitulate very early organ development, they can be very useful as models for biological development and for the maintenance of human organs. And they're also incredibly useful for biomedical research and drug development. Now, among the different types of organoids, it seems that human brain organoids are particularly ethically sensitive. And it's because of this that my colleagues and I initiated this project, which is now Brain Initiative funded, called the Brainstorm Project, a collaborative approach to facilitating the neuroethics of bioengineered brain modeling research. I'm the PI. We also include researchers from Case Western Reserve University and leading brain organoid researchers from Harvard, the George Church Lab and Paula Arlada's lab, and from Stanford, Sergio Pasca's lab. What we discovered in the process of our 2-year project is that brain organoid research is rapidly evolving and it involves many components. We're going now from what we call brain organoids to brain assembloids. Brain organoids, as shown here from the Arlada lab, are small, uniform looking in structure, and as you can see, they're white. They look like little pieces of tapioca, and that's because they lack vascularization, and therefore they're smooth and round, and they typically model a particular cortical region, a particular region of the brain. There's no one single organoid model system grown from stem cells that can recapitulate all the various brain regions. To get all the various brain regions, you have to make what Sergio Pasca at Stanford calls an assembloid, which is where you put together various region-specific brain organoids, connect them together, and basically model in a little bit more realistic style the complex structure of the actual human brain. Now, what we've also discovered in this area of research, as we go from brain organoids to assembloids, more complex models, is the fact that we're talking about an extremely broad continuum of research activities. On the one hand, you have the kind of work that Paula Arlada is doing, which is to study natural human development. Here, the pace is very slow. It takes a long time for human brain organoids to develop, pretty much in gestational time. You have to culture brain organoids for a year or more to get the really complex cell types and the development that you might see in vivo. On the other end of the spectrum are engineering purposes or engineering uses of brain organoids. Nature and human development and study human development, but rather to make scalable tools for further study. So here the brain organoid itself is not maybe the object of study, but rather a tool to interrogate other scientific questions. And here there's a very heavy engineering component. Often you want to pair up your brain organoids or assembloids with other non-living, non-organic systems, devices, computers. So there's an enormous continuum and everything in between. So what we've realized is that we need to start thinking very seriously about bioengineering ethics as we get further to the right of the continuum toward bioengineered constructs, which don't recapitulate actual things in nature. We do need to think about what it means to have bioengineering ethical perspectives brought to bear. So looking ahead, what we've discovered is that brain organoid and assembly research is very rapidly advancing, and it represents a very broad continuum of activities. A lot of this research, I would say all of it, is flying under the radar because we're talking about institutional research where you're using established cell lines and it's all being done in vitro, and typically that's the kind of stem cell research that has the least amount of controversy traditionally, but that's changing now. We think ethicists and neuroscientists have to be working together to identify key ethical issues along the way, along with the technical challenges in real time that might affect the design of new experiments. So it's a complex area, it's growing. There's a lot of collaboration between engineers and basic scientists and biologists and geneticists and cell biologists, but we also need to bring ethicists into the mix early on in the experiment. So if you have any further questions, I'll be happy to chat with you. You can contact me by email at hms.harvard.edu. And I look forward to speaking with you in a breakout session. Thank you.
Hello, today I will be talking about Spike Forest, our interactive framework for spike sorting validation and analysis. Here's a very brief introduction to the problem of spike sorting. Extracellular probes are used to detect individual firing events from neurons that are in the vicinity of one or more electrode channels. Here's an example of the voltage trace for a single electrode. Each time a nearby neuron fires, we see a voltage drop, forming a spike waveform. Generally, we assume that the spike waveforms from the same neuron have generally the same shape. The goal of spike sorting is to identify or detect when these events occur, and then sort these events so that spikes from the same neuron are labeled in the same way. Unfortunately, there is little consensus about which spike sorters perform best in different experimental conditions. In fact, a lot of times, the choice of which software algorithm to use depends more on practical issues such as ease of installation rather than based on careful benchmarking. The purpose of our work is to prepare a collection of ground truth recordings from simulation and from real experiments where both intra and extracellular signals are acquired. We then automatically run multiple spike sorters on each sorting, and then compare the output spike trains with known ground truth in order to yield a matrix of accuracy metrics, which we then present on our interactive website. Our framework comprises 4 components. First, we have a Python package, including wrappers for 10 spike sorters. These are wrapped using Docker container recipes and can be run using either Docker or Singularity containers. Second, we have a database of ground truth electrophysiology recordings, some simulation, and some paired recordings. Third, we have an analysis pipeline for automatically running the sorters on the recordings. And finally, we host an interactive live updating website where we post the results. Here's the homepage of the Spike Forest website. The rows of the main result table represent different study sets of recordings, and the columns represent 10 different spike sorters. The table reports the average accuracy of spike sorting over ground truth units in each study set, where the average is taken over all ground truth units having SNR above a particular user-specified threshold. You can also switch between reporting accuracy, precision, and recall. You can drill down by clicking on rows of the table, expanding study sets into studies. Each study consists of recordings that were all acquired or generated using similar parameters. You can view details for individual recordings within a particular study. The website also enables further detailed exploration of results. For example, here are all the ground truth units for a simulation with reported accuracy and SNR for each unit. If you click on one of the markers, you can see the corresponding some corresponding spike waveforms associated with that unit broken down into correctly and incorrectly sorted events. Sometimes spike sorters fail or crash during the run. The website reports those crashes, and you can even see the console output, which can be helpful for diagnosing software bugs. In summary, we have a website and a Python package for validating spike sorting algorithms on ground truth datasets. We have wrapped several algorithms in a common framework, and we have a database of registered recordings with ground truth. All this software is open source, and our results are independently repeatable. We are working on an integration between web-based and desktop tools for analysis and visualization, and we are accepting contributions and pull requests to this open source project. I'd like to thank my collaborators and all those who have helped by contributing ground truth datasets and algorithms.
Today I'm going to introduce a new tool called the Constrained Network-Based Statistic. So this is a tool developed for functional connectivity, which is how we commonly measure associations between brain areas using functional magnetic resonance imaging. This is really commonly used to understand the intrinsic organization of the human brain. One of the most common workhorses for neuroimaging is multiple testing based inference. And typical testing procedures can be very conservative. These sorts of analyses can involve tens of thousands of different variables. So it's really important to gain as much power as possible. And also effect sizes can be really small in fMRI. Many different recent studies have highlighted this. So it's really important that we try to maximize power as much as possible. One common way that we try to maximize power is by grouping things within contiguous clusters. So you might think of cluster-based inference in activation mapping or the network-based statistic in functional connectivity. So this pools information across the local neighborhood. However, statistics have to have contiguous edges. Things have to be right next to each other, even though we know that there are widespread networks that sometimes are not detected in small local clusters. And statistics are also treated as identically distributed across the brain. Although we know that different parts of the brain, let's say from visual cortex to like prefrontal cortex, or areas that are around like CSF or not, have very different statistical properties. So our goal is to build and benchmark a procedure that addresses these limitations. So that's the CNBS, the Constrained Network-Based Statistic. This has a couple main features that I'd like to highlight. One is that there's no contiguity requirement. We actually use some predefined large-scale networks defined in a healthy controlled data at Yale to perform this inference. And here I'm showing you the 10 networks as developed, similar to what's reported in Shen et al. And the figures adapted from Finn et al., both here at Yale. And it also allows us to estimate statistical properties separately for each network before doing the correction. So we take into consideration the fact that these different networks can have very different properties. Some key details that I'm just going to brush through in the interest of time is that we start with a partition. That's the one that I showed you. We have some graph with some weights. It can be either a T statistic or a Z statistic or really anything. We apply that partition to the graph that has these test statistic weights, and we estimate a CNBS statistic for each network, which is really the average of the weights within the network. Then we use the permutation within each network to estimate a p-value and then do multiple comparison correction. So first, I'd like to show you that these results seem to make sense, or rather, the use of these large distributed networks seems to make sense. So here, this was repeated in several different tasks in the HCP data. I'm just going to focus on the average task. So when we organize edges within these predefined networks, they seem to show similar values, supporting the idea that these might be reasonable. These might be a reasonable level to make inference. I'd also like to highlight that a lot of effect sizes, or most effect sizes, tend to be below medium, which will be important for the next part, which is to talk about whether CNBS actually seems to be useful. So here, I'm just going to highlight the threshold-free NBS results. We examined standard and threshold-free as representing some typical procedures, but they perform similarly, and threshold-free does a little better. So what I want to show you here is that at a large effect size for edges, they tend to detect effects at about the same level. Of course, CNBS has more variance because it doesn't have that much spatial specificity. But when we look at small effect sizes, that's a medium effect size. And now when we look at small effect sizes, we get much better detection with CNBS. And at the network level, we actually tend to get much, much greater detection because CNBS is tailored for making network level inferences. All right, so quick summary. CNBS seems to address some of these limitations of modern commonly used multiple testing procedures. We tend to observe better power for most effects, although there's a lot of edge level variability. There's not a lot of spatial specificity with this approach. So if you're willing to give some of that up for better power, then this might be the approach for you. The spatial distribution of these effects is consistent with the predefined networks for CNBS, which support the idea that this might be a valid level of inference. So I'd like to thank the lab that I'm doing my postdoc in, that's with Dustin Steinost, HCP data used for this analysis, and my source of funding, and some collaborators. And I'd just like to give a quick shout out to the BISWeb project. We have a lot of really great tools available in a web-based interface for doing fMRI analysis and visualization. And it's a really neat project, no installation or downloads necessary. So I recommend you check it out. Thank you.
Hi, my name is Sri-Sara, and I'll be talking about uncovering principles of how cortical regions interact to generate behaviors using dynamical systems modeling. So most neuroscientists ask a basic question, which are, how do brain regions interact to govern behaviors? A challenge in this is that despite how well designed the experiment might be, subjects can execute very similar behaviors, but the neural activity recorded across these subjects may differ even if they're taken from the same region. I'm going to walk through this with an example in sensory motor control. We're going to try to address how do premotor and primary motor regions interact to drive movements. We're going to test our tools using an experimental setup where 2 non-human primates were trained on a reach to grasp task in Dr. Mark Schieper's lab at the University of Rochester. So in each trial, each monkey was asked to reach and manipulate one of these 4 objects. A trial would start with the animal holding on a center object. An LED cue would turn on to indicate which of the 4 objects to move and manipulate. And then once they initiate movement, they reach and they manipulate the object. While the primates were executing these movements, Dr. Schieper recorded from the primary motor and premotor areas with floating microarrays, and that captured neuronal activity, and simultaneously we were able to get 3D kinematic trajectories with sensors on each arm and finger. So what's interesting is in this experiment, the monkeys executed very similar behaviors, which you're going to see in the top panel. I'll play the cylinder for you. But the neural activity in both premotor and motor cortex, and one in blue, premotor in green, across the 2 monkeys differed despite the fact that the movements looked very similar. You see this also in the sphere. Now they start moving. Movements look extremely similar, but their neural activities differ. This makes it really difficult to answer the question, what can we learn across multi-subject data? If the cortical activity looks different during similar behaviors, how do you find correlations between the two? In fact, in this data set, when you look at how the cortical responses differ as kinematics differ, there's no real relationship. So our hypothesis is that it's not about the readouts, the neural recordings, that should correlate to behavior, but rather it's the internal dynamics of the cortical activity. So how populations in PM and M1 interact within structure and across sectors, that does have a linear relationship with the kinematics. So we're going to use dynamical systems models to quantify these internal dynamics. So this is a modeling framework where neural firing rates that are displayed in a state space. So here's an example of 3 neurons. And the firing rate trajectories x of t start as an initial condition and can be driven by a cue and movement onset, and the trajectory in the neural state space then influences the kinematics in the physical space. And you can write down the dynamical system equations that govern this. This is a simple linear time invariant model, which is quite widely used in this field. And in this case, we're going to use the LED cue and the movement onset as the inputs, driving both the neural state, x of t, that then in turn drives the kinematics. So this is a block diagram of our system, and this is a schematic. Now, once you have this model, you can look at the state solution x of t, which is a function of A and B, and quantify dynamics. But before I get there, I just want to show that this type of LTI model can accurately reconstruct activity in both the monkeys, if you build monkey-specific models. The dynamics you can infer from these models include which region is driving overall cortical energy, M1 or PM. You can also ask the question, do populations within region interact more, or do they tend to interact more across regions, again, over time? And it turns out that these dynamics, both cortical driver and the interaction dynamics, have a linear relationship with the kinematics that we didn't see looking at raw readouts. So what I'll be talking about today and discussing in the panel are the utilities of dynamical systems models and how they can answer very important challenging questions in neuroscience.
Good afternoon. I'm Daniel Fengone. I'm an F32 fellow at Brown University. And today I'm excited to share some of our ongoing work on auditory reliant BCIs for individuals with tetraplegia and severe motor impairments. Brain-computer interfaces have been quite successful in enabling communication and effector control in individuals with severe paralysis and tetraplegia. And BCIs are able to decode, using BCIs, one is able to decode the neural signals into device control signals in order to control an effector, such as a computer cursor or a robotic arm. In this example, the user is utilizing the intracortical BCI to communicate using a virtual keyboard. However, most of the BCIs that are out there rely on the user's visual abilities to fixate on a screen for extended periods of time in order to perform the IBCI tasks. However, this might not necessarily be successful at all times because visual-based BCI can be challenging for individuals in late-stage ALS where visual movements are challenging, as well as other forms of traumatic brain injuries, patients who might potentially benefit from a BCI, but no functional vision or lack or little control of visual movements might impair their abilities to utilize a BCI. Therefore, an auditory-based BCI has some promise, is promising because it utilizes another unused mode of feedback for the IBCI user. Also, it remains to be seen whether long-term usage and performance can be improved by having multiple modes of feedback. In this example shown on the right, you can see the standard task of an IBCI user navigating a cursor from the center of the screen to the cued target shown in red, and the cursor trajectories are shown on the right. So the IBCI user has to estimate the directional spatial information and move in the direction of the cued target. So the first question we wanted to ask was, how do you provide spatial information via auditory signals to the IBCI user? So for this, we use something known as HRTFs, or head response transfer functions. And the basic principle of HRTFs is that the location of a sound source can be identified by its azimuth and elevation. So by shown graphically here by each of the cyan circles correspond to a particular HRTF that corresponds to a specific azimuth and elevation. So any source, any sound source can be modulated to appear from one of these directions by convolving with the head response transfer functions. So we first went to estimate how good these HRTFs are at estimating, users are at estimating direction. So we tested this in healthy subjects and in the IBCI user. So what's plotted on the horizontal axis is the presented target, and on the vertical axis is the estimated target, the response from the user. And what we find was that both in the healthy subjects and the IBCI user, mean localization accuracy was about over 90%. And the size of the circles correspond to the frequency of responses. So we see that pretty good response was seen from both healthy subjects and IBCI user. And convinced by these findings, we implemented an IBCI task where the objective of the IBCI user was to navigate the cursor shown in white to the target that was cued. So in this case, it's a virtual 3D room, and each of the targets radially arranged shown in blue. And one of these targets would be presented over headphones as the cued target using the HRTFs. And the objective of the user, IBCI user, is to navigate the cursor to the cued target and using auditory feedback. We use two 96-channel microelectrode arrays that was implanted in the precentral gyrus to record motor cortical activity in the IBCI user, in this case, a 35-year-old man with C4 spinal cord injury. And we decode kinematic information to perform these cursor movements. And in this case, a Kalman filter was utilized to decode the movements. But in addition to the cursor velocity that was updated, the HRTF database is also updated to present an updated auditory feedback to the user using headphones. And here is an example of the IBCI user navigating the cursor to the cued target. Once the target is correct, it lights up in green. So once again, target has been cued through headphones, and the user, when navigating to the right target, it turns green. And if it goes wrong, it turns red. So when looking at the average neurocursor kinematics of this task, what we find is that the user is able to navigate to these targets with high reliability, with success rate increasing from 35% to 62%, suggesting some form of learning happening for this task. This demonstrates that using these tools that the IBCI user is able to accurately identify cued targets, but also suggests that these tools could be further developed to develop advanced applications like spellers and display icons. And with that, I would like to thank my team, the BrainGate team at Brown, MGH, and the VA, headed by Dr. Lee Hochberg. And also I would like to thank the BRAIN Initiative for the F32 funds that have provided the research support for this work. Thank you for your attention.
Great. So I had the chance to applaud for all the talks. Thank you all. Those were a really interesting series of presentations. So I'd like to invite all the speakers if they'd like to turn their cameras on, and we'll start our discussion. And anyone who's participating, please feel free to add questions in the chat box, and I'll take those as we go along. But I'll start out sort of taking the presentations in turn. Maybe I'll start with Insoo. Really exciting stuff about the organoids, and I had not heard about sort of pulling them together into these assembloids. And you mentioned that they really start to present certain bioengineering ethical considerations. And I wondered if you could say a little bit more about that and kind of where you're thinking those considerations come in, maybe along that continuum that you presented between development and engineering aspects.
Sure, Elizabeth, I'll be happy to do so. I wanted to, before I answer your question, draw people's attention to, I think it's the current issue of Nature. There's a news story there about organoids and consciousness, and it quotes me and many other people that I work with in that news story. That seems to be what most people are associate as the immediate ethical issues around brain organoid research. But there could be the possibility of the emergence of consciousness. We don't find that that's actually quite really even on the near-term horizon for many reasons. And so the kind of bioengineering work that I think are really kind of more at the immediate forefront of our thinking is the assembloid work, as you mentioned. Now, assembloids could either be different cortical regions put together, or it could be a particular cortical region, let's say a visual or some other region that's linked with other organoids. So Sergio Pasca has been doing work where he links a cortical organoid to spinal cord organoid to muscle organoid. When you start making these like linked organoids of multiple types that are interactive, we're not saying that they're conscious yet, but there's some question about what are the limits of how complex you can make these linked systems. So I think that the bioengineering ethics issue is about what should you build and how far should you go in building these, which then raises questions about who should review this work, because it's not a full human subject. It's not, purely in the purview of the Stem Cell Research Oversight Committee. It's not yet animal research. That's kind of an interesting area for further discussion and exploration. So the bioengineering issues come up where there are lots of really interesting combinations you could start making between brain organoid and some other computer system, robotics, brain organoid. So we're really on the far right side of that continuum. Like they want to create many of these quickly, link them up with other things to then interrogate other scientific questions that are simply not reducible to wanting to learn about human brain development. It might be something more about, learning about how brains can signal to muscle or something a little bit more interactive. So the bioengineering ethics component of that is really kind of the area that we're delving into now, which is you can't simply take traditional bioethics, which has to do with human subjects research or even animal research. You can't really use a lot of that in this space. There's probably a lot of really interesting, useful material in ethics from engineering ethics, but typically they work with non-living matter or even computer engineering ethics, computer science. So there has to be some interesting combination of the two, of like bioscience, bioethical issues, combined with the engineering and building component of it. So that's really kind of the new area. I know that the Nature news article kind of focuses on consciousness and how it might naturally arise in organoid models. I think that another fascinating question is just, whether or not the organoid model seems to be really similar to human brain development and even fetal brain development is kind of doesn't fully capture the concern that we might have where you have a brain organoid system that doesn't really look very human or natural, but it starts to kind of cross over a little bit more to what I would call like artificial intelligence or computer-based intelligence, but it's like human neural based. It's a strange combo between computer science, and neurobiology. And that may look nothing like normal human consciousness, but it is something that we might worry about in terms of, is there an emergent property there that was a little bit hard to predict and that could raise ethical concerns? So like general emergent properties is, I think, what we're after. Thank you.
Interesting. Yeah. So emergent properties that we may not be thinking of that, apart from consciousness, apart from pain and suffering, which are things we think about around animal work.
Right, and the emergent properties question comes up in computer science as well, right?
Yeah, very interesting. Thank you. All right, so I'll ask another question for Jeremy. So thanks for your presentation. This is work that we've been really paying attention to because I do work in neurophysiology. We have to deal with a lot of spike sorting. I guess I have a couple of questions. So one has to do with kind of, are there big conceptual differences that you see across the algorithms? And is that something that is easy to describe? And then kind of a second question is, it looks like, a lot of the work is focused on data sets where you have both ground truth, the intracellular recording and the extracellular recording. But it seems like there are also lots of questions about, if you have different kinds of electrodes, maybe that are used more commonly in humans or non-human primates, where you wouldn't be able to have the ground truth. And if you can sort of extend the principles of what you're getting from, the original data sets into these other kinds of recordings that have very different electrodes with very different properties.
Yeah, great questions. I'll answer your second one first. Yeah, it's a very good point that the data sets that we do have ground truth for, they may or may not have the same properties, or may not have been collected in the same way as data that a particular group has. And so, yeah, I do think it's important that we sort of extend our validation techniques to operate in a regime where ground truth is not known, where we don't know exactly when the neurons are firing. And we've done some work recently on that, where we have collected not ground truth data, but we've sort of started to accumulate curated data sets where the people doing the curation have a very high confidence in particular units. Then you can sort of, obviously the ones that they have the most confidence are the units with the highest SNR, but there's other things that you can do, like artificially amplify the noise, or do other things that make the spike sorter, make it more difficult for the spike sorters to get the right answer. So that's sort of one of the new kind of directions we're taking, and that will allow us to get a better variety of data into the system. And then regarding differences in algorithm, it's really true that one thing that's pretty striking is that the different spike sorters don't agree very well with each other. Maybe they agree for the most obvious units, and that's actually still something that is not completely settled, whether for the high SNR units that there's agreement across the sorters. But yeah, especially for when you get lower amplitude spikes, there's big differences between the sorters, and it does have to do with fundamental differences in the algorithms, whether they use clustering, whether they use template matching, things like that. So I would say we're sort of at the very beginning stages of trying to sort out all of what's going on. So it's just our first attempt.
That's great. Yeah, I can tell it's going to be a very useful website and really exciting work. We did have a question come in the chat about spike sorting. I don't know if people are able to unmute themselves. This is from Alex Burton. If not, I can read his question, his or her. Sorry, I don't know, Alex. So the question is, oh, looks like they're coming on. Alex, would you like to unmute?
Oh, he or she says they have no mic.
Oh, okay. So I'll ask the question. So the question is, let's see, we see a movement into smaller wireless implantable recording devices that require low power consumption. Do these spike sorting algorithms require different computation powers, and will it be beneficial to compare the accuracy and precision of spike detection as well as power consumption of each algorithm for these wireless systems?
I think that's a great question. I don't think I'm the one equipped to sort of answer, but certainly we do want to have the choice of spike sorter and parameters is certainly going to want to be dependent on the type of data that's collected. And there's a lot of different factors involved with that. I don't know if anybody else has insights from the panel.
No, it's a good question, because yeah, a lot of things we're going to want to be doing is, it would involve online spike sorting.
Mm-hmm.
And so I guess that's where maybe that question would.
Yeah, online, most of the spike sorters that are generally available take the whole data set in and do, several passes through the data. So it's not so easy to adapt them to be kind of spike sorting on the fly. But yeah, that's a good question for the future.
Great. Okay, I can move along, but I'm going to pause and see if any of the panelists have questions for each other that they'd like to ask.
I kind of have a naive question for Jeremy. I don't know much about spike sorting algorithms beyond concept, but I have a postdoc in my lab right now who did his PhD, with another PI in Arizona, and he worked on spike sorting. And I thought the idea was interesting, which was using the idea of the spatial location of the neurons right? Which is a latent variable. You don't know where the neurons are in space, but you know, I think he had sort of a methodology where he used some estimation to estimate the latent variables to see which one was most consistent with the data. So it's not just number of neurons, but where can they be placed spatially so that you give rise with high probability to the observations that you've seen from the actual electrode. I'm just curious. I've never seen that before. I thought it was interesting. Are there more people working on that? That's much more computationally intensive. So it'd be harder to move online, but yeah.
Yeah, I think there's advantages to using the knowledge that each neuron has a spatial location in 3D. There is one algorithm I'll just tell you about. It's called herding spikes, and it's from the T.S. Hennig University of Edinburgh, that does use the spatial location, an estimated spatial location for the neurons as the features, as opposed to what is typically done is you take the waveform shape of the spike and compute like principal component features of the shape. So it is a different approach when you have like an electrode array and you're estimating the kind of centroid location of them. And I do think, yeah, it depends on the application, but that has been studied to some extent, and there are advantages of that.
Great, thanks. I'll ask a question for Stephanie. I thought your work on the sort of new way of assessing functional connectivity looked really interesting and powerful. And I guess I had a couple of questions. One was about thinking about it in relationship to Sri's talk about kind of the individual variability. And just this is a naive question about whether the analysis that you're doing with fMRI is cross subjects, or if it's something that is at the individual level. And then the second question had to do with whether this kind of statistical tool might be useful when we're looking at large-scale neural recordings of single units or the LFP. So thinking about taking it to other modalities besides fMRI.
Those are both excellent questions. Oh, the second one I think is particularly intriguing, and it's one that I probably don't have too much insight into, except I will say that I see in a lot of areas in complex biological systems, we tend to treat or information is commonly treated in a univariate fashion or like a mass univariate fashion. I'm thinking of GWAS studies as well. Whereas if we leverage the clear dependence between a lot of these variables, you can increase power. So unfortunately, I don't think I can talk much more specifically than that. But I think I could say that it may be worth considering using predefined information about the structure of dependence between variables to improve our inferences, to improve power at least. For the first question, leveraging individual variability, this particular method is based on a predefined network or a predefined set of networks. So we're not actually estimating things or estimating the network structure from the data itself. And unfortunately, there is a lot of really interesting individual variability. And Todd Constable, who is my PhD advisor, had worked with Merve Salehi on even showing that individuals may have different parcellations of the brain. And also nodes may be assigned to different networks depending on the individual, which I think is really fascinating. So that is ongoing work. It's not integrated into this approach right now. And part of that is because we may borrow power and stability by using larger data sets than just at the individual level. And some of my prior work has shown that test-retest reliability can be quite low, suggesting that it can be very hard to make stable or accurate inferences at the individual level in fMRI. So it could be very helpful to use this prior information. But yeah, it's a balancing act, how much we can integrate individual level information and group level information. So yeah, I think those are really interesting points and great future directions. Thank you.
Yeah, great. Thank you, Stephanie. So I want to make sure I get to have everyone speak a little bit. I think we only have 5 more minutes, but I do have questions for both Sri and Daniel. But jump in if other people have questions as well. Because Sri, I thought your work was really interesting, and at the end you mentioned thinking about the utility of these dynamical systems models, perhaps for other questions in neuroscience. And so I just invite you to speculate on that a little bit.
Yeah, so this is the work of one of my, she's about to graduate, Reina DeLeo, PhD candidate here in neuroscience. So yeah, so when the dynamical systems models kind of emerged about 10, 15 years ago, Shenoy, Churchland started talking about state space and so forth. And by the time it got to more recent days, you know, my student Bill Bees starts reconstructing data, and the neuroscientists on our panel like, well, okay, great, but what else is the utility of this model? And that's why we went down this path. So one of the things, as I very briefly said in that 5-minute talk, is about how when you build a model of a dynamical process, you can kind of uncover the hood and look at natural frequencies, you can look at stability, like all these properties that you don't necessarily glean from one realization, like an observation of the firing rate or that. So that's one. So what can you do with that in the context of neuroscience? Well, with this work with the sensory motor control, what she was able to show is from the model, you don't get this from data, to say, okay, throughout movement, we can actually say that when is premotor driving M1 activity, all right, meaning when is PM activity, kind of this feed-forward notion that's conventional thinking. When you want to move, premotor activates, and that dictates what's happening in motor, that goes down the spinal cord and so forth. That's kind of conventional. Well, 3 out of the 4 tasks, when we look at the model, showed that type of progression, you know, in terms of driver dynamics. But there was one task that was complete reverse. M1 drove PM, going backwards, which may or may not be surprising because there are reciprocal connections. But that one task was a task of rotating a sphere, which was very different from the other, which is a rotational movement. So here's a testable prediction now that the model brought forth that now you, for example, Dr. Buffalo, can test, which is what if you take various types of motions, reach and grasp, where you're rotating versus when it's just translational or something. Our prediction would say motor cortex will drive PM on the rotational movements, but not in the translational movements. We could be totally wrong, but these are sort of testable predictions now that can, you know, the neurophysiologists can go and figure out, which I am very excited about, because I do think being a modeling person, it has to go beyond reconstruction. It has to, right? Yeah, thank you.
Very exciting. Yeah, it's always great when you see these examples of where there's this prediction and then we can go and actually do the experiment and see how that can inform the model as we go back. That's great. Thank you. All right, so Daniel, I'll move to you. Really exciting stuff on the BCIs. And I love the idea of moving it into a different modality. I just had some sort of basic questions about how it actually works. So they're seeing the visual feedback while they're also getting auditory feedback. And then I guess if that's true, I guess the question is, how much do they need that visual feedback? And can you make it purely auditory?
Yeah, great question. So when most of the current work is mostly visual, it kind of relies on the person fixating on a screen. And so the reason we went down this path was to see if we could utilize some other forms of modality. So in the current task, there is both visual and auditory feedback. And part of the reason for that is also that the user at this point has experienced doing this task using the visual feedback, and sort of building off of that, rather than giving a purely auditory task where they're not used to the idea of how do you, what is motor intention, how do you convey that kind of spatial information through headphones. There was a certain amount of learning that they had to sort of grasp to get to the point where they're able to now utilize these spatial auditory information to do the task in the same way. So ongoing work right now is to completely sort of make a purely auditory version of this task, where, you know, we take away the screen completely and we have this 3-dimensional auditory space to play around with. You know, this technology that we're using is being used a lot in the blindness literature, where they're building a lot of interfaces where it's based on this HRTFs, and it's heavily used in video games and things like that. But bringing it to the BCI world, the biggest challenge, of course, is that we need them to still perform the motor intention of movement, and sort of they are still utilizing that feedback to gain something about their environment that might be new to them if they're not used to doing a task in a purely auditory space. So we're working towards it, to making it a completely auditory based BCI, which is part of the ongoing work.
Very cool. Also, one more question. So do you think that once they are fully trained, or once they learn to do use it with just the auditory feedback, will you have overlap in terms of the neural signals that would move the cursor in the visual space and the auditory space?
Yeah, no, great question. So we're now doing the part of the testing that we're doing now is to test auditory only, audio, visual, and visual, sort of having three paradigms that is gauging the things. The good thing, however, is that we're still recording from the motor cortex. We're not recording from the sensory areas, at least now. And so the motor intention and the motor acts should still be the same. Shouldn't be any overlap between the signals, but it is definitely a valid question that all of the sensory motor integration that might happen between visual and motor areas, as opposed to auditory and motor, which is, there's a lot of literature showing that there's quite a lot of mapping between auditory and motor regions. It'll be interesting to see if we get some increased activation, or whether one form of feedback enables us to decode better, for instance. So it's an open question right now, but we're collecting some data, and hopefully it kind of leads in that direction.
Great. All right. Well, I think there's a lot more we could keep talking about, but I think we have to end the discussion at this time. So I want to thank you all again for excellent presentations and really a nice discussion, and especially thanks to the trainees for participating in this and for your great work. So thank you all.
Thank you.
Thank you, Beth, for excellent moderation.
Oh, you're welcome. It was really fun hearing about all your work.
Thank you. So maybe there's breakout sessions, or no? Is this, or this is it?
I think this is all we get. I think this is all we get.
Okay, sorry. I thought I heard, like, when I came in late and I heard breakout sessions. Like, okay, great. Okay.
No,
Thank you.
so you're all set. Thank you all.
Nice
all right. Thank you very much.
Panel of NeuroMatch. This conference, if you're not aware, has been put on by a lot of volunteers around the world. It's a very cool sort of grassroots international neuroscience conference, which, if you've had the pleasure of being in any of the panels, has been going, I think, really well, despite kind of the chaos behind the scenes. This evening, we have the pleasure of welcoming some really awesome people working on the cutting edge of neuroprosthetics and neurotechnology, who are not just creating innovative technology, but inventing sort of the next wave of consumer and commercial medical devices. So with that, I'd like to turn it over to Dr. Milton Morris, who is the CEO and president of Neuro-Medical. He's previously been at Cyberonics, at Biogen Scientifics, at Interpulse Corporation, at kind of the who's who of implantable medical devices. And so I'm really excited to hear about the work that they're working on in Neuro.
Hey, thank you, Deb, and thanks for having me join here, and thanks for putting me in the who's who. I wasn't sure I was part of that group. Just for time's sake, I know we're time bound here. I'm going to try to fly through a few slides that share with you the journey that we're on now in pioneering ultra miniaturized implantable medical devices, and in an attempt to bring the promise of neuromodulation to the masses of people who may not be comfortable with what is currently third line solutions that come in the form of implantable pulse generators and leads, which require blunt dissection, tunneling, surgical battery replacement, as well as operating room and ambulatory surgery center settings for their implantation. So the benefits of our technology, which is a technology that was born out of Stanford University, wholly owned and I should say wholly or exclusively licensed in all fields of use, as well as some developing wholly owned intellectual property we'll talk about later. is this technology called midfield powering that allows for this ultra miniaturization of devices that we believe generate benefits that are both obvious and immediately observable to patients, physicians, and payers. It's at least our hypothesis, and we'll let you know how things are going along the way. But if we've got our hypothesis right, we believe that we have the form factor and the system that would allow millions of patients who are sitting on the bench, not well managed by drugs and more conservative therapy, to come off the bench for a solution like this one. A solution that's minimally invasive, can be placed using a modified Seldinger approach or an introducer dilator directly to the site of neuromodulation care. Can, in the case of, excuse me, in the case of sacral nerve stimulation, which is where we're starting, have the protection of the skeleton, which is the sacral bony structure that protects the device and leaves it in place. And once evacuating this device after implantation, leaves a little more than a millimeter size freckle, if that, versus what you get on the cosmetic side in other cases. Additionally, it is a local anesthetic that can be done in an in-office setting and just is far more appealing from the market research that we've done. Just really quickly, you know, when you're pioneering or bringing forward technology, you need a place to do it. And we're a San Jose-based company. We've got general and admin, namely myself, living in Houston and in San Jose, as it turns out. Series B company, clinical stage. I'm going to share just briefly what we're doing on the clinical side. We are out raising money, as we always are. And in an attempt to bring this to the marketplace through a Series C raise and the completion of our pivotal clinical trial called the SAMS UUI clinical trial. We are a platform-based company, so we'll go after a number of verticals. In other words, a number of indications that we can apply this technology to. We love sacral nerve stimulation. I'm going to tell you why in just a second. And then this platform expansion, for the moment, happens to be pain, where we've got a 510(k) submission into the FDA. So why sacral nerve stimulation? Boy, one nerve target, one product, which has already been developed through the previous spend in our company, gives us an opportunity to get after so many different indications, many of which in this lower right-hand corner are already pioneered through the great stewardship of Medtronic as it relates to establishing a marketplace, reimbursement, trained physicians, referral patterns, et cetera. But still some unmet needs that we can address, and then an opportunity to grow and expand outside of these near-term indications. So one nerve target, one implant, one product development design cycle, then you, as a platform, turn into more of a clinical stage company, and you progress from there. I don't want to show you this video because it will take a little bit of time, but just to kind of keep pushing forward here, not all of these indications are the same as it relates to maturity. So we talked about how these guys on the right are already in the marketplace with reimbursement and well-developed, and an efficacy level on the therapy side that's already been established. We have a better system, at least that's what we think, something that's more amenable to consumption by a larger group of patients. And so it's not for us about pioneering new therapies, it's about bringing established therapies to a much larger population of people. Talked about this already. This is how we figure out where we're going to go. We're not the Stanford Biodesign where you shadow a physician and figure out what unmet needs that physician has, and then you back out of that and find a great optimal solution for that unmet need. No, we've got a great solution, and we then go cherry pick indications, and we're not bashful about that. But we have a real solid team that knows how to commercialize and bring things into the market, and that's what we bring forward as a value proposition to our investors and to patients and physicians. Won't belabor the point here, but we are focused on OAB, as I mentioned earlier, large addressable markets on the OAB side and also on the incontinence side of the space. Lots of people struggling with these diseases. These are secrets. People don't talk about them, don't want you to know about them, but they're getting crushed. These people have sexual dysfunction, intimacy problems, low self-esteem. It's a real debilitating condition. You're paralyzed by it. People try to treat themselves with pads and adult diapers, a growing $300 million a year market in and of itself. So these people are used to wearing something to manage their symptoms. We're going to ask them to wear something slightly different and give them their freedom back, which freedom from this debilitating condition and freedom from a kind of liberating perspective, self-liberating perspective, in that they've got control over the delivery of this system, of this therapy. So we did do some third-party market research. I'm not going to spend a ton of time here, but it did suggest that people would prefer a system like ours, which is a wearable system. And I do want to just back up really quickly now that I think about it. Sorry for going a little bit out of order here, but I wanted to just share with you what this system will look like for a user. Again, most of the people reaching for this therapy are women. 90% men get caught up in other conditions that get treated, but it's a 50-50 problem as it relates to urge urinary incontinence and an overactive bladder. But we have an external device which can power a miniaturized implant, and that external device fits in the base layer of clothing and helps us to keep this person's secret. They don't want people to know about their condition, and they're used to using wearables. And so that's what I meant by the system. So we power it externally. It allows us to move the battery out of the implanted pulse generator, which allows us to dramatically shrink the size of the implant itself. And for on-demand, non-life sustaining applications, this is a solution that patients have actually said they prefer overwhelmingly. And if we were able to actually use it in an intermittent fashion, meaning that if I used it for say 2 hours a day, but I got the benefits of non or reduced symptomology throughout the day, they would overwhelmingly prefer this solution over the incumbent products, which are the fully implanted pulse generator and lead concepts. We've done now market research on the survey side too, just kind of increasing the numbers here. You can see 105 patients, and you can see where they're preferring our system 4-to-1 over even the rechargeable versions of SNS. They're preferring us even over the tibial nerve versions of the chronic implanted tibial nerve stimulation versions of neuromodulation. If you're going to bring something to the market, it does need to be protected. So we do have a lot of intellectual property, as I mentioned earlier. The technologies from Stanford, mentioned that earlier, up until through the last probably 5 decades, we've been using near-field coupling to talk to and empower implanted devices. And we tell physicians not to implant them more than 3 centimeters beneath the skin. Otherwise, we can't talk to them or power them. What midfield powering offers is the ability, it's a reoptimization of one of Maxwell's equations. It's all in the literature. This is nothing actually that is not spoken in peer review form, and allows us to create these standing waves, evanescent fields on the surface of the body that add constructively to create propagating modes deep within tissue, 14 centimeters and beyond. So we're able to actually power these ultra miniaturized devices, and we can actually put different tissue electrode interfaces on this receiving element for various applications. We're also able to steer and beamform this propagating wavefront, and it's designed through the dielectric properties of each layer of tissue that we encounter. This just gives you a sense for the size. It is a revolutionary thing, not an evolutionary thing. We're 75 times smaller than the nearest competitor here, which is Nalu doing pain. Micro, which was just released by Medtronic at 3 cubic centimeters. We're at 0.02 cubic centimeters as it relates to the pulse generator. This is using standard construction techniques, safety and reliability techniques, hermetically sealed electronics, feed-throughs, all of that kind of technology that's been used to and shown to be reliable through the years. Talked about IP already. We did an acute clinical trial. It's in the literature now, just showing the implant procedure, the explant procedure, as well as the powering, and already published, leverage that to close out our Series B financing. Usually in these kinds of startup companies, you close out your round with a value inflection, and for medical devices, it tends to be around data. We are now launching well, we've already launched our seamless pivotal trial. It's a two-staged single IDE pivotal trial. The first phase, we're going to learn an awful lot. It's our first real chronic experience in up to 40 patients. We'll confirm the system performance, evaluate patient compliance, determine daily stimulation duration. Happy to report 2 hours a day stimulation is doing awesome for our patient population. We're more than halfway enrolled here, and patients are having their lives changed. There's no other way of commenting about that. 100% of them are responding to intermittent stimulation, which is great. Phase 2 will be the pivotal trial that we'll submit to the FDA for FDA approval. And we'll also submit a portion of that data for CE mark approval as well. So that's what's happening for us in a nutshell. We've got a great team here, people with deep experiences in miniaturization, neuromodulation, and at small companies and also large. We also have to have some sort of academic and physician support for what we do. We're happy to have Ash Sharan on our SAB. Ash was a past North American Neuromodulation Society president. Bertio Block's a power user of the InterStim and Axonics SNS device. Craig Commoner from Stanford is as well. And Steven Siegel is our PI for the SANS UUI clinical trial. We're really happy to have him. All this has some level of basic mechanisms associated with them, and Chet DeGroat really pioneered most of that micturition system in cats, believe it or not, as a model. So wonder how he made that connection, humans to cats, but you did a good job there. Just wrapping it up, great team, real good history of bringing things forward. We do love pelvic health, rapidly growing market, well suited, cherry picked for our solution. We do like midfield powering, and the Stanford license allows us to use it in many different fields, in all fields of use. And we believe we're going to be disruptive and upstream in the treatment algorithm for most current canon lead technologies in their applications, though we will steer clear of things that are life-sustaining, like pacemakers and implantable defibrillators. Just not a great match for us. Our rights are exclusive, as we talked about before. You got to protect your rights if you want to commercialize and be successful. And we are a platform technology. So with that, I'm going to stop. Lost track of time, but hopefully we're in good shape.
We're great, Hilton. That was plenty of time left.
Okay, so maybe I overshot my mark here. Well, look, happy to take any questions. If I were to say anything else about this this project, exciting project, takes great people to be successful in translating from an idea to the marketplace. When I showed up to this project about 5 years ago, two of the three founders had gone back to Stanford. They had a licensing business that didn't work so well. It was just not timed well for the market. And they had $20,000 left in the bank. It looked like a bit of a dumpster fire, to be quite honest with you. Lights being shut down and the whole nine. But we had a good conversation. I had a good conversation with Alexander Ye, the lone remaining founder. We pivoted, changed the business plan, and really have been pursuing this sacral nerve stimulation application ever since. And we've been able to generate some excitement there at a time early on when people were wondering why would we select this particular marketplace. Since then, we've seen Axonics, which is now launched with a rechargeable version of this technology. I think I have a hidden slide that I can go to on that. And so this is Axonics to the right here, InterStim to the right. Now they've got their micro device. But the Axonics product is, I mean, that company is now a $2.1 billion market cap, publicly traded company. After entering the market, they've been in the market for less than a year. And they did their IPO with 6 months data before they even had an FDA approval. So I think their experience really helped to justify why it would be useful to go into this marketplace. There's just a ton of people sitting on a bench that aren't having a great experience and are not willing to do the traditional canon lead. So our idea is to address that market. We'll start out there, and then there are a number of other indications where there are similarly patients that don't want to do the can and lead approach, but that would come off the bench for us.
Okay, so thank you, Milton. That was a lot of very cool stuff, and I'm actually super excited to see how this device has developed, at least in the last 5 years. From first reading about it in the literature to seeing kind of what you guys are doing now. There's a question first from Matthews Henning, who's asking, not knowing much about translation, he's sort of interested in knowing more about what steps are involved in moving to human clinical trials. And also kind of a follow-up with that, if there's animal work being done in the company, or is that all being driven from sort of the academic partners that you have?
Yeah, great question. Sorry for not diving in on that. So a couple things here. When I showed up, the technology was already in the literature, a re-optimization of one of Maxwell's equations. It's rooted in mathematics, which is great. So for a person like me who's been in the medical device space in one way, shape, or form for 28 years, most of that with larger companies, when I looked at this particular opportunity, I wanted to make sure that the basis for the technology was solid, that the foundation would be solid, and it was. And so then after that, it's just a function of, well, where can we really differentiate ourselves? We quickly found that OAB would be ripe for disruption. We could differentiate ourselves there. The first thing, though, the next thing we did was we had another round of friends and family come in with some seed funding. We hired a person and we went to work in the animal setting and the preclinical setting. We did sheep. We implanted them first on a table doing acute studies. We moved to chronic animal studies. We have animals out to close to 3 years probably now with multiple implants in, still functioning and they're healthy. We built a business plan and a business model around sacral nerve stimulation. We filed intellectual property, continued to build on that, and we took it to early investors that we knew from an institutional perspective. They were institutional investors, but we knew that they would invest early on in what is now called bioelectronic medicines. We took that round of financing. We used that to develop a prototype that was human grade that we can do an acute human study in, which is the first in human acute trial that you see here. We continued to do animal studies. I think at that point in time, we went into chronic animal studies for Series A. And it culminated with 5 patients being studied acutely, and we refined our implant procedure, our protocol. We launched I shouldn't say protocol, but our prototype device. We launched an ASIC project as well, which we knew would be a long pole in the tent, timeline-wise. The prototype was made of all discrete components. So we have the ASIC done. You know, we really had to structure the program so that the long poles in the tent could get done early. And if you look at the risk profile of our program, we upload it, we have all the risk up front in the translation from that journal article that's in press to an ASIC in a human grade ready for a chronic clinical trial device. So all of that was where the risk lived because of the cherry picking of the indication that we went after. So I think it's very important to figure out where you're going to go. A well-worn regulatory path is good. I think it's essential to have if you're looking for financing and you're looking to get into the market. To the extent that you're going to someplace totally novel, it can be a real uphill battle. And you just need to understand that there could be headwinds there because everything's new. And
which I think, I think Dr. Oxley will talk more about that a little later. But we have one other follow-up question. Sorry to interrupt you, Milton.
No, you're good.
Take up time. So another question from Alex Burton is asking if the devices that you are developing have a security mechanism to prevent unwanted stimulation from external wireless power transfer systems, for example, wireless phone chargers or far field, car garage. I'm sure you have some protection for it, but maybe explain some of the science of that.
Yeah, we had to commission a third-party expert at cracking devices. There's a lot of literature out there about how people are cracking the code and talking to these implanted devices. So we have an encryption protocol. So you literally have to know the key and the encryption to for the implant to know that it's receiving energy or being spoken to by a wireless transmitter, and in particular the specific wireless transmitter that is allowed to talk to the implant. So not only can do we block out just any other random EMI or EMC, but even for a wireless transmitter that is manufactured by New Spirit, it has to be the wireless transmitter that is assigned to this device and to that patient. So we go to great lengths to do the encryption, and that's required. The FDA wouldn't let us get this far without it.
That's awesome. If there are any other questions for Dr. Morris, please leave them in the question and answer period, and we'll try to get back to them when we have the open panel. Thank you again, Dr. Morris. That was really a very comprehensive set of answers and a very cool technology, and I'm excited to kind of see where that goes. Next, we have Dr. Tom Oxley. Dr. Oxley is the Chief Executive Officer of Synchron, which makes the Stentro device, which recently had, by recently I mean yesterday, had a paper released on first in human trials, which is very exciting technology. He's also a neurointerventionist at the Mount Sinai Hospital in New York City, who also established the Vascular Bionics Laboratory at the University of Melbourne, and is currently the co-head of this lab as well. He wears lots of hats and is very excited to kind of hear what comes from this. Thanks a lot, Tom.
Thanks, Dev. So good evening, everyone, or good afternoon. I'm in New York, so it's evening here. I'm going to, my talk's a little bit more clinical. So I'm going to be speaking today about some results that we've just released literally this morning, actually. And I guess it's the culmination of years of work moving through the preclinical, benchtop preclinical, and now into the clinical stage to a first-in-man study in a technology that's seeking to create a new market in the space of neuroprosthesis or neuromodulation for an implantable device that can generate a treatment effect in the field of paralysis, which for a long time has been held up as a potential new area of growth for clinical medicine, but has not quite gotten there for various reasons. And I think we're coming through with technology that has really emerged on the back of lots of work that's been done up to this point. But what we've tried to do is take some critical steps that solve a clinical translation issue. And so I'm going to take you through a couple of these features. So to speak about paralysis, we've spent a lot of time thinking about who the target population is. The patients that we have approval for in Australia and have been discussing with the FDA to this point have primarily been for ALS, stroke, and spinal cord injury and muscular dystrophy. But we think there is a broader category of patients across multiple different conditions that result in paralysis. And by paralysis, I mean an inability to effectively use your limbs, arms and legs. Another term for that would be motor impairment. And so there are various causes of motor impairment, from stroke trauma to neurodegenerative, to demyelination, to tumor, and to neuromuscular. And we've really identified that as we've gone through talking with the FDA and the protocol that we're about to submit for our first IDE submission to the FDA, that our patients have to hit three particular features. One is that their limbs don't work, and there are different ways to assess that, but the capacity to utilize arms and legs has to be severely disabled. Second is that there has to be a level of functional impairment or disability that is associated with that limb failure. And so there are various scales that we use to assess that, but we're looking at particular types of scales that measure one's ability to perform activities of daily living. And particularly, I think for the brain-computer interface space, the instrumental activities of daily living. And then finally, they have to demonstrate that their motor cortex is still functioning. And so we're not proposing that we can treat people who have impaired motor cortical function due to cortical stroke. So we're talking more about subcortical stroke. And the way we do that is by conducting a functional MRI scan and have the patients go through a very similar process of motor cortical activation, attempted movements in the fMRI scanner. If those three categories are met, then we believe our technology will be potentially beneficial for restoring some degree of independence. So I won't talk about market, I'm just going to talk about the technology. So in terms of the system overview, this is an endovascular or interventional procedure. We come into the jugular vein in the neck. We use catheter delivery to get into the superior sagittal sinus, which is the largest draining vein that runs down the middle of the brain. It splits the left and right hemispheres and therefore gives access to both left and right motor cortex. We've spent years in animal models, particularly sheep, examining how the device is incorporated into the blood vessel wall. We do have decades of experience from cardiac stents and neuro stents on what that process is like, but what we showed in our 2016 Nature Biotechnology paper was that the process of endothelialization is not only important from a safety point of view to reduce blood clot formation, but also for signal recording sensitivity. And that's because the ability to record local field potentials or electrocorticography is significantly impaired by the incorporation of the sensors into the tissue, into the interstitial tissue. And you can imagine if the sensor is dangling in the blood inside the blood vessel, it's less likely to be able to capture local changes in field potentials. We've built what we're calling wireless is a antenna, which is a box which has a passive induction coil and a signal transmission unit under the skin, which then interacts with what we're calling an external telemetry unit, which is attached over the skin. So there's no battery in the system. The system only works when the external coil is placed over the skin. We're building a little magnetic coupling mechanism, so it just clips onto the skin. It can be taken off on and off whenever the patient wants to use the system. As soon as it plugs on, it activates the system that it's connected to. So we have a signal control unit that's connected to a personal computer. We've been working primarily with Windows 10, and we have been building, basically converting different types of classifying different attempted types of movements from the motor cortex from left and right hemispheres, and then configuring that into a software that delivers multiple command functions to the patients. Both of our first two patients had eye function, so we utilized that to give them excellent cursor control with an eye tracker, and then built functionality, including multi-click, left-click, zoom control, which even with those few outputs has given them excellent, easy to use and natural control over a Windows 10 operating system. Our first two patients had ALS, or motor neuron disease. It's upper limb predominant. And so there's primarily weakness in the upper limbs. There was some preserved power in the lower limbs. We'll probably move towards a more severe population as we move forward into the US trial. Our patients critically have been dependent on their families or partners for all activities of daily living, not able to use the telephone, the computer to do finances. And we have a whole range of exclusion criteria to make sure there were no pre-existing blood vessel coagulopathy or bleeding or blood clot formation type medical problems that would contribute to the side effects that we're concerned about. So the device, I guess it looks a bit like a deep brain stimulator lead, except that it's got a self-expanding stent on the end, and a 16-channel system with a cable that connects those 16 leads into a unit that plugs into the internal telemetry unit that's hermetically encapsulated with the chip inside a ceramic tile, and which generates the signal transduction through the skin. We had to overcome some really major manufacturing challenges to build sensors onto a stent. And that's because the stent is a certain type of metal and the sensors are another type of metal. So we had to build a insulating layer onto a metal stent. So we had basically a construction or fabrication challenge that had not previously been solved. And we're pretty excited by the solution that we've got. We think it's quite scalable. 2 kilohertz sampling rate, wireless data transmission, and about 4 millimeter spacing of our sensors on the device. So the procedure, to make sure we know where we're going, we conduct that MRI first. We load the MRI data into the angiography suite. It's not a traditional operating room. Think of where you go to put a stent in your heart or a cardiac pacemaker. It's like that, but for the brain. So it's kind of a semi-operating room. Stab into the jugular vein, catheter up into the brain, device pops out, sits in the right spot. We put the device in the chest, close up. The procedure takes 1 to 2 hours. Ultimately, we think this will be an outpatient procedure. The data we've just published is for 12 months of data with the first patient, 3 months of data with the second patient. So here's what it looks like. This was the first spin of the brain. This is the venous system. So we inject a dye. The dye gathers in the venous system and it drains downwards from the brain into down the neck. And you can see this white lead that's left in this vein in the brain. When I first saw this, it was a pretty amazing moment for us. There's never been a device built before that had ever left a lead inside a vein in the brain. This is what happened in the cardiac pacemaker field about 30 years ago. Initially we were told that it's going to be extremely dangerous to leave a lead in that big vein in the brain. You can't do that. That's what they said about cardiac pacemakers back in the 70s. We've built it so that it's completely biocompatible, and so far so good, but we recognize there are risks. But the cardiac pacemaker literature really gives us a great roadmap on how to manage these risks. And probably the most important thing is that patients get aspirin and clopidogrel as blood thinning medications to stop. But in our animal data that we also just published, 95% of this device is incorporated into the wall within 45 days. So it's that first 45 days that's the most critical period, so that patients can't miss a day of their meds. Okay, ABC is patient 1 from baseline. You can see the dye is in the blood vessels in the brain. So the white stuff is the dye, and different ways you can see there's the brain, top view, coronal view, blood vessel there in the superior sagittal sinus, brain is here on the right, brain is here on the left. Then after 3 months, there's the device inside. You still see the dye flowing, so there's no blood clots. If there was a blood clot, there'd be loss of the dye here. And then after 12 months again, it looks like the device has moved back a bit, but if you actually track it compared to these blood vessels, you see that it hasn't moved a millimeter and there's no blood clot formation. Over on the right, we have just co-registered the active area of motor cortex from the functional MRI scan before the surgery. So that's the red and the yellow against the sensor placement in the green, proving that we were able to land the sensors immediately over the region of motor cortex that we were targeting. Just mentioning here was the animal data. This is a cross section of the device. This is after 3 days. You can see we've cut the stent here. So there's all the different areas of the stent, and this bit here is a sensor. See how they're separated, and see how they're sitting on the inside of the blood vessel. So they're exposed to the blood at this point. At day 45, you can see that the tissue has grown over the sensors. That's a sensor there. That's a stent struts. And the tissue is completely incorporated over the device, reduces thrombosis and improves signal quality. So then we take to basically what we're calling motor mapping. We run through a range of we've got about 20 different proprietary particular types of attempted movements that we get the patients to conduct. They're pretty basic, like move your ankle, move your hand, and some other more complicated things. We looked at which ones provided the most robust classification, and then we used those to drive signal command functions that could then drive the operating system. And primarily we were focused initially on just clicks. So we looked at click accuracy. That was the likelihood that the patient was to be able to deliver a successful click when they attempted to deliver a click. And then we mapped that onto typing in combination with the eye tracking. And then we took a step beyond that, and we combined that with zoom function. And then the combination of those factors gave the patients very comfortable, easy, long-term use of the system, which you typically can't do with eye tracking if you're using eye tracking to try to click, because it's quite draining, because there are particular ways to click. In our system, it's very relaxed for the patient. They're in control of the click. We give them multiple different click outputs, and they're able to use the system for hours on end, and they've continued to use the system out to the period of time. So I'm probably running out of time, but I'll just show a couple of things. So you can see here, he's using the zoom function there. He clicks, he opens up WhatsApp, and he's going to start sending a message to his partner. So before this, he was not able to use the phone at all. He was not contacting his partner, and she couldn't really leave his side. at all. And so we've given him accessibility and use of the system that he can do completely on his own. He was quite slow, I would say, compared to the second patient. He was getting, I think it was 12 correct characters per minute with what's it called? Predictive text turned off. He's much quicker with predictive text turned on, but our second patient was able to achieve a much faster rate. And so part of that's got to do with the training. We've actually changed the algorithm slightly for classification. It's been an interesting challenge to have an algorithm that's changing as the trial goes, and that's going to be an ongoing feature of our feasibility study. And I just quickly translate these signals. So I'm just going to jump through this just to show the different speed with the second patient here. I think here, so here's Philip now. Let's get rid of that noise. I want to hear my voice. So he's clicking at a much faster rate. And in fact, they show that the footage that ABC ran this morning was even more impressive than that. So, you know, the rates compared to BrainGate rates, they're still not the fastest we've seen. But what's much more important here is that what we've achieved is a fully implantable system, no craniotomy, plug and play, no engineer in the home, a software that's completely self-generated, and a safety profile that's looking favorable. So, you know, we've been really focused on a clinical translation pathway that brings this technology to patients in a way that's going to be useful. And, you know, there's been a lot of attention from, let's say, richer and more famous entrepreneurs in this space talking about data rates and channel counts that I think moves away from the focus, which should be on delivering a system that actually can impact patient lives. And I sometimes wonder that we have set the bar a little bit high with engineering compared to what patients actually need to have a big impact. And the FDA's made this clear because they've actually put a call out for these technologies because there's such a huge need in this patient population. So we're really focused on delivering a clinically relevant, translatable outcome that's measurable, which is going to satisfy Medicare from our reimbursement strategy, and which satisfies FDA from a safety strategy. So with that in mind, we're up to this point, from a commercial point of view, up to this point, we've raised 25 million. We're opening a Series B now to raise another 20. And the goal is to launch our first pivotal study and try to become the first to market company in the implantable BCI space to treat paralysis. And I guess beyond that, we have a plan to turn this into a stimulation device. I don't think I've got it there, but we have some patents. We have many patents around applications of endovascular closed loop neuromodulation, which we're excited about. And about a quarter of our raise will go towards conducting a feasibility study over the next couple of years in that first neuromodulation population. But we'd like to position ourselves as the market leader neurovascular bioelectronics technology. And with that, I'll stop talking and happy to take any questions. Thanks for having us.
Tom, thank you very much for focusing on the sort of the patient need aspect of that. I think that's a really important point that you made without having to name any names in the field. But I think that's a very cool idea. And I have tons of questions about stimulation and encapsulation, but I'll leave it for the audience first. So the first question that we're getting is if you could comment briefly on the types of algorithms that are being used for decoding, and maybe a little bit about how the signal might be changing as encapsulation is occurring.
So I'll answer the second question first. The signal change, we looked at this, we published this back in 2016 in our Nature Biotechnology paper. We looked at a couple of different things. We looked at somatosensory evoked potentials. We basically showed that ability to detect morphology would change, and the amplitude was changing over time. And we were looking at the ability of us to, we were grouping evoked potentials and showing that over time, our ability to record evoked potentials improved substantially. And then we mapped that to complex impedance spectroscopy and showed that there was a shift in impedance that was occurring at the same time. So there's probably still a bit more to be teased out, but it was enough for us to not do what some people had wanted us to do, which was do an explant study in humans and put the device in, do some recordings, prove it worked, and then take it out, because we realized that actually the signal recording, it really takes a couple of weeks for it to get really good. That was one thing. In answer to the machine learning side, definitely not my area of expertise. I will say that we started out doing classification with support vector machine. We moved on to I think it was a deep learning network on the second patient, which actually turned out to be more effective. There is quite a lot of info on that in the paper. I'm not going to say anything else in case I sound really stupid. Suffice to say that there's an interesting challenge in the FDA typically want you to lock algorithms and then go and test the algorithm. And we're still in this process of determining what the best algorithm is, because we couldn't do any validation work in animals. And so we're in this interesting phase right now of trying to identify what that best algorithm to use is, but we need to make a decision pretty quickly on what we're going to push through for our clinical trial, because you got to make a decision quickly. You can't, otherwise you're an experimental academic group, beginning to be curious about different things. We need to build a clinical product. So we are going to probably try and keep it pretty simple with the algorithms.
Could you say a little bit more about what the sort of decision points are in making that choice?
Well, the decision points will be how effective the system is, that it's improving the ability of the patient to regain tasks, independent tasks. So until we've got to a point where we've got the balance of how severely impaired the patient is to how much the efficacy impact is, and that they're both measurable and that they're clearly apart from one another. Once we've got that balance right, we'll lock everything and move towards the clinical study. So I think we're moving towards more severely impaired patients, and towards, we're trying to figure out what that number of outputs needed to come up with a really useful product is. And we've, only between 2 and 4 outputs with our first couple of patients has led to really significant outputs. But part of that is making your software really smooth and easy to use for the patients. So it's a combination of all those things.
Cool. In terms of the geometry of the device itself and the types of signals that are being recorded, do you find that particular electrodes are being utilized better? I mean, is there some aspect of like the distance from the tissue that matters if it's on sort of the more dorsal side of the vasculature? Is that better, or can you comment a little bit about that aspect?
I don't know about, interestingly, because we're using a machine learning algorithm, we have not been doing a huge amount of single electrode analyses yet. But what I can say is that what's been really interesting is that the area of the brain that we're closest to with the stentrode is the lower limb representation. So we have been able to do classification for upper limb, but we're pretty focused on lower limb because that's what's closest to the device. And part of the issue there has been improving the signal to noise with the system as well. So we have had to make some changes because we're right over the chest, which has meant that there's quite a lot of cardiac noise. And so, we're learning a lot as we go. There's hardware changes to make, there are software changes to make, and there are neuroscience related things to consider as we're developing the system to bring it into the pivotal study.
Awesome. Okay, to the audience, if there are any other questions, please put them in the chat and we'll try to get to them at the end of the session. Thanks again, Tom. That was very eye-opening in terms of what's coming, how that's developed, and what's to come.
Thanks, Dave.
All right. So next we have Patrick Ganser, who is a principal research scientist at the Battelle Memorial Institute in the NeuroLife program. And he's been working a lot on sort of the bioelectronic medicine that they're developing there, as well as sort of take-home BCI interface system. Take it away, Pat.
All right. Thank you, Dev and Doug, for organizing the panel. Very excited to share some of the recent research and translational neurotech we've been developing either at Battelle or previous institutions. I'll be talking a little bit about things that Tom and Milton introduced, that is brain-computer interfaces in a different form, as well as peripheral nerve stimulation, what we call bioelectronic medicines. We'll be honing in on two things that we've been translating into the clinic that's at different stages of maturity, mainly to help patients with spinal cord injury. The first is an implanted brain-computer interface, and it's one of the first to restore the sense of touch and movement. We'll get into how we do that, how we're maximizing what we're recording from the neural interface to bring new functions to the patient and to have their thoughts drive multiple devices simultaneously for upper limb function. The last thing that we'll talk about is bioelectronic medicine. It's also neuromodulation. I don't know what to call these. Using vagus nerve stimulation that's paired with upper limb movement to boost rehab and to get new connections to form to paralyzed muscles. So as I mentioned, the two embodiments of neurotech that we work on and that I've been focusing on in my career is really to address spinal cord injury and upper limb dysfunction. So although you think of the spinal cord when you hear spinal cord injury, it impacts the brain in major ways. Of course, these are distributed circuits that go along the neuraxis. In the cartoon, you see a depiction of some of the maps in cortex that get at how these representations for motor control or processing touch are wired. This is something to keep in mind when we're talking about these two pieces of tech, such that we can, as Tom was mentioning, figure out how to interface with these through an implantable. Where would we implant? If someone's thinking of movement, where do we aim in the brain? And really to hone in on more of the detail of the two pieces of tech that is now in the clinic, you can go about restoring upper limb function in a number of ways. You have stem cells, grafts, you have different approaches using other pharmacological methods. We'll be first talking about how to bypass the injury completely, again, using a brain-computer interface. And another approach, which is complementary but still unique and different, is to enhance the circuits that remain and enhance plasticity of those circuits that are broken to drive new connections. So we'll start off with number one. So the brain-computer interface that we work on at Patel is organized as follows. Has a lot of similarities with what Tom was mentioning at a high level, where we're aiming to record from the brain. In this case, we're working with a patient that has a C5, C6 spinal cord injury. So they have no control over their hand. You can imagine how devastating it is to just not even use your hand for an hour or a half hour during the day. The neural interface that we have is quite invasive. It's a Utah array, so it's about the size of a pea. And through a craniotomy, it's implanted into motor cortex so that we can listen to what the patient's thinking and also maybe even tell what the patient's touching, which we'll get into in a second. After that, again, Tom has covered some of this. Once you have these electrophysiological patterns, it's a very complex code. So we have 96 channels of spikes and information coming in very fast. How do we decode this? And when a patient thinks of different movement or touches something, how do we decipher what's happening and what they're doing? Just looking at the patterns of neural activity. The last component of the BCI is, okay, I can record, I can decode, who cares? What am I going to do with that information to improve function? So the way that our BCI works is the patient thinks of movement, could be hand open or hand closed or something else. It's decoded rapidly, and then we stimulate the forearm to make the hand movement that's desired happen, again, bypassing the injury. So this is a video of the BCI system in action, just to show you some of the raw data. So the participant will think of a movement that's in the top right of the video that will then be decoded, trigger arm stimulation to make the hand move. And the participant can interact with a whole array of objects Without this system on, the participant cannot perform these activities. He has complete hand paralysis. So he goes from really a zero or a low level of hand function to being able to move most of his hand in different ways for a power grasp or even manipulating small objects. So this was published in Nature in 2016. It's very exciting, but as we all know, there's always room for improvement to further enhance function. So one of the things that we discovered is that when the participant is performing these activities, it's largely with the hand that he can't feel. This is a huge problem. If we think about shoveling snow, we come in, our fingertips are numb, or our hand falls asleep. That's quite devastating to the ability to move. Your hand feels foreign. So these are huge problems. So just to give you an idea, the participant's basically his whole hand is insensate. He has a small part of the digit one, which is his thumb, that he has some abnormal sensation on in panel A that's depicted from monofilament testing. And so there's a line where he really can't feel. So along with paralysis, there's also the insensate capacity on his hand. If you go to how these deficits look when he's grabbing objects and you blindfold the participant and ask him if he's touching something, if it's something very small like a pen or a marker, he is completely unable to tell that he's touching that size object. If you increase the size of the object to like a mug or a small glass, he's still guessing. So he's at 50% capability to tell that he's touching something. So this is a big problem. So we set out to investigate what else might we be recording in the interface that's implanted, and how can we use it to improve sensory and motor function at the same time. So this was recently published in Cell in the spring. The team is below, composed of bioengineers, statisticians, neural engineers, physicians. It's a really multimodal, talented team that has to make these complex projects move. So one of the first results that we looked at, again, to see what is the interface recording, something that might have been there for years, and how can we use it to restore touch activity. The first thing that we did is constructed an active touch decoder. And so when the participant reaches out, touches an object with his paralyzed hand, even though the vast majority of his hand is insensate, there is still neural activity that is driven. We performed neural mapping studies to look at on different digits evoked electrophysiological activity. This also shows up when he's when a blindfold's off, when we're not passively stimulating, but he's actively engaging in object touch. We first built a touch decoder that picks up on this residual leftover activity on the hand that he largely can't feel. And the decoder is generally robust. It performs at mid-80s in accuracy. And in black, it's not tricked if you remove touch events by doing stimulation without an object present in the grasp area, if you're just moving the arm around or just at rest. So the decoding is robust. And of course, that's what you want for anything that's going to activate a device. In panel B, after showing that we can decode residual touch, we then said, so what? How are we going to leverage this to improve function? So the way that it works is active touch that's remaining is sensed by the computer and rapidly fed back artificially on skin that the participant can feel, which is the red band here over his bicep. So he has normal sensation here. This is composed of haptic feedback motors, things that are in cell phones that vibrate. So that's the way that artificial sensory feedback works. And one of the first indications that this actually helps the participant is in panel C. So as you saw, when the participant is interacting with a large object, he's guessing if you blindfold him, which is a big problem. If you turn on this closed loop haptic feedback system that gives him artificial feedback when he's touching something that he can't largely feel, he goes from a little bit below 50% to almost 100% acuity in being able to detect these objects, again, through artificial closed loop feedback. So this was very exciting, a first indication that we can use this activity to improve upper limb function. And I think this is one of the last results I'll show before we shift to the bioelectronic medicine work. So when you're touching something, you're usually moving. And so we next up the ante, if you will, and instantiated something that we call sensory motor demultiplexing. So these signals on this 96 channel chip and these patterns are generally multiplexed or interleaved in time and space. We built two different algorithms that were dedicated to detecting when he's thinking of movement or when residual touch is happening, which would be in the cartoon in red and blue. And when that happens, the system in real time can activate the given device, whether it's stimulating the upper limb to make the hand move or closed loop haptic feedback to give the participant artificial sensory feedback during upper limb tasks. So this is a movie of the cartoon in panel A. I'll just describe the panels real quick. So this is a live color-coded activity panel looking at neural activity across the 96 channels, warmer colors or more spiking activity. This is the participant interacting with a standard object. And in this panel is what the computer's thinking is happening based on brain activity, where red is touch and blue is movement. So the participant is cued here 3 times to touch the object and then think of movement that then triggers stimulation 1 second later. And he just repeats this 3 times. So the computer in red first can indicate that something's being touched. And about a second later, the participant thinks of movement after he's touching the object to grasp it and transfer it. So just to show some of the raw data. And when you use this system, this demultiplexing system in real time, there's a number of improvements. The first of which is in panel C, which is a sense of agency. So without any sensory feedback, limbs or skin can feel foreign. You don't feel in control of your hand. With this sensory motor demultiplexing system active, where you're getting artificial rapid sensory feedback fed back to you, the participant feels more in control of his hand during BCI operation because of this rapid sensory restoration from skin that he hasn't really felt in many years. And in the sensory motor domain in panel D, the BCI system speeds up significantly because he's getting this closed loop sensory feedback again in the gray bars, so that the interdecoder intervals become closer in time. He's rapidly going through his thought sequences faster, and then he can transfer objects more rapidly. So these are some of the improvements that we saw in the Cell paper. They were very exciting, and we're one of the first groups to demonstrate that you can record these things at the same time, separate them out, and transfer these different decodes to different devices to improve function. So the last thing I'll talk about in just a handful of slides is transitioning to bioelectronic medicine. So briefly go over this slide. Instead of targeting neural activity in cortex, we'll be talking about tracking upper limb function and strength. Instead of algorithms, we'll be talking about a clinician dictating when stimulation happens and decoding really or deciphering what is a good movement during rehab. And instead of targeting musculature, we'll be talking about the vagus nerve. So this technology is also in clinical trial, just started recruiting patients for a phase 1 effort. So I'll walk through the preclinical work and really where it's going in the next couple of years. So really briefly, the first speaker covered a lot of what is bioelectronic medicine. You can have a peripheral interface. The vagus is very commonly a target. There are many, many nerves, tibial and sacral. There's a long list here. Bioelectronic medicines can also be mediated through central interface where you're stimulating cerebral targets. Deep brain stimulation is an example. And again, just to breeze through this, they can be open or closed loop, which is pre-programmed or responsive to state. And there's a number of disease states to look at, arthritis, GI, overactive bladder, a long list of problems. So I'll go through the background of how we think VNS works here and end in just a handful of minutes. So the vagus does a lot. This is a depiction of what the interface looks like that's used in some of these studies. It's a helical series of cuff electrodes. This is an outpatient procedure. And although it's connected to a lot of organs, we interface with it, and we're going to be talking about enhancing brain change and boosting rehab. We interface with the vagus to enhance neuroplasticity. So upon stimulation, the vagus nerve projects to the nucleus basalis and locus coeruleus and releases a number of chemicals, including acetylcholine and norepinephrine. So these are two neurotransmitters that are really intimately involved in plasticity or change, where circuits can form, new axons can sprout. And if we think about neural damage and what happens to a circuit, if it's impacted and its functions decreased, can we get the brain to change during rehab more and drive change in those circuits back to the paralyzed muscles that maybe mediates function? So that's the whole gist, is to enhance change faster during rehab. So we call this targeted plasticity therapy. One of the big thrusts and how this work was funded was via Dr. Doug Weber while he was at DARPA. He started a couple of very unique and really game-changing programs. One's called Electrics, which is short for electrical prescriptions, as well as TNT, which stands for targeted neuroplasticity therapy. So again, the depiction of how we think this works: the vagus is stimulated, molecules are released precisely in time, and we're going to be talking about boosting rehab here in the next few minutes, and then open it up for questions. Some of the first work that showed how this can actually help the brain change is depicted in the right three panels. So when you engage a given motor circuit, let's just say it's moving your shoulder, there's of course neural activity transiently that's responsible for this in motor cortex. If you pair that neural activity with vagus nerve stimulation, again, and the release of these neuromodulators, 1, 10, 100, 1,000 times, you can start enhancing plasticity and growing these active circuits, which is shown at the bottom in the green depicted neural tissue. So we first tested this in the TXBDC, which is the Texas Biomedical Device Center, as well as UT Dallas, in models of spinal cord injury. So again, the gist is you damage a circuit, you have a decrease in its function, but can you grow it back to maybe pre-lesion levels and get function back to the upper limb? So we use two different models of spinal cord injury: a unilateral contusion or a midline contusion, both at the cervical level, such that the brain is disconnected from really the hand musculature, leading to massive decreases in strength and upper limb capability. And just to walk through the results and where this is going clinically, one of the interesting things about bioelectronic medicines is that they can potentially be a precise medicine where you can target something in time, and maybe timing really matters for a therapy. An alternative question is, hey, Pat, can I just turn the vagus nerve stimulator on during rehab? Do I really have to be targeted? How targeted do I have to be to these good movements to boost them up? So one of the first results that demonstrated this timing mechanism after injury is at the top right, where you have the decrease in function on the y-axis, which is a correlate of strength after spinal cord injury. This is preclinical work. And the classic interface or intervention after this sort of insult clinically is just rehab. So the patients will go into the clinic, practice what they've lost. You do get an increase in function in blue over time, not up to pre-lesion levels. If you stimulate the vagus and you're very picky, only with the best movements, again, over many weeks, thousands of pairings in red, you get an increase in function over rehab alone, showing that you can boost functionality and increase connections potentially back to the paralyzed muscles. And in black, that group got the same amount of VNS as the red group. However, it was only during paired to the worst movements. So you have an equivalent amount of VNS. In the red, it's the best movements. In black, it's the worst movements. And it's no different than rehab. So it seems you do have to be selective in how you pair VNS during rehab. And looking at the timing of how this works, you can get about a 65% improvement in function compared to rehab if you precisely pair VNS, again, in the preclinical work. If you delay that stimulation by 2 seconds, you get a subtle drop in function. And in black, one of the last groups is delayed by about 20 seconds. You get a full drop in capability, even though it's the same amount of VNS. And so lastly, just the last couple slides, some of the base work that is exciting that's now in pivotal trial was done for stroke. So this works in rodents as well as humans with a similar effect size such that you can enhance upper limb function. This was at the bottom left is the phase 1 clinical effort showing that you can boost capability after ischemic stroke compared to rehab. The phase 2 work also looks very promising at the bottom right. Again, a little bit more controls, double-blinded, and a crossover design. And the pivotal trial is now going to be published soon. This is very exciting, showing that there's promise preclinically and also in clinical translation for the therapy. And last slide here, this is now spinning off for spinal cord injury. The Texas Biomedical Device Center is developing at-home rehab. So going into the clinic is expensive in terms of time and reimbursability. Can we have these rehab cascades be done at home? And also there's been a lot of device engineering, miniaturizing the IPG by an order of magnitude, having it be wirelessly powered as well as wirelessly triggered. Some of the things that Milton was talking about, leadless. And this is the clinical trial that's starting. All the patients are recruited. So it's a very exciting time for bioelectronic medicine, pick your nerve, and dysfunctional state, as well as BCI. So lots of people to thank on the NeuroLife team, the statisticians that help with the decoding, the clinical teammates at OSU and at UT Dallas, the funding from DARPA, Wings for Life, the Crew Foundation has all made this possible. So stay tuned, and a very exciting space to be in. Thank you for your attention.
Thanks, Patrick. That was a lot of really good results. That was pretty cool to see kind of where this is developing. So we don't have that much time for questions, because I wanted to let Patrick finish kind of all of that stuff. If anyone has any, please leave them in chat quickly. Doesn't look like there are any right now. So I'll just ask one briefly, Patrick. What do you think is the sort of pipeline for the commercialization of the BCI aspect, right? Because you guys are using the Utah array right now, which isn't really set up to be fully commercial as of yet. And then the other sort of FES and the sensory systems are also very more kind of researchy than consumer device at this point. So do you guys have a pipeline for that, or how to kind of spin that out?
Right. So the business case for implantable BCI is not great.
Right.
And Tom can talk about that. I think that the work that he's doing on his team is fantastic to really get at something that doesn't involve a craniotomy, might last much longer. However, implantable Utah arrays are showing some promise over longer periods of time for cursor control. Some of the BrainGate participants are now over a decade out via implant and looking at neural decodes. We're also looking at, in terms of stimulating the upper limb for hand function, decoding residual EMG instead of motor intention in cortex. And again, you might be aware of this work, where your motor intention is not, you don't need to have an implant in invasive surgery in order to get at that, hey, I want to open my hand or close my hand. So we're investigating different interfaces that might be less invasive or more invasive, and looking at really the modularity of BCI, where you have algorithms, end effectors, that can be paired with different approaches to, again, meet these patient needs and decrease risk. So that's kind of our current strategy right now, is to be flexible and leverage the modularity of the interface overall.
That's awesome, man. I hope that eventually we'll be able to kind of merge what you guys are doing and some of the work that Tom and Milton are working on as well, to combine so these holistic, full range closed loop BCIs. That'd be super cool. All right, so with that, we'll move on to our last, but definitely not least speaker. Dr. Ricky Muller is an assistant professor of electrical engineering and computer science at the University of California in Berkeley. She's also the co-director of the Berkeley Wireless Research Center, a core member of their Center for Neuroengineering Prostheses, an investigator of the Trans-Zuckerberg BioHub, and on top of all of that, she's also the co-founder of Cortera Neuro-technologies, which is a medical device that is commercializing a neuroimplant device, which I think is related to the work that she'll be talking about today. So very excited to kind of see where all of your stuff is, Dr. Muller. So please take it away.
Thank you so much for the introduction, and thanks for inviting me here today. I've really enjoyed listening to the other talks. I realize we're all really talking about wireless, minimally invasive neurotherapeutic implants, so my title doesn't really say much about what I'm going to be talking about that's different. So at the core, who am I and what do I do? I'm an ASIC designer. I work on wireless devices, wireless systems. I work on making them extremely tiny and minimally invasive and safe. And I've also been working a lot on giving devices closed loop capabilities, which is really what I'm going to be talking about now. So DBS, or deep brain stimulation, really doesn't need very much introduction, especially after all the talks we just heard and to this audience. It's a very powerful tool that acts a lot like a pacemaker for the brain. And it starts with an implantable pulse generator in the chest and long leads that are implanted in deep structures in the brain. It's used very widely to treat Parkinson's disease and other movement disorders, such as essential tremor, dystonia, as well as epilepsy and a number of other emerging clinical indications. I'll let Andrew show you how a deep brain stimulator works. Andrew's 39 years old. He has Parkinson's disease, and he's implanted with a deep brain stimulator. And here he has his device turned off. You see his symptoms of classical symptoms of bradykinesia. He has difficulty initiating movements, difficulty speaking, rigidity, explains if he tries to stand up, he'll fall. And we see this very classic tremor that is commonly associated with Parkinson's disease. And when he turns the device on, he really regains his motor function to an incredible degree. He's able to speak. If you could hear him, you really wouldn't know that he had such advanced Parkinson's disease. He's demonstrating all of the tests that they give him at the doctor's office, that he has motor dexterity. It's incredible. So clearly this technology is affecting many, in fact, there are about 200,000 people walking around with deep brain stimulators today. So the best devices today, or I should say, when I made this slide, the best devices were about 4 to 8 channels of stimulation and recording. And actually earlier this year, Medtronic released a device that has 16 channels of stimulation and 6 channels of recording. So that's a fantastic improvement. And it requires a large amount of programming by the doctor. So the patient goes into the surgery, they have a period of recovery, they come back into the doctor's office, and their stimulation parameters are programmed. They perform these tests, these motor tasks. The doctor sort of sets what they think is best. The patient goes home. They come back a couple of months later. They repeat this process. They go home. They come back a couple of months later. It's refined even further. And actually, some patients are so difficult to program that it can take a period of perhaps even a year or two to get these therapeutic stimulation parameters titrated just right. And being able to send and record neural activity while this stimulation is going on could actually enable us to automate finding the best therapeutic parameters for a patient, so that this kind of titration could happen much faster, result in faster, better outcomes, and even improve accessibility by not requiring the patients to constantly be coming back into the doctor's office, in very few hospitals actually that perform this type of surgery. Importantly, the important part of this is really to be able to sense the neurological activity, see what's going on underneath, and to learn specific signatures or the biomarkers of disease or even biomarkers of unwanted side effects. So here's an example from my collaborators in the lab of Dr. Phil Starr at UCSF. And this is a patient who has advanced Parkinson's disease. He is implanted with a deep brain stimulator, and Dr. Starr and his team, they actually discovered that there was a specific spectral signature when the patient went into a state of dystonia, which means that the patient actually has too much motor activity going on. It's hyperexcitable. And in that kind of state, you would actually really want to back off on the therapy to allow the patient not to have all this hyperexcitability really kind of take over their motor function. And so closing the loop in this would really be able to provide therapy in a very patient-specific manner, and also only at the time when these symptoms are present. So I co-founded a company called Cortera Neuro-technologies, and we were founded in 2013. So actually before the Brain Initiative was even announced. And we started by, we had a lot of interesting IP in really miniaturizing recording devices, making them extremely minimally invasive and wireless. A lot of the things we still really care about today. But when the Brain Initiative came out, we partnered up with UC Berkeley, UCSF Medicine, and the Lawrence Livermore National Lab to tackle this idea of closing the loop in deep brain stimulation. And we were interested in Parkinson's disease, but we were interested in a lot beyond Parkinson's disease. We wanted to develop a device that could address the conditions that manifest at the systems level in the brain. So major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder. We had to think about how we were going to do large-scale recording in the brain in multiple brain regions on both hemispheres, how we were going to aggregate all of that data, and then also be able to provide targeted therapeutic stimulation exactly at the time and place when it's needed in order to treat these conditions. Obviously, this was an incredibly lofty goal. So we started by building these modules that basically were electrode arrays that then started with our basis of recording technology. And to that recording, we added the ability to provide targeted therapeutic stimulation on every single channel in each of these modules. And then each of these modules was able to communicate with this central hub. So it took all the data, sent it to the hub aggregated all the data, it performed computations, it did all this closed loop classification, and then was able to send back commands that also took care of power and wireless communication. So there was really a lot going on, an enormous set of challenges. And we were really focused on how to make this scalable and minimally invasive and have really seamless communication for all these parts. And in order to enable that, we really focused on having a single chip solution that sat at the head of each of these electrode arrays and kind of took care of all of that communication. Now, one issue we discovered very early on was the interaction between sensing and stimulation. This is actually data from a Parkinson's patient at UCSF. And as soon as we turn on stimulation and you try to record in that region of the brain, all you really see is this very, very large stimulation artifact. And that's because the stimulation pulses are very, very large, and we're trying to record extremely tiny neural signals underneath. And so when they're masked by this large artifact, you see them through, you see that in the time domain, you really can't resolve any neural signals, and you see all these artifacts are also spread throughout the frequency domain. So even aggressive filtering kind of doesn't help you too much. So we took a step back to see what we could do about this problem so that we could actually enable closed loop stimulation and record at the time that we are stimulating, at the same time that we're stimulating. And we're electrical engineers. We just kind of looked at this from the perspective of, well, we are just shoving currents through electrodes. And it turns out that for safety reasons, the stimulation pulses, first of all, they're fairly short, but also we take a lot of care to make sure that we clear away all the charge, that everything is nicely charge bound, so we don't leave residual charge on the electrodes that can corrode the electrodes and cause tissue damage around the implant as well. So given that we're clearing all that charge away and these pulses are short, there's, sure, they're causing voltage deviations, but there's no reason we can't just go back to recording as soon as they're over. And we decided to take a hardware-based approach to making these two, to making stimulation and recording extremely compatible with each other. That's exactly what we did. This kind of gets you to the punchline, is that, before we had these really, really large persistent artifacts, and now what we have is really just kind of one sample of artifact while we're actually stimulating, and the rest of the time we could record the underlying neural signal. And we took care of this all within the design of the chips that we did and the hardware. And I won't get into the details here, but essentially every chip did 64 channels of simultaneous recording and stimulation. We had integrated power and data and so on. And here's the final device that actually is sitting inside a hermetically sealed, this is a ceramic package for hermetic sealing to implant in humans or for human use. And it's about the size of a multivitamin in this iteration. But of course, before we could implant these in humans, we needed to implant them and do animal studies. And so we partnered up with the lab of Jose Carmena at UC Berkeley in order to try out this technology in non-human primates. So we built a device. It's got this kind of funny shape because it was designed to be exactly pitch matched to the electrodes that were already implanted in the primates in the Carmena lab. And we put 2 of our chips on the device for a total of 128 channels. And then we put an SoC FPGA. So we have essentially a reprogrammable component that is running all this data aggregation and closed loop algorithms, and it's running them directly on board. So we're not actually interpreting the signals offline on a computer. The device is doing it entirely autonomously in situ. And then we have power and data and everything going on. And just to kind of go through this quickly, because I don't know how we're doing on time. But we implanted it in the primates. We took overnight recordings to kind of make sure we could record everything. We compared it to a very standard neurophysiology unit that's commonly used in primate neuroscience labs. We got excellent fidelity of the neural signals, and then we wanted to show that we could record and stimulate at the same time. And so here we have, what you're observing here is in real time. We don't have stimulation. We trigger through the wireless link that our stimulation comes on. Then you see that one sample perturbation from the stimulation. We what we do on the board is we actually are able to take out that one sample. So with very, very simple techniques to do that and recover the entire underlying neural signal. And then when we turn it off, we really don't see any difference. Obviously, eyeballing it isn't always good enough. So we went through and quantified the difference between when we weren't stimulating at all and when we had canceled the stimulation, and we get extremely good agreement between the two neural signals. And so now we're able to record continuously while we're stimulating and close the loop in that manner. And so we used trained primates who were trained on a center out task, and they have a cursor that they hold at the center. They get a go cue and a particular peripheral target appears. They move the cursor to that peripheral target and they hold it there. They get a juice reward. We have them repeat this hundreds of times, and we extract the neural features of motor planning, motor execution, and recovery. And from that, we build our closed loop decoders in order to, what we're sensing here in this experiment is we want to sense when the primate is actually planning, or so when they're in motor planning, when they're planning to move to the peripheral target. And then we provide stimulation at that time in order to disrupt the movement. And through that, we're actually able to bias the reaction time to be significantly slower compared to when we do sham stimulation. And this was the first time this kind of result was really shown autonomously in closed loop. We then miniaturized our device considerably, took it down to about 1 inch by 1 inch. And this is kind of a little bit where our story ends, because actually the technology was acquired in July 2019. So now this technology is being taken on and incorporated in a closed loop deep brain stimulator. Okay, and I'll go ahead and, end here. Do I have, how am I doing on time, Deb?
So we're at the question period now. If you need more time, you can go ahead and take it if you'd like.
Let me just, quickly show a couple of slides. I think that I wanted to show this mostly from the standpoint of what we've been working on more recently, and I think because it goes with a lot of the other talks that we've seen earlier, is that we actually have also been working on extreme miniaturization of peripheral nerve interfaces, and also from the standpoint of closing the loop in peripheral nerves. And in this, we've been using, instead of electromagnetic fields, RF or midfield, we've actually been looking at using ultrasound as the wireless link. This was something that was proposed by a colleague of mine, Michel Maharbez, where he showed that you can miniaturize deep tissue implants and use ultrasound in order to power them up and communicate with them. He and Jose Carmena as well built a very, very beautiful demonstration of this, where they used just a single transistor to do some peripheral nerve recording and prove that this link actually works. At the time that this came out, I actually joined the UC Berkeley faculty in 2016, and we got together to see, okay, what can we do in terms of really shaping this into a complete, safe wireless device where we can do entire peripheral nerve stimulation with high accuracy, with high efficiency, with precise charge control. And we built this device called StimDust, and we got it down to 1.7 millimeters cubed. Of course, this is without the hermetic package, but really kind of the smallest of its kind deep tissue peripheral nerve stimulator. Here it is. We ran rodent studies. I won't go through them in too much detail, but then we also built some high performance recorders recently, and we're really working on kind of closing the loop and using networks of these really, really tiny, minimally invasive implants that we can implant through catheters or laparoscopic procedures, or even injection. Okay, and that's where I'll end. So thank you so much, and I'm happy to answer really any questions that you have.
Awesome, thank you so much, Ricky. It's really cool to see kind of how it developed, and then moving on after acquisition to kind of a new technology. So we have one question from the audience so far. From Alex Burton, the question is, how reliable are these biphasic pulses to maintain a zero balance of the charge transfer between the electrodes? And is there some method to electrically couple the electrodes to make sure there is that charge balance?
Yeah, there are. It's a great question. There are many methods. The classical method is actually to use AC coupling capacitors, and for a long time the FDA was requiring that there is an AC kind of blocking capacitor to make sure that the stimulation is entirely balanced. There are other circuit level techniques that can be used to get rid of needing these large off-chip capacitors. And what's very commonly used is first biphasic stimulation. We take a lot of care in the design to make sure that the up and down phase is very well matched. Of course, there's still going to be a little bit of residual charge error. The electrodes are actually shorted at that point in order to clear away the charge. And so we consider the entire stimulation pulse end to end to include that little shorting phase to make sure that we've trickled away all of the residual charge.
It looks like we don't have any other specific questions. If you don't mind, Dr. Miller, we'll move to kind of the panel discussion and open up to everyone. So if all the panelists could turn your cameras back on, maybe we can start some of those discussions. And I'll kind of kick it off. So all of you talked about technologies at different levels of development and commercialization. Could any of you comment on sort of what you think the biggest hurdles are still in the field of getting a device translated all the way through to sort of a commercial or to a final population, as well as what you sort of think of in terms of like the development of the field at all? Are we still kind of nascent, or do you think we've arrived in terms of really hitting widespread medical devices? Anybody can start.
Dev, hit that first part of your question again.
So you all are kind of working at different levels of devices in terms of commercialization and sort of translation. But what would you think are some of the biggest hurdles that you have ahead or that you've overcome so far in this process?
Well, I'll offer just my thoughts on that. You know, I came into this knowing that this was a pure translation project, and I think one of the largest hurdles was to just really find the right financing and then building the right team to bring it forward. But getting that early financing, I mean, we were lucky to have firms like Action Potential Venture Capital that, you know, really has had a pretty good sized focus on bioelectronic medicines through their, I guess, base company, GlaxoSmithKline. But without those guys, it'd be very difficult to get a project like this financed, which makes it difficult to move it along. I think it was also telling that from a fundraising perspective, if you didn't have things in place like reimbursement for your therapy or some sort of a known regulatory or low risk regulatory pathway, that you'd also find it difficult to get funding. So people wanted 3-year programs that maybe were 5-10K regulatory processes versus things that look like a longer 7-year or more kind of a timeline. So funding, I think, is a big hurdle, and it was very difficult to get that up front, but we found the right people who were really interested in what we were doing to help move it along.
Do you think that's changing at all with sort of more visibility of implantable technologies and bioelectronics and sort of neuroprosthetics? Or do you think the same issues you guys had sort of 5 years ago are still at play now?
My thought is that there's more money out there now, and that there's more visibility, and a lot of that great work you're doing that Doug did with ElectRx, the Brain Initiative as well. You know, it doesn't hurt that we've got Elon Musk pouring in, you know, tons of money into this space as well. So I think there's more money now than there ever has been, and more visibility, which is good.
Does anyone else have any input on that or comments on sort of the hurdles that you see?
I'll chime in here if I can really quickly, and I guess pass it to Ricky. Sorry. from a rehab perspective, there's trade-offs in everything we do with science or choosing design requirements. There's a cost for every action. So as rehab interfaces, and we talked about functional electrical stimulation, things that are not implanted per se. Compliance is a big hurdle. So if you don't want something that is not implanted, that a patient has to choose to wear, it's almost no different than a seatbelt at times, which people still don't wear. So if we talk about a wearable interface, that's a big hurdle. So it's a big trade-off cost if you want things rehab to be done at home. Again, there's compliance there as well. So I think a lot about compliance when we look at-home rehab, at-home therapy that's becoming incorporated into games, or there's a huge variety there, or wearable interfaces that the patient doesn't have to wear. So I think there's a really unique sweet spot that I think Milton and Tom and Ricky are looking at, which is something that doesn't have a lot of surgical risk. And you don't have to choose to operate it, and it has some smarts. So I like that that's being addressed. There's lots of cohorts that are looking at that. And the last thing that I'll add is from an algorithm side, Tom touched on that a little bit. We like to have these fanciful architectures that can close the loop using deep learning. However, keeping the end in mind, the FDA has released guidance on, as Tom mentioned, you have to fix these algorithms. Simpler is usually better. Interpretable AI is a big thing. We haven't really touched on that, but that's another trade-off cost of performance and speed, but you have to have it be eventually trusted by the user. So those are a couple hurdles and things that I think we think about all the time when we're looking at neurotech that's smart, closed loop, maybe wearable, take home. So lots of trade-off costs always when you're trying to come up with the next iteration. So.
Yeah, I almost don't know where to start because there's so many challenges all the way from taking something out of academia and into a company to then having it be widely adopted on the other end. Starting from in terms of when to translate technology out of academia, this is a major challenge, and especially kind of going back to at what point you can really raise money on a project like this. I think that there are points of value inflection where first, you build a device and then you trial it in animals, and then you have to get it across a huge gap before you can trial it in humans. And that's where the big inflection point happens, by the way, is to actually trial the technologies in humans, like Tom and Milton are doing. It takes an enormous amount of capital, enormous amount of time, enormous amount of risk just to get there. And that's something that a lot of technology companies don't have to take on. There are so many hurdles from the standpoint of adoption on the other side, because if you look at great companies like Medtronic, they have their pipelines and they have their methods, and doing something that dramatically changes or deviates from the status quo of what doctors are already trained to do, what doctors trust, it actually, you could have an incredible, amazing technology and then have an enormous roadblock in actually getting it adopted by any clinician. And so, starting that process, figuring out how to essentially feed the technology into a known pipeline and take advantage of known infrastructure that's there, I think is another major hurdle for companies like these, particularly because the sort of go it alone timeline and price is mammoth.
Yeah, that's a good point. I think also one of the points that Tom and Patrick had mentioned in terms of sort of the iteration, once you have a device that is sort of ready, whether it's algorithmic iteration or sort of software, it's going to be a big challenge. right? And it's one thing that I don't know has been really well answered in the development pipeline of these sort of implantable devices. Unfortunately, I have a lot of questions that I would like to ask, but unfortunately, I think we're going to be kicked at 8:50 on the dot. And so I'd like to take this time to thank all of you for giving up 2 hours of your time to talk about this process. It's really cool to see where the field's going and where it's come from. Hopefully for all the attendees, this was a very beneficial panel. I know for me, it definitely was. And based on the way the Zoom is set up, it almost feels like this panel is directed completely at me, but obviously it's for the field at home. So again, thank you all very much. And I look forward to future sort of in-person conversations about these, hopefully.
Hey, thank you, Dev. Thanks for having us. And thanks to all the panel members for joining. It was very informative and enjoyable.
Yes, thank you so much.
And I think we lost Tom there, but it's really cool to see kind of where everything's going. I appreciate it. All right, well, have a good evening, everyone, and enjoy the conference if you're still going to be part of it.
The doors open. So we'll just wait a couple moments for people to come into the room, and then we will get going. And in the meantime, I will introduce this session. So my name is Megan Peters. I'm one of the co-organizers of NeuroMatch. And today we have actually a shortened session for you. Unfortunately, 2 of our speakers here have canceled. So the second 2 talks, talk 2 and 3 of this session, have been canceled. Those are the talks by Rashid Saluja and Chiara Vega Bellido. Unfortunately, they are not able to make it today, but we have an excellent first talk for you. And so first, we will hear from Huijing Xu from the University of Southern California. And Huijing is going to share with us today a talk titled Chronic Recording from Multiple Hippocampal Subregions in Free-Moving Rats with a Flexible Paraline-Based Multi-Electrodes Array. That's a mouthful. And I will also say, please use the Q&A button at the bottom of your screen to ask questions, and then we will read those out in the Q&A period at the end of the talk. So whenever you are ready, Huijing, take it away.
Yeah. Okay, so hi everyone. My name is Huijing Xu. Today I would like to talk about the chronic recordings from multiple hippocampal subregions with a flexible paraline-based multi-electrode array from free-moving rats. So first, I would like to give a brief background and motivation, talk briefly about the background and motivation behind this project. And then I will talk about how we designed and inserted this flexible paraline MEA. And I will also talk about in vivo recordings obtained with the paraline array from both acute experiment and chronic experiment. So first, the hippocampus is a crucial subcortical structure that is closely related to the formation of new long-term memories and declarative memories. So our ability to remember what happened, when and where did this happen, are highly dependent on the proper function of the hippocampus. So anatomically, the hippocampus is consisted of 3 subregions, 3 major subregions, which is the dentate gyrus, the CA3, and the CA1. So projections from the entorhinal cortex to the dentate gyrus, and then from the dentate gyrus to CA3, from CA3 to the CA1, form a trisynaptic circuit, which is essential for the processing of memory information. So clearly, collect stable long-term recordings from populations of hippocampal neurons from behaving animal is the foundation to understand the mechanism behind memory formation, and is also essential to investigate the function of the hippocampus. So an electrode that a recording electrode that can collect stable neural activities from all 3 subregions of the hippocampus over a long period is needed. And also such device is also a key element for the development of hippocampal prosthesis. However, stable long-term recording is challenging. since once the electrodes implanted, immune response will be activated, and over time it will try to isolate the electrodes from surrounding brain tissues. Parylene, which is a flexible polymer, so several features of the parylene make it a very good candidate to be used as the supporting material for implantable multi-electrode arrays. So first, parylene is very flexible. So compared to other rigid materials such as metal or silicon, it can greatly reduce the stiffness mismatch between the implant and brain tissue. In addition, it has very high biocompatibility. It is one of the materials that within the highest USP classifications. And also, parylene has been widely used as insulation and coating materials for medical devices for a very long period, for a very long time. In addition, the fabrication of parylene is compatible with standard nano fabrication procedures. So this means electrodes with almost arbitrary layout can be fabricated with high accuracy. This feature is especially beneficial for brain structures such as the hippocampus. From the histology, we can see that all hippocampal neurons are packed into those very thin cell body layers and curved into a very complex double C shape. So to recording from multiple cell body layers, electrodes need to be processfully arranged along the recording shank to conform to the curvature of the hippocampus. So to determine the layout of the parylene multi-electrode array, we first took a measurement of the depth difference between the CA1 and CA3 cell body layer from the brain atlas. So from that brain atlas, at different anterior to posterior difference between CA3 and CA1 layer. Besides the brain atlas, we also measured this distance between the CA1 and CA3 region from brain slices collected at different anterior to posterior locations. Again, from those evaluation, we can see that this depth difference varied from location to location. On average, they're around 1.1 to 1.2 millimeter. The CA3 region is about this 1.1 to 1.2 millimeter deeper than the CA1 region. In addition to those measurements, neuroactivity itself, it can actually provide very valuable insight into the anatomical structures of the brain region of interest. Like the hippocampus, when we use the standard 16-channel microwire electrode arrays, when we implant those microwire arrays into the hippocampus, we can monitor the signal. And while the array is within the cortical region, most neuroactivity we see are actually single spikes. Once those microwires advanced into the CA1 region, these complex spikes, which is a group of action potentials fire with a very less than 5 millisecond interspike intervals, start to show up. This kind of firing pattern is the characteristic firing pattern of hippocampal pyramidal cells. As the microwires further advanced into the CA3 region, complex spikes generated from CA3 pyramidal cells can be recorded. So by looking at depths where those complex spikes were recorded, we can actually get an estimation about the depth difference between the CA1 and CA3 cell body layers. So combine all the measurement from brain atlas, brain slices, and also the estimation from the neuroactivity, we designed this conformal parylene-based multi-electrode array that target at both the CA1 and CA3 cell body layers. The array consists of 8 parylene shanks with 250 micrometer spacing in between. So in total, the parylene MEA can span about 2 millimeter anterior to posterior range of the dorsal hippocampus. On each shank, individual shank, there are 2 recording groups with 4 recording electrodes within each recording group. The recording electrodes is 30 micrometer in diameter, and the spacing between electrodes is 40 micrometer in between. So with this kind of design, we can make sure each recording group can cover the cell body layer, and also because each recording group is several hundred micrometers thick. So this kind of design can give us an opportunity to compensate variations caused by animal and different implantation locations. On each shank, the location of those 2 recording groups is specially adjusted according to the previous measurement and estimation to make sure those electrodes conform to the curvature of the hippocampus. So to implant this flexible paralleling array, we used a dissolvable pack brace to provide support for the exposed paralleling tip, and also attach this flexible paralleling array to a acrylic backing. So during the insertion, first the exposed tip is inserted into the brain tissue. Before insertion, we remove the dura and the blood vessel to make sure the soft tip can be inserted into the brain tissue. And then once the tip is inserted, a small drop of saline is added to gradually dissolve the pack brace. Once the pack brace is partially dissolved, part of the paralleling array can be exposed, and with the supporting from the remaining pack brace and the acrylic backing, the paralleling array can be further inserted. So after the paralleling array being inserted into the desired depth, saline can be added to wash away the entire pack brace. This way, the flexible paralleling array can be released from the acrylic backing. With such method, this flexible array can be implanted into the hippocampus without using shuttle devices or coating to the paralleling array. Here is a horizontal brain slices collected at depth about 3.8 millimeters. We can see the traces caused by those paralleling shanks. So, during the implantation and immediately after the implantation, neural activity was monitored and also recorded. Here's one example showing the neural activity recorded with the 8-shank paralleling array from one animal. So we can see that all 8 shanks recorded neural activities from the brain region, and within 5 of those out of 8 shanks, we can see that the neural activity actually recorded from both recording groups. If we take a close look on one shank, we can see that complex spikes recorded from both the top and bottom group, which indicates that our electrodes actually recorded from both the CA1 and the CA3 region simultaneously. So besides those acute experiments, we also let the animal recover and recorded neural activity and the animal's behavior while the animal is running freely in an open field. So here is the multiple units recorded from both the CA1 and CA3 region from one animal. So in total, we have implanted 11 animals, and for 8 of them, we collected chronic data over a period ranging from 5 to almost a year. So 91 units were recorded from those 8 animals, with 67 units from the CA3 region and 24 from the CA1 region. And multiple units were recorded from the both regions of 5 animals implanted with chronically implanted with the paralleling array. So we also took a look at the signal quality over time. So we first took a look at the noise level over time. For all 8 animals, we can see that the noise level is stable for at least over the 10 weeks post-implantation. Besides those noise level, we also took a look at the average spike amplitude, or just the spike amplitude. So the spike amplitude varied a little bit. For one animal, we see that the amplitude increased first and then gradually decreased. For other 2 animals, we see the amplitude is decreasing, but for the rest 3 animals, we can see that the amplitude is pretty stable for the over the period of 5 to 12 weeks. So for one particular animal, we actually recorded for neuroactivity can be recorded for over almost a year. So from this plot, we can see that the noise level is pretty stable for the entire period of time. For the amplitude, it changed, but still it's around 100 microvolts. So it's still considered to be good signals with good signal to noise ratios. At day 362 post-implantation, we can still record very high amplitude spikes, and we can also see those clear complex spikes recorded from this animal. Like I mentioned, we also recorded the animal's moving trace while the animal is moving freely in this open field. So those location specified firing property, which is the very famous firing property of hippocampal neurons, those place cells can be recorded from these animals, and we also observe those place fields from both the CA1 and CA3 regions. So after all recordings collected, we also sacrificed the animal and did some immunohistochemical staining to evaluate the immune response to this implantation. So we collected tissue from the animal being implanted for 6 months and stained those 50 micrometer brain slices with GFAP first. So we calculate the activation of astrocyte. The astrocyte at about 75 micrometers away from the implanted site, and by comparing the concentration of astrocyte, we can see that the astrocyte concentration went back to control level at about 75 micrometer away from the implanted site. Similarly, as the GFAP, we also stained with mu-N to see how the neuron react to the implanted MEA. So we can see that although at the implanted site the neuron concentration reduced, but the concentration of neuron went back to control level at about 150 micrometer from the implantation site. So as a summary, we have developed this flexible multiple electrode arrays which conformal to the anatomy of rat hippocampus, and we showed that simultaneously recording from multiple subregions with this multi-electrode array is durable, and we also collect stable long-term recordings from several animals. So such method is not just limited to the hippocampus. With special designs, we can actually have polymer arrays that targeting at both the cortical and subcortical regions. And in addition, we are also try to exploring the ability to add stimulation functions into those devices and to evaluate how this device can deliver current to the surrounding tissue. So together, we are one more step closer to develop devices for the hippocampal prosthesis. So at last, I just want to thank our funding agency, NSF, NIH Brain, and U24, especially this NIH U24 grant that gave us this opportunity to form this polymer implantable electrode foundry. And this foundry actually gave us the opportunity to promote the polymer electrodes to all the neuroscience researchers. So if you're interested in polymer array, you want to design your electrodes, you can always contact us, and all those services is funded by the U24 grant. So that's all for my talk, and I'm willing to take questions.
Fantastic, thank you. And in lieu of applause, because we cannot applaud on Zoom, if you enjoyed the talk, please drop some praise in the chat. So we have a couple minutes for questions here. Unfortunately, the next two speakers in this session did cancel. So we could take a few minutes here for questions if people do have any. So please drop them in the Q&A or drop them in the chat if you have any questions or comments. I'm wondering if we have any questions at all from YouTube as well. Elnaz, do we have questions from YouTube? I also forgot to introduce you, Elnaz, at the beginning of this session. So Elnaz is our our fantastic backend tech support from NeuroMatch as well. So it looks like we don't have any questions specifically, but Huijing, if you'd like us to drop any email address or Twitter handle or similar in the chat, we can do that. And of course, you are always free to follow up with Huijing after, and maybe you'll even get matched with her as the NeuroMatch algorithm will do. So I think we should probably close up for this session and let other people go to the next talks if they are hopping between rooms. But thank you, Huijing, for the very interesting talk. We really appreciate your being here. And we will maybe close this room now and put up a splash screen or similar so that people don't get confused. So thanks again for being here, and we'll see you next time.
Yeah, thank you, Megan.
Okay.
Everyone.
Bye-bye.
Bye.